Good morning, everyone. Distinguished speakers, learned faculties, esteemed delegates, we welcome you all to the third day of our conference, Clinics in Hepato-Biliary Diseases 2024, organized by Gastroenterology Department, Sargangaram Hospital, under the aegis of Delhi Liver Foundation. In the previous 2 days, we had some important state-of-the-art lectures, real-life case discussions, and some interesting debates and discussions. Today, we hope to dive deep into some state-of-the-art lectures covering some interesting topics to have the understanding of the subject even better. So without any further ado, let's start the first session of the day. The first session is From CBD Stones to Cold Polypectomy, Endoscopy's Cutting Edge in 2024. For this, as moderators, I would like to invite on the stage Dr. Rajiv Ranjan Sinha, Sir Jagannath Hospital, Ranchi, Dr. Sanjay Khanna, Synergy Clinics, New Delhi, Dr. Gopinath, Life Care Hospital, Bengaluru, Dr. Kumud Bhattarai, National Academy of Medical Sciences, Kathmandu, Nepal, and Dr. Anurag Govil, Santokba Durlabji Memorial Hospital, Jaipur. And as chairpersons, I would like to invite on the stage Dr. Roshan Kafle, Bir Hospital, Kathmandu, Dr. Prasann Bir Singh, Tribhuvan University Teaching Hospital, Kathmandu, and Dr. Vijan Singh Chandil, Treatwell Diagnostics, Jammu. I would like to invite the speakers on the stage by our respective moderators.
Good morning, everybody. So we'll start off with the first session. And the first lecture is going to be delivered by none other than Dr. G.V. Rao. He doesn't need any introduction. And the topic he'll be talking about is management of CBD stone. When would an endoscopist fail? So we'd like to have the surgeon's perspective on the topic.
At the outset, let me thank Anil for the honor of this podium this morning. The initial title of the talk was, is there any stone that cannot be handled by endoscopy? Subsequently changed to when the endoscopist would fail. So I'll answer both the questions actually. It's a very provocative statement, especially to a surgeon, because the gold standard obviously is surgery, and it can handle all types of stones. Now, be it endoscopy or surgery, the approach and outcomes depend on anatomical axis, whether it's pre, post laparoscopic cholecystectomy, and whether the stones are simple, difficult, or the type of access to the common bile duct. Now, if you take about endoscopy, either we go through the normal anatomy or altered anatomy, like in Bill 2, Roux-en-Y, gastric bypass, or post-liver transplant, and umpteen number of technologies are used, including baskets, balloon dilatation, EHL, ESWL, and laser lithotripsy to clear the bile duct stones. Now, these endoscopic techniques are evolving with encouraging results, and it is very difficult to define difficult CBD stones because it involves different clinical scenarios, and a step-up approach is what is practiced from balloon dilatation to mechanical lithotripsy to intraductal lithotripsy in difficult CBD stones. So in the commonest scenario that we encounter in clinical practice of concomitant cholelithiasis and CBD stones, preoperative ERCP followed by laparoscopic cholecystectomy is the most used practice in clinical practice as in today. The success rates of this are about 80 to 92%, reinterventions in 8 to 20%, and the pancreatitis is seen about 6 to 10% of these patients. This is in high volume centers with expertise and technology access to every possible technology. Now with this background, the endoscopists feel that all stones can be handled by endoscopy, and the endoscopist would never fail clearing a CBD stone. That's the gastroenterologist's perspective. But there are several caveats to this, and there are several insights that we have to look in before we can finally conclude on this. Does that mean surgery does not have any role? Is can equivalent to should? Is evidence biased? Is evidence equivalent to practice and equivalent to compliance? Is the universal agreement for endoscopic interventions, and are dollars equivalent to rupees? Now, there is undisputed rule of ERCP for CBD stones, for primary CBD stones of less than 1 to 2 centimeters, gallstone, pancreatitis, cholangitis, unfit patients, post-operative retained stones, recurrent stones, associated liver cirrhosis, coagulopathy. This is an undisputed rule. Now, come to the guidelines. The ESG guidelines clearly says whenever we have CBD stones, these patients can be taken up either for ERCP followed by lap chole, or simultaneous lap cholecystectomy with CBD exploration. Unfortunately, the same guidelines here, it says that you have to practice a step-up approach wherein you go through the endoscopic approach first, and if it fails, then you subject these patients to surgery. Now, guidelines is evidence biased. I strongly feel it is biased because look at these guidelines. We have 23 authors and from 23 departments, 21 are endoscopy departments, and only 2 are surgical units. And so we need an unbiased evidence to get to this evidence, and it has strong guidelines for developing guidelines. It means whenever we're having guidelines, you should have an equal representation from both the medical and surgical departments to make sure that you have these guidelines, unlike you're getting biased statements like this from the ESGE. And there's a new evidence pyramid that is likely to come because there is wavy, the difference between various patterns is so wavy that the new guidelines or the revisited pyramid is going to something like look like this, wherein the barriers between these all the evidence seems to be wavy. Now, there are several caveats actually. Not all CBD stones can be handled endoscopically. CBD angulation is associated with increased recurrence, and you have an angle less than 145 degrees increased recurrence. So obviously, these stones have to be tackled surgically. Distal CBD diameter and stone size are independent risk factors for stone recurrence. So why do you want to take these patients when you know that there are going to be high incidence of stone recurrence, subject this patient for endoscopy surgery? There is no universal agreement among endoscopists. Balloon dilatation seems to be superior to mechanical lithotripsy with the less adverse events. It seems it is not definitely better. Evidence is not equivalent to compliance. Now, I see every endoscopist doing a short sphincterotomy and balloon dilatation, but evidence says no sphincterotomy and balloon dilatation is better. There is no compliance to what is evidence and what is practiced in clinical practice. And if you see this various types of mechanical lithotripsy, though we have standard lithotripters that have got good clearance rate, they feel that laser-guided lithotripsy considered a better option compared to the conventional mechanical lithotripsy options. And again, there is no universal agreement actually. I strongly believe, because most of the endoscopists also told me that more than 3 minutes is what is required for balloon dilatation. But whenever we hear in the workshop, it is either 1 minute or 3 minutes. But evidence says that you have to dilate it for more than 3 minutes to prevent pancreatitis. I'm surprised. Longer the duration, less pancreatitis. Very controversial statements. Laparoscopic CBD exploration, on the other hand, either it is transcystic, we go through the cystic duct, or transcholedochal, straightforward, no major equipment is required. Rarely you do a choledochojejunostomy or hepaticojejunostomy, very, very remotely possible. And if you look at meta-analysis that are published in 2024 and the systematic reviews, this is all put together. Single-stage laparoscopic cholecystectomies and CBD exploration is superior for stone clearance as compared to two-stage procedure. That is all the data that is put together. I'm not cooking up any stories behind this. This is what is published in 2024. And all stones that cannot be managed endoscopically can be managed surgically. All endoscopic failures can be managed surgically. And this is the data which shows that the reinterventions resulting from complications is just 1.6%. And surgical endoscopic reinterventions are very, very low. This is the data that comes in 2024. And majority of the patients, in spite of what is said and done, that Mersey syndrome requires some sort of surgical intervention for long-term good results in these patients. Now look at this data that we see. Before 1990, I strongly agree that the stone clearance rates were better endoscopically, complications were more surgically, the mortality was more surgically. Now, what happened from 1990s to till date, you see the thing right now, the stone clearance rates are getting better surgically compared to endoscopy. Complications are far less as compared to endoscopy. Compare this over the years. Mortality is less surgically as compared to endoscopy. Length of hospital stay is less surgically as compared to endoscopy. This is pure data that is published that should show that single-stage procedures and laparoscopic surgical procedures are safe and can be done. Unfortunately, the cost of endoscopic therapy depends on the size of the stone. The increasing stone size, the cost increases. Unlike in surgery, what happens is the stone size, if the small stone size, the cost definitely increases because you have to go through transcystic method to use additional accessories. Otherwise, all standard thing, you go through the bile duct and clear the bile duct here. To sum up, for routine CBD stones, we have similar results. For gallstone pancreatitis, endoscopy is preferable. Large CBD stones, surgery is preferable. Post-chole endoscopy, post-op status endoscopy, abnormal luminal anatomy, surgery, stones with coagulopathy, endoscopy, EHPO, surgery, internal fistulae, surgery. Endoscopy's perspective is endoscopy is preferable, but surgery perspective, surgery is preferable. From patient's point of view, though both are similar, surgery has got better results. From the insurance point of view, surgery is inexpensive as compared to endoscopy. So when should the endoscopies fail? Basically, it all depends on the clinical setting, condition of the patient, stone size, access, endoscopic expertise, and laparoscopic expertise available in various institutes and across the country and across the globe. You cannot standardize one mode of treatment for everything. So not all CBD stones can be handled endoscopically. With limitations understood, the approach should be patient-centric. And we need maybe in future a algorithm to decide on surgery versus endoscopy based on unbiased evidence, expertise, and technology availability. Thank you so much once again for the patient hearing.
Any question from the audience? Yes? After? Okay. The next speaker is Dr. M. Ramchandani. He is also needs no introduction. He is Director of Interventional Endoscopy at Asian Institute of Gastroenterology, Hyderabad. And he has lots of publications, own work in national and international scenario. Welcome, Dr. Mohan Ramchandani.
Thank you, Dr. Sinha. And at the outset, I thank organizing committee for giving me this opportunity. What happened? No. It was open, no? Okay, so we'll be speaking about colonic polyps. Why it is important topic? Because India is a country where, though the colon polyps are less common, if you see the colon cancer, which is 26 per 100,000 in West, we are less than 6.4 per 100,000. So the incidence is less. But if you see this graph, how many cancers we are diagnosing? 4.4 and 3.4 are dying. That means incidence is almost equal to mortality. That's happening because we all diagnose the cancer in very late stage 3 or stage 4. That is because we depend on symptoms. If patient come with symptoms like bleeding, the patient has bad prognosis. If patients come with obstruction, very bad prognosis. So we must diagnose these cancers on routine screening, and we must have acumen how to diagnose this. And that is why it is important to know how the polyps looks like macroscopically and also by image-enhanced endoscopy. One must see a polyp with a Paris classification. As soon as we see a polyp, classify them as Paris classification. Why it is important? Because if you have a polypoidal lesions, the cancer rates are less. So the polypoidal lesions are 1S or 1P, or they can be a flat polyp. If you have a biopsy forceps, and the polyp is size, the height is less than that of biopsy forceps, they are all type 2A. Either this can be a flat elevated, completely flat, or excavated. Now we'll see why it is important. If you see this classification, if there is a polypoidal lesion like 1P or 1S, the cancer is there. It has not gone into submucosa. But if it is a flat polyp, even if there is a small cancer area, it has already gone into submucosa. So a flat polyp will start with level 4, while a polypoidal lesion have a different level, like the cancer will straight to head, then stalk, and then go to submucosa. If it goes to submucosa, then cancer spread to lymph node. Then it becomes a surgical candidate. So if you have a pedunculated or a 1S polyp, it's good because you can endoscopically resect them. And if you have a depressed lesion, already 50% have cancer. So moment you see a polyp, if it is elevated, it's good. But if it is a depressed one, it's already a cancer. The second classification is laterally spreading tumors. Polyps does not always spread vertically. They can go horizontally. And if they are going horizontally more than 1 centimeter, they are known as laterally spreading tumors. Now, the laterally spreading tumors can be good. Good means granular. G for good, G for granular. If you see a granular, it is good. Now, you saw it's a flat, elevated, homogeneous. But there can be some mixed polyp, like a elevated polyp in a homogeneously granular polyp. So that is known as 1S. So 2A plus 1S become a mixed nodular variety. And then there is a spread of cancer. So if you see a non-granular, it is not good. Non-granular, not good. Always, because there is no granules and they are mostly depressed. So more cancer. And you can see here, if there is a homogeneously granular polyp, the cancer rate is 0.5%. But as there is a big nodule appear, the cancer becomes more, 10.5. But if this non-granular to start with, already the cancer rate is high. And if it becomes more flat, the cancer rate becomes 31%. So just by mere seeing a polyp, whether it's a laterally spreading tumor, it's a deeply excavated or a homogeneously granular, you can decide what type of treatment I'm going to give. Because if there's a homogeneously granular, there is less cancer, you can remove by EMR. But if it's a depressed polyp, you cannot remove by EMR. You must do ESD. So that's very important to have a classification. Now, coming back to the image-enhanced endoscopy. Now, I will not go into the details of NBI, but NBI picks up angiogenesis. Whenever there is a cancer developing, there is neovascularization. And this neovascularization can be picked up by narrowband imaging. And that gives us a good imaging diagnosis of what is happening in histology. Like you can have a good three-dimensional microvascular architecture distortion, which can be picked up very easily by these chromoendoscopy. You can do chromoendoscopy by spraying the dye, or you can do by image-enhanced endoscopy. Now let's come to the most common classification which is being used is a narrowband imaging classification, that is known as NBI, International Colorectal Endoscopic Classification. It divides polyps into 3 types. Type 1 is hyperplastic polyp. We do not need to do anything about that. But if it's type 2, it is adenomatous polyp, and in type 3, it's a cancerous polyp. He goes for surgery, this goes for endoscopic resection, this can be followed up. Now, how to diagnose this? By seeing 3 things: color, vessel, surface pattern. Now, see the color. First, come to the color. If there is a polyp, and you cannot see the polyp, because the color of the polyp is same as that of background, it is most likely hyperplastic. When the color becomes darker, it is more likely to be adenomatous. Then see the vessels. As soon as you switch to NBI, you will start seeing either no vessels or there can be a lacy vessels. So these are hyperplastic polyps. While if there's a thick brown vessel, you can see the vessels which are thick brown but very regular, they are adenoma. And once you see, as I said, color same versus dark, vessels thick versus lacy vessels, or third is surface. Once you see the surface, there is a dark spot surrounded by white, it is hyperplastic. While if there is a tubular or branched white structure surrounded by these vessels, it is adenomatous polyp. So we can clearly define type 1 and type 2. Type 3 is more aggressive, where there can be areas of disruption of missing vessel, amorphous area, which is clearly a cancer. So you can have a type 1 and type 2. Type 1 is hyperplastic, but there are certain problems. The problem is that type 1 is clearly defining us a hyperplastic polyp. Type 3 is clearly defined as a cancerous polyp, but type 2 is bad because it is not allowing us to know whether it's adenoma, whether it's a superficial cancer, because there are certain difference. So how can nice be still nicer? Because all hyperplastic polyps are not simple hyperplastic polyp. There can be a sessile serrated adenomas, which are more aggressive. So nice classification does not allow us to do that. Type 2 also does not allow us to further differentiate between low grade, high grade, or cancer with superficial spread. So you can combine, as I said, Paris classification with nice classification. If there is a very aggressive cancer, but the polyp is pedunculated, then you still can remove by endoscopically because it has not gone deep. So it can be endoscopically removed if it is type 3, which is cancer, but if it is pedunculated. Similarly, type 2, if it is depressed, then it can still be more cancerous. So you require to do a ESD. While if a type 2 polyp is having mixed nodular variety, again it requires ESD. But if a type 2 polyp, which is neither depressed, neither mixed nodular, easily can be removed by EMR, which can be done in 15 minutes. So this is how you can take advantage. Second problem was M.I.C.E does not allow us to do differentiation between a low-grade dysplasia and high-grade dysplasia. So M.I.C.E classification does not require magnification endoscopy. So the Japanese came with a Japan NBI expert criteria that was known as Janet classification, but it requires magnification endoscopy. I'll quickly show this video, which is very important, a 2-minute video. You can see there is a polyp, which is same as that color of the background, and there are dark spots surrounded by whitish. It's clearly like M.I.C.E classification. It is hyperplastic polyp. Clearly, there is no doubt about that. That's a hyperplastic polyp. Now, the problem with M.I.C.E classification was there is no provision of sessile serrated adenoma. Now, look at this adenoma, which is same as background. There are lacy vessels, clearly like hyperplastic polyp. But here we can see, if we apply the magnification endoscopy, you will start seeing these vessels, which are almost similar to the but you can see open pits. These are open pits. Once you see open pits, it's a sessile serrated adenoma, which is more cancerous. Now this polyp, again, as soon as you see the NBI, darker than background, there are the many gyrus-like whitish structure surrounded by vessels. This is adenomatous polyp, clearly type 2A, which is like type 2 M.I.C.E. But here we can see a 1S variety with a central depression. There is a central depression, and as you apply the magnification, there is a difference. You can see in the depressed area, there are irregular polyps. So this is a more aggressive polyp. It's a type 2B, which is going more deeper. And you cannot remove this just by EMR because the size is small. Okay, you can remove, but mostly it requires an ESD. Here you can see a polyp which has completely lost surface pattern. There is no vascular pattern. Everything is distorted. I can't see anything. No vessels, nothing. So this is a Janet type 3, and it's a deep invasive cancer. So this is how the polyps are being diagnosed now. I have many slides. Unfortunately, I don't have the time. I'll not go into the details, but I will quickly come to a polyp which are very important. This is known as sessile serrated adenoma, and we are seeing more common now. Once we know that these polyps are associated with a more aggressive cancer, they can be easily mixed. They are proximally flat polyp, and the polyp, they are transparent. You can see through them. There can be a mucus which is difficult to rinse, and then there are open pits, and then these are grooves. So these are sessile serrated adenomas, and they are seen on the right colonic, but the hyperplastic polyps are usually seen in sigmoid. They can be left alone. But if you find a hyperplastic polyp on the right colon, you must do a magnification endoscopy and see these polyps because they can be sessile serrated adenomas. So I think with this, I'll end my talk since I have finished my time, but I will say that if we are not able to diagnose these classification very easily, you have an AI now, which allows us to pick up the polyps, and you can do the magnification endoscopy and do an endocytoscopy, which will tell you by the AI whether this polyp is a neoplastic or a sessile serrated adenoma, or they can be having invasive cancers. So you need not to learn this. The AI will take over, and you can see real-time histology, and AI will help us because you can see there is a serrated lumen, the nucleus are well placed, so this is adenoma. So this is how the classifications of polyp are being developed, and if you want to come learn more, you must visit us at AIG. from 19 to 21 September, we have huge faculty, 50 faculties from world over teaching us on these things. Thank you very much for your patient hearing.
Thank you very much, sir. Our next speaker is Dr. Zahir Nabi. He is a consultant in Asian Institute of Gastroenterology, Hyderabad. The topic is called the new heart in colonic polypectomy. Please, sir.
Good morning, all. I thank the organizers, especially Dr. Anil Roda, for this opportunity. So the topic assigned to me is called the new heart in colonic polypectomy. So in the next few slides, I'll be discussing why hot snare is not hot anymore, different types of cold snare polypectomy, the choice of snares. And if we see the story of endoscopic polypectomy, it all started in 1970s, and since then we have gained a remarkable improvement. The first study on cold snare polypectomy was published almost 3 decades back, and since then it has been a cold revolution. So hot snare polypectomy, not hot anymore. Why? So there are 4 reasons for it. Majority of the polyps that we see during routine colonoscopies are small, means giving heat may not be justified for such small polyps. Delayed bleeding and deep mural injury, they are associated with hot snare, use of hot snare or any other hot technique. And thermal artifact at margins is a headache for pathologists as well. But my main worry is delayed bleeding and deep mural injury. Let's come to delayed bleeding first. So why does delayed bleeding occur? So during hot snare polypectomy, the mucosal defect that you see immediate after polypectomy is not the actual size of defect. The defect, in fact, increases in size on the next day and next to next day, which means that the thermal injury has already spread deep into the submucosa, and that's why there is an extension of thermal injury to nearby vessels. And this is an ongoing process. So what you see on immediate after polypectomy is not the reality. In fact, the reality comes the next day when the chances of delayed bleeding increases. There is a premature loss of protective scar that forms, and this may be due to trauma from bowel movements and all, which in combination with, if you have coagulopathy, it leads to delayed bleeding. So there are studies which suggest that the incidence of delayed bleeding are much higher after hot snare polypectomy as compared to cold snare polypectomy. Let's come to the second aspect, that is deep mural injury, which is in fact a bigger concern as compared to bleeding, which can be controlled. So if you see the defect or the depth of injury, on first day, you will see that the defect is larger with cold snare polypectomy. But what happens on second day with hot snare polypectomy, the defect in fact increases. On the other hand, it reduces in cold snare polypectomy. And again, the reason being that the inclusion of submucosa during hot snare polypectomy is much higher as compared to cold snare polypectomy, where the inclusion of submucosa is only 24% in 24% of cases, which means that the exposure of submucosa, the exposure of vessels is much higher with the hot snare polypectomy, and that is the reason for deep mural injury. Now, where in GI tract it matters the most, I think if you see the layer architecture of different places in lumen, you'll find that the muscle and mucosa, they are very thin. The maneuverability is poor and the lumen is narrow, especially in duodenum and right colon. So there is no surprise that the cold revolution has maximum taken place in colon, especially the right colon and transverse colon. The duodenum, where also cold snare polypectomy technique is now picking up. And you'll find that the majority of the guidelines or the expert recommendations, they suggest that always close the right colonic defects because of delayed bleeding and also because of thermal injury. And duodenal defects, you should always close. Why? The reason being they have thin walls, and they are the main places where cold revolution has taken place. So what do guidelines say about heat right now? Most of them, they say no, especially about hot forceps polypectomy. So whether it's a AGA guideline, ESG guideline, or Japanese guideline, they all mention that do not use hot forceps polypectomy. Now coming to cold techniques, so there are 4 main cold snare techniques. One is using conventional snare, cold snare polypectomy. Second is using dedicated snares. Third is using cold snare EMR for larger polyps. And then last is cold forceps polypectomy. Let's come to why should we use a dedicated snare for cold snare polypectomy. If you compare cold snare versus hot snare, you'll see that cold snares are smaller in size, they have stiffer sheath, that's a very important advantage of cold snares, and they are thinner in diameter as compared to the conventional hot snares. So these differences are very important. And what does it mean that when you use a dedicated snare, less force is required, they have better efficacy, and less stalling, means the snare getting stuck into the polyp is less common with a dedicated snare. So there are different type of cold snares that are available. Now you'll see that all of them, they measure 0.3 mm or less. All of them are available in different configurations, 9, 10 or 15 millimeter. So are they all same? No. If you see the force required to resect with different commercially available cold snares, they are different. And as compared to conventional snare, which requires a lot of force to cut the same polyp. So that is the reason why dedicated cold snares are important as compared to the conventional snares, and not all the cold snares are same. Now, what about the technique? I think the technique has been described well. You just need to focus the polyp at around 6 o'clock position, and then finally you press the snare sheath and then cut it. This is a 3-stage process where you push the snare, you close it, you wait, see all the margins have included or not. This type of protrusions are very common, and this is mainly the muscularis mucosa that's being protruded outside. What are the outcomes? So this is just a summary slide of a lot of randomized trials that have taken place. What about the comparison of cold snare versus hot snare? Complete resection rate appears to be similar. Post-op bleeding is less common. Depth of resection is less in cold snare as compared to hot snare, which may be a disadvantage as well. And procedural time is, of course, less in cold snare polypectomy. What do the guidelines say? Use cold snare polypectomy for polyps less than 10 mm. All the guidelines universally recommend this aspect. What about cold forceps? Is there a place in 2024? If you compare cold snare versus cold forceps polypectomy, you'll find that if you are using a conventional snare, definitely the complete resection rates are much less with cold forceps polypectomy. Only jumbo forceps can match cold snare polypectomy, and that too for polyps which are less than 5 millimeter in size. So that is the reason that if you are using a cold forceps, most of them, they recommend avoid cold forceps, but AGA guidelines suggest that if the polyp is very small, 1 to 3 mm, you can use cold forceps, jumbo cold forceps with equivalent results. So always prefer cold snare over cold forceps. Jumbo forceps should be preferred over standard forceps. If you are using a cold jumbo forceps, it can be an effective alternative for polyps 1 to 3 mm. So what about cold snare EMR? Cold snare EMR is being utilized more and more often now for polyps which are measuring 15 to 10. The principle is the same, you just don't apply heat. You do a sequential resection by injecting and then going from one edge to the other edge. So the results are pretty good, but what are the worries? It's a very safe technique, delayed bleeding is very less, but the main problem is high recurrence rate. So you can find recurrence rate in 1 out of 4 patients. So what are the concerns with cold snare polypectomy? If you see, the main concern is low depth of resection. If you see these two images, you'll find that the amount of submucosa included in cold snare polypectomy is almost negligible, and muscularis mucosa is also included less often in cold snare polypectomy as compared to hot snare. So these are all studies which suggest that the vertical margins in cold snare polypectomy is not deep enough. So there are studies which have compared all modalities, and they suggest that still underwater EMR or conventional EMR, the depth of resection or en bloc resection, complete resection are better with hot snare EMR. But then mind it, this is for polyps measuring from 6 to 20 mm, so the quality of evidence is poor. So to overcome all these limitations, there is a combination that has been proposed, that is underwater cold snare polypectomy. There are limited data, but it's a very promising technique, and I think this is going to be the future of cold snare polypectomies. It shows better R0 resection, better polyp retrieval rate, lower polyp fragmentation rate, and similar safety profile. So to summarize, cold versus hot, the cold forceps polypectomy, I think for less than 3 mm, cold snare polypectomy for all polyps, irrespective of their nature, less than 10 mm, cold snare EMR for polyps measuring more than 10 mm, and underwater cold snare polypectomy, the data is less than 10 mm, and it's a promising technique. And this is my penultimate slide. The efficacy of cold snare polypectomy is best still in less than 10 mm, so I won't recommend it for more than 10 mm, where the chances of incomplete resections are high. The snare type, always use a dedicated cold snare because it requires less force. Post-op bleed is negligible, and it's also shown safety in patients on antiplatelets or anticoagulants. Cold forceps should be avoided in general. If used, use jumbo forceps. Cold snare EMR we have discussed, and all the guidelines unanimously recommend less than cold snare polypectomy for those less than 10 mm polyps. The only concern with cold snare polypectomy right now is inadequate depth, higher recurrence. The emerging indications of cold snare polypectomy, where it's showing encouraging results and excellent safety profile, is for duodenal adenomas and also small pedunculated polyps. You should know how to maximize your success with cold snare polypectomy by using all these maneuvers that are mentioned in this slide. If you want to know more about EMR and cold snare polypectomies, come to AIG Live, and that's all from my side. Thank you.
Thank you, all the speakers. We are now open to some questions if you have any.
So I'll take the first question, if that's all right. The question is to Dr. Rao. Dr. GV, you have a unique experience of doing therapeutic ERCP and, of course, doing advanced laparoscopic endoscopy. So which is that CBD stone which you would yourself upfront take up for surgery, which means laparoscopic removal, and which CBD stones in your own practice for your own patients you take up for ERCP?
Yeah, any large CBD stones with gallbladder intact, I'll take the patient directly for surgery. Any patient with terminal CBD obstruction, I'll take this patient for surgery because we can tackle this endoscopically, but even my colleagues will agree that all these patients come up for discussion in our medical board, and we take a decision that these have to go for surgery. And of course, actually, MIRIS is now increasingly being done endoscopically, but we are not tackling the gallbladder in MIRIS, we are tackling with endoscopically. My concern would be MIRIS, there's a high incidence of malignancy, especially in the northern belt, actually. So my personal belief is actually MIRIS should be tackled endoscopically, surgically.
Can I take one question? Here. Dr. Rao, you said that one step laparoscopy and CBD explosion is better than the two steps.
Yeah.
I ask you a question. How many of the surgeons in India or abroad are competent to do that?
Now, I'll ask the same question again to you. How many endoscopists are competent to do a laser lithotripsy in a peripheral center?
No.
So these are all arguable
This
things.
is
What I'm
the-
saying is evidence is evidence. Actually, what I'm saying is it's a practice, the guideline that practice in different parts of the thing. You cannot standardize this thing to everybody. You understand? Not how many people are doing it, but what is practice. See, what is practice in India could be totally different from what is practice in some other part of the world. So the evidence that is collecting is the pooled evidence from across the globe. So that is the evidence. So standard practices could vary from places to places because it could be because of various reasons. Professional reasons, technical reasons, expertise reasons, referral pattern reasons could be variable, but we're talking about evidence as compared to practice.
Excellent talk, Dr. Rao. My question is, in a subset, we have been having increasing number of the patients being referred to us after cholecystectomy with a large cystic duct remnant, which contains a stone.
Yes, very good.
That is where the newer surgeons, or maybe the gallbladder was inflamed, they went in too early, they didn't want to fiddle around the porta hepatis, and finally to do a partial cholecystectomy or complete cholecystectomy as per their assessment. And then they have a large stone in the cystic duct. Theoretically, we can remove it by laser lithotripsy, but again, the stump remains.
I agree to this, Anil. Actually, this is basically because surgeons underutilize intraoperative cholangiogram because of the strong dependence on ERCP. Surgeons underutilize the role of MRCP prior to these things. I strongly believe that the surgeons have to get used to intraoperative cholangiogram, depend on MRCP, or to an extent, actually, an evolving specialty of intraoperative ultrasound to make sure that we do the clearance. I fully will agree with you that a lot of inexperienced surgeons are leaving a significant segment of gallbladder, which are coming back with
Which
stones and
grows with
rectangle.
passage of time. And
Yes.
these patients are referred to us by surgeons.
Yes,
only.
absolutely,
Then
right.
we do an MRCP
Yes,
and refer them back
absolutely
to
right.
them.
So when we
that
do
one-time solution.
yes, absolutely right. What you said is absolutely right. Actually, some of these technologies are underutilized, so I think the surgeons have to get used to these technologies.
And one basic question to Dr. Mohan and Zahir. Dr. Mohan, what is the pathogenesis of the polyp of different varieties? Whether the polyps remain SSA or hyperplastic or adenomatous, is it all genetically determined or there are different initiating factors?
Yes, that's a very important question. I think the adenomatous polyps follow APC gene, and 75% are cancers are like that. But 25% do not follow that pathway. Some follow the serrated pathway. They are the hyperplastic polyps. So the hyperplastic polyp can be hyperplastic polyp, they can be a sessile serrated polyp, traditional serrated polyp, which do not follow the traditional APC gene pathway. But fortunately, they are rare. But once cancer develop in sessile serrated, it is very aggressive. So that means we must know how to diagnose this, at least as an endoscopist, and also we should educate our pathologist how to diagnose this. And any polyp which looks hyperplastic in right colon should never be taken lightly and must be removed, even if we are not able to diagnose by magnification endoscopy. But since it is looking hyperplastic, we must remove in right colon. We should not take it lightly.
Yeah, see, nowadays we see a lot of patients with the cirrhosis, and there are multiple GB stones, and one of the stone has come to the bile duct. We'll remove the stone in the bile duct, but this patient requires the further management. What will you do?
Thank you so much once again. Yes, actually, cholecystectomy in a cirrhotic patient is a difficult thing, basically because of the morbidity associated with these procedures. Yes, now with increasing expertise, more and more of these patients, depending on the MELD score, actually, both of these patients can be tackled laparoscopically, but a small percentage of these patients would require open surgery. But I think to overcome this problem of subsequent stone slipping into the thing or subsequent acute cholecystitis that is requiring an emergency surgery, I personally believe this has to be taken as an elective procedure so that you can clear the gallbladder after bile duct clearance.
So you will go for the lap cholecystectomy or open cholecystectomy?
I would certainly say try for laparoscopic cholecystectomy, but if there is any difficulty or intraoperative excessive bleeding, then we go for open surgery at the same time.
Thank you. Mohan, how often you use chromoendoscopy apart from optical chromoendoscopy?
Rarely used. One, because we are not very well trained, because we are well trained in NBI or magnification endoscopy. But if you see the Genet type 2B classification, whenever we are in doubt that this Genet 2, NICE 2 still keep us still confused whether it's an invasive or not. At that time, you can use the chromoendoscopy to further diagnosis. But role of a routine chromoendoscopy spraying indigo carmine on every polyp is not practical, and we do not use it. But if doubt, like invasion versus no invasion in Genet type 2B, we use it.
Excellent talks. My question is an extension to what Dr. Viren Singh asked, but to you. In a patient with cirrhosis and has portal colopathy and all those, so will all those NBI and will still be valid in these kind of patients for detecting malignancy in colonic polyps?
That's a confounding factor, yes, but it's still the tubular adenomas and cancer, it still looks same. But yes, I agree that hyperplastic polyp or a normal colonic mucosa is well congested, and there can be some changes, but adenomatous polyp and precancerous polyp like type 3 are can be easily picked up even in portal hypertension cases.
Sir.
Just a comment on what Dr. Virender said. The frequency and incidence of gallstone in cirrhotic is almost twice the general population. It is not uncommon for them, one of the stones to slip down, which occurs in 1 in 10%. We do an ERCP, and almost always these patients have to be followed up with lab chole, because with passage of time, your liver function is likely to deteriorate from A to B. And open versus laparoscopic, there is no doubt laparoscopy is the treatment of choice and is the modality of removal of the gallbladder, unless you are pushed to the wall if there is intra-op bleeding. With our expertise and expertise at our place, most of the surgeons will prefer not to do an open cholecystectomy in cirrhotic, which has much more morbidity and mortality compared to laparoscopy. It's just a question of getting more experience.
We
And you
also
should not
get
postpone it, because with passage of time, liver function will only deteriorate.
We also get a lot of referral from our liver transplant surgeon awaiting transplantation, acute colitis. We put transcystic stent and keep on exchanging till the liver transplant is available. That's also a point.
Zahir, one question to you. What is your, you said all the snares for cold polypectomy are not the same, right? So which is the one you prefer at your center? And second is, what is your take on stopping of anticoagulations while doing a cold polypectomy?
So the recommendations are the same, but in a high risk cardiac patients, I think if the patient is on DOAC, it has to be just to be stopped on the day of the procedure, and then subsequently it can be continued. And if the patient has a high risk of high cardiac risk, I think in those cases even it can be continued. So far the data suggests that delayed bleeding is not a major issue after cold snare polypectomy. Regarding the type of snares, as I mentioned, that the force required to resect is different in all the snares I just showed. I'm not going to take any commercial name, but then there are snares. If you are beginning cold snare polypectomy as a beginner, I'll use a snare which has the least force to resect, because then it boosts up confidence and I won't be worried that I have included muscle layer into the snare. And as I gain experience, I think any dedicated snare, whether it's Microtech, Olympus or Boston, they are equally effective. But the force required to resect may be less with Boston snare as compared to Boston and Microtech as compared to Olympus and the other companies.
If there are no more questions, we'll finish the talk. Thank you all the speakers. Thank you so much.
Thank you all the speakers, the moderators and the chairpersons of the session. Moving on to the next session, Endoscopy's New Frontiers, Artificial Intelligence, Innovative Techniques and Barrett's Esophagus Management. May I please invite the moderators on the stage for the session. Dr. Shailendra Kishore from IIT Kanpur, Health Center Kanpur. Dr. Preeti Rajput, Dr. Satyarth Chaudhary from Gastro Liver Institute Meerut, and Dr. Shankar Khalko, Liver and Gastro Clinic Ranchi. The chairperson for the session, Dr. Yogesh Batra from Nirprastha Apollo Hospital, New Delhi, Dr. Srijan Man Pradhan from Kirtipur Hospital, Kathmandu, Dr. J.R. Mahapatra from Peerless Hospital, Calcutta, Dr. Lalit Kumar Das from Shahid Dharm Bhakt National Transplant Center, Kathmandu, and Dr. Sajan Agarwal from Gujarat Gastro Hospital, Surat, Gujarat.
ओपन करना सर, इसको क्या करना है, बंद कर, ये पीछे खोला तो है आपने, इसको मिनिमाइज कर दूँ, हाँ ओपन किया लो, हाँ
Yeah, good morning, everyone. For the first speaker of this session is Dr. Jayanta Samanta. He's Associate Professor, Department of Gastroenterology, PGI, Chandigarh. So may I request sir to kindly start his talk. Thank you, sir.
Done? No?
लेने का सर। ये है ना सर?
नहीं, ये मेरा है ही नहीं। ये आया ना अभी।
कौन सा सर?
Sorry, I did not tell the topic which he'll be delivering. The topic is artificial intelligence in endoscopy. Has it come of age? Sir, stage is all yours. Thank you.
एक मिनट सर, ओपन हो रही है।
ये भी नहीं चल रहा है।
चलेगा। एक मिनट।
Good morning, everyone. As we start off, at the outset, I'd like to thank Dr. Anil Arora sir and the whole team for giving me this opportunity. Yeah. बहुत बड़ा है, 800 MB का है।
हो जाएगा। इसको क्लोज करो।
वीडियो प्ले होगा इसमें?
जिससे पेन ड्राइव लगे रहने दीजिए।
आया नहीं वहाँ पे।
जिस आ जाएगा। एनिमल एडिटिंग होगी।
Sorry for the delay. My job today is to talk on artificial intelligence in endoscopy. Has it come of age? So artificial intelligence has of late in the last few years, maybe around 10, 15 years has come of age, has been come much into prominence. So let us start with the history. So let's see how artificial intelligence came into being. So the first probable concept of artificial intelligence was given way back in 1950s during the Second World War by Alan Turing, where he developed this Turing test, and that is when he started developing this concept of making an intelligent machine. After that, the first term of artificial intelligence was coined by John McCarthy in 1956. Since then, there has been not much of a movement between 1970s to 1990, which we always all call about as artificial intelligence winter, because there was reduced funding interest. People thought that it's not of much use. Followed by that, deep learning came in the year 2000, followed by from 2010 to 2014, CAD was applied to endoscopy initially, and it was that same time when in real life artificial intelligence became popular, with Apple releasing Siri or Amazon releasing Alexa. Followed by PharmaBot was built in 2015, 2017. Chatbot Mandy was the first time launched, which was an automated patient intake device. Followed by, since 2018 till present, there have been multiple AI trials going on in gastroenterology. So that is how the history of artificial intelligence has come into being. So artificial intelligence in our everyday life is filled from the smartphones to apps, to autonomous vehicles, self-driving cars, fitness monitors, etc. Everything is about artificial intelligence. So when we talk about artificial intelligence, what do we mean? It's like simulation of human intelligence in machines programmed to think and act like humans. So there are multiple terms. I'm not going to go to the details because the time is very limited. Artificial intelligence is a broader term when we talk about programming systems to perform tasks. Out of that, machine learning is one of that, where you train algorithms, and deep learning, where you use multiple deep neural networks with multiple layers. So what happens is one of the layer acts as the input for the next layer, and this is how the machine learns how to understand pattern and then help in taking decisions. So if you look into the publications in artificial intelligence or AI in endoscopy, you'll see that it has skyrocketed in the last 15 years. And if you see, these are the various countries where more and more people are kind of doing research in artificial intelligence. If you look into what are the various areas where artificial intelligence publications has been there, majorly in conventional endoscopy, capsule endoscopy, and most of the diseases like GI polyps, gastric cancer, GI bleed, these are the major areas where artificial intelligence has been studied in details. So whenever we talk about AI applications in endoscopy, we talk about 4 things. One is CAD-E. CAD-E is computer-assisted detection. CAD-X is computer-assisted diagnosis. CAD-E or CAD-X can be a combination of both, and CAD-Q is where you do a quality assurance. So what are the various things or topics that can be covered under these headings? Like colonic polyps, Barrett's, where CAD-E is used, diagnosis of the neoplasia, what is the nature of the polyp? For that, you use a CAD-X or H. pylori IBD severity. CAD-E and CAD-X combination can be used in this. And when you talk about procedure assurance or procedure administration, the quality of your endoscopy, then when CAD-Q comes in. And as you go along the line, the complexity of your machine keeps on increasing. So I'll give you a brief overview. It's a very large topic. I'll give you a brief overview of the various fields in which artificial intelligence has come into being. So let's say when you do a routine upper GI scope for a gastric cancer screening or a routine screening. So this is one of those devices, a WiseSense device. This was an RCT published where they showed that how artificial intelligence can be used in order to ensure that the endoscopist is not missing any blind spot. So this particular device had shown that blind spot monitoring accuracy was as high as 90%. You can see on the left-hand side that it shows what areas of the stomach has been covered by the endoscopist and what areas are not, and that can guide the endoscopist to cover the uncovered areas. Similarly, AI in early gastric cancer can help in detection. So what happens is there are multiple data that is coming up where they use CNN in order to increase or enhance the detection rate of early gastric cancer, which is often missed by general endoscopies, where you can see on the left-hand screen that there will be a blue color box which will keep on indicating where there is a suspicion of an early gastric cancer. And these things have shown a detection rate of as high as 92%. Early gastric cancer depth can also be identified using artificial intelligence. Coming to AI in Barrett's esophagus, again, CNN-based devices have been used where they have used Barrett's AI prediction with Barrett's esophagus and showed that the accuracy as high as 90%. And it has also been shown that even AI improved the performance of the non-expert endoscopist in Barrett's esophagus. If you look into the meta-analysis of performance of artificial intelligence for upper GI neoplasia, it was shown that it has a very, very high sensitivity and specificity of 90% with an area under curve of 0.95. Coming to colonoscopy, artificial intelligence probably has the highest interest of late in colonoscopy for 2 purposes. Again, CAD-E and CAD-X, that is detection of polyp and then characterization of the polyp. So this was one of the first randomized controlled trial published from Wang et al., where they used CAD-E in order to find out whether artificial intelligence was improving the adenoma detection rate or not. So what they found out was they randomized around more than 1,000 patients, and they found that yes, AI was superior to in adenoma detection rate, and the mean number of adenomas was also higher. And this was a meta-analysis published last year, which showed that yes, ADR rate was higher detected in CAD-E group as compared to the control group. Coming to polyp characterization using EndoBrain, this was a Yoichi Mori's project, and they have shown that you can actually use EndoBrain. EndoBrain is one of those first commercially available artificial intelligence softwares where you can use this device in order to kind of characterize the polyp, and then using this EndoBrain where there is a endocytoscope attached to the tip of the scope, you can actually kind of tell whether the polyp is neoplastic or not. So AI in colonoscopy, CAD-E or CAD-X, there are multiple devices available in the market. At least 5 to 6 companies that have been doing artificial intelligence using various kinds of devices. Even activity in IBD can be similarly assessed using artificial intelligence. And probably one of the important points is that advanced endoscopy, use of histology, artificial intelligence in histology, and the use of omics in IBD, probably we are moving towards AI-enabled precision medicine in IBD. Small bowel capsule endoscopy, again, artificial intelligence has shown that it can improve detection rates in all categories of the lesions in more than 97% of the cases. What about pancreatobiliary endoscopy? AI has been used to predict difficult bile duct cannulation, show where the area is and where to target. AI in stone removal, Huang et al. Had devised a technique of seeing the cholangiogram and predicting how difficult it will be to extract stones, and they have also kind of validated that study in a subsequent study. AI in post-ERCP pancreatitis prediction, again, these risk calculators have come up where you can actually kind of put in your risk factors and kind of find out what will be the risk of post-ERCP pancreatitis. AI-based collimation to reduce radiation dose. This is another interesting part where artificial intelligence is being used to focus only that part of the fluoroscopy where you are using the radiation, and as a result, it has shown it not only reduces radiation dose in the patient, but also of the endoscopist. AI in US training also similarly, they can guide you where to focus and what stations you have not covered. So they can keep on telling you where the station is and what are the movements that you're going to do. Similarly, AI has also been used to analyze the various kinds of pancreatic masses and kind of try to find out whether it is neoplastic or non-neoplastic. In cholangioscopy, similarly, it can be used. Even third space endoscopy, AI has been used where they can actually kind of identify those vessels and so that the operator can kind of target and be careful when they are doing these kind of dissections. But all that glitters is not gold. If you look into the data, the past meta-analysis that I showed was of randomized studies, but this particular study published of non-randomized studies using CAD-E showed that there was no difference. So this is kind of a real-world scenario where the endoscopist is using on its own preference and shown that there was no difference in the adenoma detection rate or the other aspects when CAD-E was used as compared to the routine colonoscopy. Similarly, this particular meta-analysis published this year had shown that if the strategy of leave aside policy of diminutive polyps in rectosigmoid, there was no difference whether you are using a CADX or you are not using it. So not all is rosy. So there are certain challenges in AI like reliability, robustness, reproducibility and generalizability, translation in clinical practice, etc. And probably some of these can be solved by high quality data, adequate sample size, regulatory approval, etc. Certain additional caveats will be overconfidence and selection bias when you're kind of training the AI software. There is always a risk of decrease in the skill of clinicians. There is over-dependence on that AI if that is being used more and more in the near future. Legality is a major issue because there can be misjudgments from the AI or a miscommunication between the human-AI interaction. And in those situations, who is to be blamed if there is a malpractice because of that? And obviously, there are no standard measures or reportable success. Future perspectives, more rigorous studies and clinical validation is needed. More coordinated research between the medical technologists, the computer expert, the gastroenterologists and researchers are required in order to make the AI more and more fine-tune them before it can come into regular clinical practice. Understand the role of human-AI interaction, need for appropriate AI governance. That's very important. And obviously, we need cost efficacy studies to understand whether these expensive softwares are of actual any benefit or not. So finally, my take-home message will be AI in endoscopy has arrived, but has it come of age? No, but still a long way to go. Technology will probably help raise the bar of all endoscopies, whether an expert or a non-expert, with the use of these AI technologies. But efficacy is not equivalent to effectiveness, so we need to tread with caution. Technology will not replace endoscopies, but we need to understand, we need to adopt technology, otherwise there is a fear of being replaced. And finally, as Victor Hugo has said, the future has many names, and AI is an opportunity for endoscopy. Thank you.
Thank you very much. It was a very lucid presentation. The next speaker of the day is Dr. Saurabh Mukeshwar. He is a consultant, Department of Gastroenterology, Midas Hospital, Nagpur. His talk is on IEE-RDI, TXI endoscopy, upcoming new techniques for endoscopists. So the stage is all yours. Thank you.
A very good morning, all of you. I'm Dr. Saurabh Mukeshwar, and thank you, Dr. Arora and Delhi Liver Foundation for having me here. So today I'll be talking about some exciting developments in the field of endoscopy, TXI RDI. Now this is all Olympus based. This is a technology in the Olympus scopes. The other companies do have their other technologies, but this talk will be primarily focused on development of these technologies. So as we see, our televisions have evolved from the 1930s to 2010s, and now you have LEDs. So the quality of TVs is obviously increased and improved over the years, and so have our endoscopes. I'll give you an example. This is a patient who was referred for a gastric hypoplastic polyp removal, and on narrowband imaging in this particular case, a lesion was identified in the esophagus, and we performed DSD, and this turns out to be, it was an adenocarcinoma. So high quality endoscopy does make a difference. Can pick up cancers early and save lives. So let's start talking about texture and color enhanced imaging. So this is top left is your white light imaging, where you can see, that's a polyp on the left of the screen. Bottom right, TXI mode 2 is an enhancement of the texture. You can see slight irregularity. And top right is a TXI mode 1, where you have both texture and color enhancement. Now you can see in the texture and color enhancement, the polyp really stands out. So this is the advantage of TXI mode 1. I'll just skip this. So how does it work? So TXI, when you compare it to white light endoscopy, this is a series of 12 gastric neoplasms and 20 gastric atrophic and non-atrophic mucosa. 6 endoscopists were involved in the study, looking at visibility and color difference. The image quality scoring, you can see from 1 to 4, 4 being very clear and 1 not so clear. So you can see TXI mode 1 scored the best, and that applied not only to the experts, but trainees as well. The color difference, what you can visibly see in these images, was much superior in TXI mode 1 versus TXI mode 2 or white light endoscopy. For H. pylori infection, 60 patients undergoing upper GI endoscopy, 22 images of white light endoscopy and TXI were compared. They classified patients in different categories: those with active H. pylori infection, past infection, or no infection. And you could see that TXI was more superior for active H. pylori gastritis detection. And compared to white light endoscopy, it had other patterns like diffuse redness, visibility of atrophy, and in past infection patients, map-like redness, much more superiorly seen with TXI versus white light endoscopy. Again, in Barrett's esophagus, now 52 patients, you can see TXI 1 outperformed TXI 2 and even narrowband imaging in terms of visibility. Colorectal lesions as well. This is a series of 22 patients, 68 lesions, various Paris classification lesions. Again, TXI mode 1 was much superior to TXI mode 2 or NBI for non-flat as well as flat polyps. So interesting studies. This is ulcerative colitis patients, 146 patients who were under remission with ulcerative colitis. A Mayo endoscopy score, which is something we routinely perform, was obtained. They additionally obtained TXI scores as 0, 1, or 2, 0 with no accentuated redness, 1 with accentuated redness, and 2 with accentuated redness and poor visibility of the deep vessels. So what was evident was patients with TXI score 2 had much higher relapse rate versus 1 versus 0. And what was interesting was patients with Mayo score of 1, they could bifurcate them in different categories based on TXI. So those with Mayo score 1 and a TXI score of 0 had a much lower rate of relapse versus those with a Mayo score of 1 and a TXI score of 2. So applying this to screening colonoscopy, 338 patients randomized to TXI versus white light endoscopy. There was no difference in baseline variables. The withdrawal time, in fact, was longer with white light endoscopy. And you can see the difference in the adenoma detection rate. So increased adenoma detection rate when you did colonoscopy with TXI, and more adenomas were detected per colonoscopy in TXI mode. How about adding something else? So this is endocuff vision. Now endocuff, if you're aware, increases your colon adenoma detection rate. So this is all patients had TXI endoscopy, colonoscopy, and those one group had endocuff and the other group did not. So you can see increased adenoma detection rates in those with endocuff in addition to TXI. So we can certainly, you can look at the adenoma detection rates. We are looking at almost 65%, which is very high. Something interesting, this is biliary cannulation. This is a series in patients with altered anatomy, and the bottom you see in the left is a patient with precut, and on the right is a patient with intradiverticular papilla. And when you switch on the TXI mode 2, you can see in the right video and in the left video, you can identify the papillary orifice more clearly. So higher cannulation rates were achieved when you used TXI for ERCP, and the time to cannulation was shorter. There are several applications of TXI have been there in cholangioscopy for identification of manor papillary orifice, ESDs, and duodenal ampullary tumors. So now I'll talk about the next part of the talk. This is red dichromatic imaging. So this is a new technology from Olympus where they are having the amber light. And the amber light, the advantage is it's mostly reflected if your the blood concentration is low, but it gets absorbed when the blood concentration is higher. So RDMO2 looks at deeper vessels, where deep penetrating amber light is absorbed strongly in the deeper vessels. So this is an example of RDMO2. On the left is white light endoscopy. And on the right, you can see with RDMO2, you can more clearly visualize the deeper submucosal vessels. So the advantage really with RDI is that you can identify deep vessels, as I mentioned, and also the bleeding points. And this is a video showing a diverticular bleed. You can see up on the screen, there was a diverticulum, and there's brisk bleeding from the diverticulum. Now, with the help of this amber light, you can basically point out the source of bleeding more clearly than your standard white light endoscopy. And this is the amber light, which is RDI mode. And you can see the source of bleeding can be seen a little better as compared to your standard endoscopy. All right, move forward. Okay. All right, so how does it work in the clinical practice? This is a series of patients undergoing ESD with RDI full-time versus white light endoscopy, and different locations, esophagus, stomach, and colorectum. And you can see the procedure time with full-time RDI mode was shorter compared to white light endoscopy. Sorry, the dissection speed was faster. Randomized control trial looking at ESD with right RDI versus white light endoscopy. Almost 400 patients were included. So what was seen was there's no difference in hemostasis time, no difference in the treatment time, but the psychological stress that the endoscopist experienced was much less when they were in the RDI arm versus the white light endoscopy. For patients with upper GI bleeding, we all know it can be quite challenging sometimes to find and pinpoint the source of bleeding, and can be very annoying, especially when it's a brisk bleeding. So this is 64 bleeding lesions evaluated by both white light and RDI. You can see all endoscopists, RDI outperformed white light endoscopy across the trainees or experts. Interesting application. This is RDI for eosinophilic esophagitis. Patients had similar standard endoscopy scores of EOE, but those with RDI grade 2 had much higher eosinophil count, suggestive of more significant inflammation. So last slide here, this is RDI looking at high-risk varices treated with endoscopic sclerotherapy. Interesting study. 155 patients with risky esophageal varices were treated with endoscopic sclerotherapy, either with RDI or white light endoscopy. And what was seen was shorter time and higher success rates were obtained with RDI versus white light endoscopy. And more interestingly, the color difference, which is exactly what we are trying to aim for here, was much better seen with RDI versus white light endoscopy from bleeding point versus surrounding mucosa, and bleeding point versus the surrounding pool of blood was more discretely identified with RDI versus white light endoscopy. So in conclusion, compared to white light endoscopy, you can have improved visibility with TXI, increased adenoma detection rates, you can predict the relapse of ulcerative colitis, you can help in papilla identification and cannulation. For RDI, you can identify the bleeding point during upper GI endoscopy, hemostasis during ESD, predicting inflammation in eosinophilic esophagitis. I'll thank you here, and I'll invite all of you to the liver meeting in Nagpur, which is a midterm INSL meeting as well on 18th and 19th of January, and I'm happy to take any questions. Thank you.
Thanks a lot, Dr. Mukeshwar, for such a lovely presentation. The next topic of the day is management of Barrett's esophagus, what is new? And the speaker is Dr. V.G. Mohan Prasad. He is founder and chairman, VGM Gastro Center, Coimbatore. So the stage is all yours. Thank you, sir.
At the outset, let me thank the team SGH for inviting me, especially my dear friend Dr. Anil, Ashish, and Praveen. So already some 6 seconds are gone. So let's see. Okay, Barrett's was started in 1950. The term came in from Barrett, which is a transformative process in which the metaplastic columnar epithelium replaces the endogenous stratified squamous epithelium in the lower portion of esophagus. So why do we have to bother? Because the intestinal metaplasia can go to low-grade dysplasia, high-grade dysplasia, invasive carcinoma. What is the prevalence? 6 per 100,000 in India, and in our own 56,000 GERD patients. It was, the BE was only 0.56%. It may be different in different corners of the country. We all know the Praha. So the high resolution and NBI about which we heard is very helpful because the superficial blood vessels are brown and the deep submucosal veins are cyan, and any abnormal vessels can easily be picked up, and the pit pattern is of paramount importance here, and the vessels, vascularity. So if you see the normal pit pattern here, the abnormal pit pattern, and also see the abnormal vessels. So the NBI can go in a big way to help us to diagnose, and of course all the classifications, Amsterdam 2 or Kansas or Nottingham, all talk about, like the regularity or irregularity of the pits, and also regularity and irregularity of the vessels. And of course, Barrett's, if there's a case like this, can easily be identified. But if we had a patient like this, 39-year-old guy, who had columnar-lined esophagus right from cricopharynx down to the hiatus. So this becomes a challenge. Some of the areas had low-grade dysplasia. So how do we diagnose where even to target in these cases? So AI comes in a big way. We had a lot of lectures on AI. And now, the CAD system outperformed a panel of 53 endoscopists, just completely bowled out. So accuracy, sensitivity, specificity, all were superior in these cases. So the AI can distinguish between a squamous mucosa from a non-dysplastic Barrett's to dysplastic Barrett's. So what about pathophysiology? What is new? We know that esophageal acid exposure is the prime mover. But then what is more important is we have genetic and environmental factors and molecular mechanisms that play a role in the causation and progression of this disease, so that personalized management strategies can be tailored once we know this. So, and now today we know that the metaplasia, the intestinal metaplasia, is because of GE junction stem cell disease. And we thought that it's the acid that goes and corrodes the superficial layer, and then the stimulus causes the stem cells to produce a reparative epithelium, and then that gets transformed to Barrett's. Is an old concept, and but the new concepts are different. And it is not the reflux acid paradox, but histologically acute GERD that causes this. So the chemical injury causing surface erosion and then the polymorphs coming in is one, but the latest concept is the acid going to the base of the esophagus because of the loose junctions, and this gastric acid triggers the inflammatory response. And of course, this is the most important thing. And then what is interesting is like bacteria can also produce a problem here. The bad bacteria, increase, and the good bacteria like firmicutes go down. The fusobacteria, proteobacteria increase, and these through the LPS TLR4 pathway can increase NF kappa B and interferon gamma, and can trigger inflammatory response. So the lymphocyte infiltration happens. So now today the concept is that the acid hits the base and not the roof. That is the latest concept today. And monogram has been written on esophageal disease and role of microbiome. This article is not latest. It's 20 years back, 2005, which shows bacterial biota in the Barrett's esophagus. We know that today the Barrett's has got more of Fusobacter and Proteobacter, and esophageal adenocarcinoma also can be increased because of Proteobacter. And there are articles which say even probiotics can help. reverse the situation. I'm not going through that. So how about genetic markers? We'll be doing it in future, all these. So the TP53 gene mutations and CDKN2A mutations have been shown to predict progression and prognosis, and the DNA methylation markers also. And the microRNAs, the cytokeratin 7 and 20, can differentiate a dysplastic Barrett's from a non-dysplastic Barrett's. So pharmacologic approaches, of course, acid is a prime mover, you have to suppress it. People have shown that PCABs are 10% more efficient than even the PPIs. So you have to suppress acid. And there are newer targets for Barrett's treatment. Newer pharmacologic approaches are coming up in the pipeline, and endoscopic therapy is the major player here. You can resect it using EMR or ESD, but remember to ablate the mucosa either through RFA or through cryo. And then remember to augment the OGJ, because very important, because chronic acid reflux can produce problems. Surgical options of fundoplication. What is new? DNA changes and the extra chromosomal DNA. These can get altered years before the development of cancer. So you can do them as markers. Cranberry juice is known to protect. There are studies that showed that PPIs reduced the EAC progression by 71%. This is meta-analysis. And AI, of course, has come in a big way. I'll just show you a couple of cases before I sign out. 50-year-old gentleman, my old patient who's been on regular follow-up, had a low-grade dysplasia at the time of endoscopy, and D-meter was more than 40. We did RF ablation, we did arms, and then 2 weeks post-arms, I called them back for a collagen spray because this can enhance the tightening. And I've got the patent for endoscopic spraying of collagen, and also now the Shiley VGM Hemosil spray has been approved for marketing in India. And post-arms, the tightness, and again, the augmentation of LES, and the D-meter has gone below 12. This is the second case where, again, a Barrett's. We did a band EMR here for a low-grade dysplasia, and now patient is absolutely doing well. So what are the things that endoscopically can increase the output, like Watts 3D, which can collect more cells, and it can be AI-based pathology. And again, tissue cipher is one of the most exciting things in the first AI-driven precision medicine test. And then, of course, the non-endoscopic techniques are cytosponge, EsoCheck, and EsoFact cap. And endotherapy of Barrett's neoplasia, I'll just sign out with this. So we need to acquire tissue and resect it, either by EMR, wherever it is big, or wider areas, ESD, and elimination of intestinal metaplasia is of paramount importance after you do an EMR or ESD, and then you have to augment the OGJ. So nodular lesions you can easily remove, subtle lesions are difficult. So conclusions of endoscopic therapy is that even in HGD or T1A carcinoma, it is very good, and excellent survival rates. I would leave you to go to this 2022 AGA guidelines for screening and surveillance, and these are the practice guidelines for eradication therapy in 2024 AGA. So we need to counsel for tobacco cessation, weight loss, and refer patients with BE, high-grade dysplasia, or mucosal cancer to high-volume centers, so the complication rates will be less, completion of eradication will be there, and a dysplasia has to be certified by a good pathologist. And then the goal of therapy has to be discussed with the patient, and then we have to document very well. My friends, at the end, I would like to conclude here. We have a lot of exciting info in Barrett's. The next decade will see that our practice of detection of Barrett's, surveillance, and prediction of progressors will all change within the next few years. Thank you so much for this patient listening and this knowledge.
Thank you, Dr. Mohan, for the excellent presentation. The session is now open for discussion.
My question to Dr. V.C. Mohan. Sir, Barrett's esophagitis is only to be looked up when the symptoms of GERD is there. Do you do screening biopsy or for Barrett's esophagitis? Any?
So, what was the question?
GERD is quite a common symptoms, so you should.
Okay.
Yeah.
Oh, from here. Sorry. Yeah.
So routine upper GI endoscopy, you should do the regular biopsy for such patients, or only the metaplasia is diagnosed when you do this?
Yeah, great question. Those days, using white light endoscopy, people used to do biopsies every 2 centimeters all around. But there are a lot of studies which showed that is not ideal, and the targeted biopsies are the best. Today, with the advanced magnification systems and narrowband imaging, you can easily find out what is the metaplastic type of mucosa. If you don't have, you can do a dichromo endoscopy, and then that can easily, like differentiate, like an iodine or even a, indigo carmine, which can stain the intestine and metaplastic type of epithelium in Barrett's. Then you can do targeted biopsies. They're always better.
My second question is, there is a mention of ecosprin in prevention of Barrett's esophagitis in a recent textbook of medicine, Harrison. So how does do you know any, you can throw some light on this? Ecosprin as a prevention for Barrett's esophagitis.
Low-dose
aspirin.
Ecosprin. Oh, yeah. Yes, of course.
How does it help? I mean, what is the rationale?
We are not, gastroenterologists are not using, but it's there in the textbooks.
Is one dye better over the other? I mean, is Lugol's iodine better over acetic acid or endococcus?
The Lugol's iodine will stain the starch in the, squamous epithelium. So, but whereas indigo carmine, in the intestinal metaplasia, you want to know whether, if you see the cardiac type of columnar lining, you want to know whether there's intestinal metaplasia IM, then indigo carmine can help.
Yeah, Mohan, coming back to the basic diagnosis, of course, as we know that dye is really not commonly used outside clinicals in routine practice. But fundamentally, going back to the diagnosis of Barrett's, would you require histology, or would you say this is Barrett's epithelium and appearance, or would you require histology? And if you require histology, is columnar lined epithelium sufficient, or do you want intestinal metaplasia? These areas are a little bit different between societies. It's not completely resolved yet. So I think that would be one question that I would like you to clarify.
Yeah, Shiva always comes out with tough questions. Okay, the British Society said even a gastric type, cardiac type of lining is okay, but it's not okay. We need to show the Paneth cell, goblet cells. It's, I just removed many of the slides. Beautiful editorial which said goblets. So then only you can diagnose Barrett's.
So histological diagnosis of IM is a prerequisite for labeling a patient Barrett's epithelium.
Absolutely.
That was what I wanted to clarify.
Yeah, because you cannot label somebody as Barrett's on endoscopy. Exactly. It's a pathologic diagnosis.
My second question is to Dr. Samantha. As far as CADI detection of polyps is concerned, I think you'll agree with me that the gold standard for in all the studies, it was not better than the expert endoscopist. So if you look at, broadly speaking, the gold standard for diagnosis of polyps was the experts, and the CADI was only better than junior fellows or junior people or fellows in training. So, but if you are going to adopt that in training, then they'll never become expert.
Yeah, I agree with you, but some of the studies have shown that the adenoma detection rate per se is higher with CAD-E, but let me complete that sentence by saying that those are even less than 5 millimeter polyps were higher detected in CAD-E as compared to this. So meaning thereby, this is what I say, this is what I said was efficacy is not equivalent to effectiveness. So basically, whether those 5 millimeter detection of the polyp, was it actually necessary? One. Second is people have also shown that more amount of non-neoplastic lesions were getting resected because of the use of CAD-E. So all these non-neoplastic lesions, detection of diminutive polyps, these definitely rose, but at to what extent or to what significance is something which we need to kind of think of.
Just Jayanta, continuing in the same vein as Shiva has asked, My question is, what is the sequence of training for the upcoming gastroenterologist? Do they first learn on the WLI and maybe 2 to 3 years down the lane you put them on AI, or they start with AI and they will never learn the WLI?
very
And
different.
then what is the flip side of it? Maybe you're leaving it to the machine. So are you less attentive? Do you need to focus less? In any case, machine is going to pick up everything. So you can be, less focused on the assessment. Is that not a flip side of it?
Absolutely, sir. That's what I also mentioned, that probably we are de-skilling the clinicians, the future clinicians that we are developing by using too much amount of AI. So AI dependence is something which can lead to over reliance on the software, and then that can lead to de-skilling of the clinicians. So probably in this aspect, what we can do is we can use the AI as a control for the trainees. So the trainee sees the white light only and does it, and detects how many adenomas they have detected, and then at the back end you have a result that these are the things you have missed. So that can be used as an evaluation process if you're talking about trainees per se.
So the trainees get trained twice. First in the WLI, then maybe 2 years
then
down the
probably,
lane
yes,
AI.
yes.
Is that the sequence followed?
We still do not know. We do not know the answer. But yes, definitely, once the trainee has been trained in the routine conventional endoscopy, probably AI is going to assist in that.
So it is a top-up training, not
Yeah.
the training to begin with.
No, obviously not. And probably AI will help much more in those situations where probably in the peripheral centers, not in the high expert centers, but in the peripheral centers where probably the quality of the endoscopy might not be that great. So AI might help to lift that endoscopy standard higher up with the help of AI. So a routine endoscopist who is not that much expert within quotes.
Won't you become more complacent, like you are depending that even the dark areas or difficult to see areas will be told to you by the AI?
Yeah, yes.
So won't you be more complacent? Oh, even if I miss, AI will prop me up.
Yeah, that gives a sense of
false
definitely.
safety.
Must be.
Jayanta, would it replace the examination time for endoscopy or withdrawal time for the colonoscopy? Whether the AI will replace that or will it remain the same? The examination time of 8 minutes or 7 minutes for endoscopy and withdrawal time of 9 minutes.
No, sir. So if you look into the data, also they suggest that probably the time for examination is higher when you're using AI, because they'll try to kind of point out every small polyps, etc., etc. So in those situations, obviously, the time will not much differ. Data suggests that the time doesn't differ much. And if you're asking me whether the withdrawal time should decrease or not, no, definitely not. That should not happen, because that will always lead to a misadenoma rates.
Since we have run out of time, I think we'll need to close the session. We thank the chairpersons and the moderators for this session.
Thank you so much, all the moderators, the chairperson, and the speakers for the excellent session. Starting the next session, endoscopic expertise, submucosal tunnel endoscopic resection, and duodenal neuroendocrine tumors. May I invite on the stage the moderators for the session, Dr. Roop Jyoti Datta from Dr. Damani's Nursing Home, Dibrugarh, Dr. Manish Sachdeva, Sir Gangaram Hospital, New Delhi, Dr. Vishal Khurana from Metro Heart Institute and Multispecialty Center, Faridabad, Dr. Kunal Das from Yashoda Hospitals, Noida. Chairpersons for the session, Dr. Apurva Shiva from Fortis Hospital, Kolkata, Dr. Sharad Malhotra from Akash Healthcare Hospital, New Delhi, Dr. Saurabh Srivastav from Pratap Gastro and Liver Clinic, Jhansi, and Dr. Roshan Shresht from Patan Academy of Health Sciences, Kathmandu.
Good morning, everybody. The topic of this talk will be tips and tricks for the beginners. And the speaker is no other than Dr. Pankaj Desai. All of us know he's a interventionist. He's a director and head of Department of Endoscopy at M.I.C.E Hospital and Research Center, Surat. Dr. Pankaj.
Yeah. At the onset, I thank Dr. Anil Arora and his team for this kind invitation. And since we have very less time, I'll just directly move on to the topic. STIR is basically an offshoot of endoscopic full thickness resection. It is a tunneling full thickness resection. And usually it is done for subepithelial lesions of the GI tract, esophagus, stomach, and the rectum. And for evaluation of any subepithelial lesion, we need to do an EUS at the onset. And these are the findings which I am not going to discuss. The common lesions which we usually resect are the cysts, NETs, lipomas, and other rare tumors. Briefly, ASG recommends EUS for all lesions. Leiomyomas, unless symptomatic, should not be resected, and larger than 2 centimeter lesions, you need to do an FNA. Now, the absolute indications where any beginner should start this stir is EUS and CT evidence of intraluminal growth arising from the muscular propria. It has to be intraluminar. Diameter of 5 centimeters, that is a cross-sectional diameter of the tumor, is the key, and tumor located in the mid-esophagus, lower esophagus, or the esophagogastric junction are the indications. The relative indications would be significant extraluminar or exophytic growths. Submucosal tumor arising from the muscularis propria are relative indications, and the contraindications are patients with severe cardiopulmonary disease, ASA3, coagulation disorders, pregnancy, and evidence of metastasis. So, which lesions should we deal, and on what locations? So, this is a very important diagram where you have to see that any lesion which is located on the lesser curve of the stomach going into the fundus is an indication for stir. Other lesions on the greater curve going towards the antrum is an indication for doing a stir. The other areas high on the lower lesser curve and in the fundus, they are not amenable for stir, and you have to do a full thickness resection or an ESD for this. Basically, what have to be used is high-end endoscopes with a necessary water channel. You require hoods, different types of knives, coag graspers, injectors. Injected would be saline in majority of the cases. You may use snare sometimes to remove the difficult part of the tumor other end to the muscle. Hemoclips, of course, for closure, and irrigation and CO2 insufflator. This is the armamentarium which you have to have. You can have Olympus, or you can have whatever sort of system that you are well versed with. The important thing is it has to have a accessory channel flushing. The common knives which I use is a triangular tip knife or a hybrid knife for my dissection. And removing the tumor from the muscle, I would use an IT knife, that is an insulated tip knife, and these are different types of clips that you can use for closure. Coagulation graspers are important to secure hemostasis during the procedure. The preferred settings that I use or that are recommended is usually an endocut Q, and we use either a forced coagulation or a precise sect if you have an herbe. Similar settings you can have on an Olympus cautery also if you have. And the effect would be 50 watts and an effect of 2. For coagulation, we usually use an effect 4 on soft coagulation at an 80 watt setting. So these are the basic preferred settings. Very important, the CO2 flow has to be very low. So it depends on what CO2 insufflator you're using. You have to find ways and different means of reducing the flow because you are working in a tunnel. Very high CO2 will cause a lot of CO2 related complications that we will see briefly at the end. The technique of stir basically is you have to inject 5 centimeters or 3 to 5 centimeters proximal to the lesion, in line of the lesion, make a subcutaneous tunnel, submucosal tunnel, dissect the lesion from the mucosa and the muscularis propria, and then retrieve it. So what important things that we should know is we have to identify the tumor. Sometimes tumors in the esophagus are fine, but tumors at the G junction are sometimes tricky. So what to do is when you see such a tumor on the lesser curve, what we do is we inject on top of the tumor so that when you see from the esophagus, you see the blue marking here. And that is where you will start creating your tunnel, so that because majority of the times in such tumors which are in the fundus, you can get lost. So this is one important trick which you should know. The second trick is, the technique is you have to inject 3 to 5 centimeters above in the line of the tumor. You can make a liberal injection with saline and methylene blue. That is what I usually use. Don't put adrenaline in this because I would like whatever bleed to happen in front of my eyes. And once you enter into the tunnel, you have to dissect like you do in any other third space procedure, that is doing a poem or any other third space procedure. So this is making a tunnel, basically clearing the submucosa and separating and identifying the tumor. You can see it is as a white tumor in the silhouette. The most important thing which I do first is I would dissect the tumor out from the mucosal site first. That is important because I don't want to damage the mucosa here. So this is a tumor which I have identified. I have cleared the mucosa on the top, and the part which is adherent to the muscle, we would use an IT knife, go along the capsule of the tumor, identifying the capsule and trying not to damage the capsule, because that is very important, especially for cysts, because damaging the capsule in a cyst would have a worst oncological outcome. So once the tumor is dissected, from the muscle, what you would require is to retrieve the tumor. And once you can see here that we are removing the last part, then we catch this tumor with a snare in a longitudinal axis that would ease out the pulling of the tumor from the tunnel in the esophagus. And once that is done, the tumor can be resected and the tunnel closed. If the tumor is too big sometimes, it is not very amenable to take it out from the tunnel, which is not very wide in the esophagus. So a double tunnel technique has been, double outlet stir has been described. So in this, what we do is dissect the tumor, as you can see here, and I thank Mohan for this video. So you resect the tumor, and the tumor, as you can see here, is in the stomach. It's not coming out from the esophagus. So what we would do is create another tunnel, another opening in the stomach, push the tumor out in the stomach, and then retrieve it from the stomach through the normal esophagus. So this would be a very important trick to remove tumors which are larger in size, and then you close the esophageal and you will close the gastric incisions, and the patient is safe. Sorry. Next, rectal tumors are also amenable for stir. Sometimes it is not very easy in the rectum because the rectum is quite redundant with the tortuous lumen, which makes it very difficult. But there are a few successful case reports, and this is one such report where we have removed a tumor from the rectum. The technique is similar. Inject below the tumor. Then you can identify the tumor like you do in the esophagus, remove it from the muscle, and then close the defect with the clips. Sometimes in rectum, you cannot make a very long tunnel, and therefore you can either convert this to a full thickness resection. And now, coming to the end, technical tips for stir at different sites. Esophagus is easy because it is a tubular structure. Usually a decreased space to perform stir, and hence a maximum diameter of 35 mm is recommended in the esophagus. Maximum diameter reported is 70, but that's probably a longitudinal one. And the cross-sectional diameter, as I told, is very important. Briefly, you have to again understand that these leiomyomas in the esophagus or G junction can be multifaceted. So you have a lot of offshoots of the tumor which are going. So once you resect a part, you can think it's over, but then what happens is few other tumors just creep on coming from below. So you have to be very careful when you are resecting esophageal leiomas because they can be multifaceted. Adverse events, you have to be very careful. You have to be vigilant to see if the patient has capnopericardium or capnothorax or capnoperitoneum, and then you have to drain it. Bleeding has to be controlled, as you can see here. And of course, the mucosal injury, if it happens, you have to close it immediately. So, to end, stir remains a complicated endoscopic surgery that requires multidisciplinary team with expertise in surgery, advanced endoscopy, and the patients for which stir is performed should be selected very carefully. Thank you so much for your kind hearing.
Thank you, Dr. Pankaj. Next lecture is by Endotherapy of Duodenal Net by Dr. K.K. Rawal. He is Director of Prime Institute of Digestive Sciences from Rajkot. Dr. Rawal, sir.
At the outset, I thank Professor Anil Arora, Parveen, and Assis for this beautiful conference. Respected chairpersons and moderators, we will discuss endoscopic treatment of duodenal net. Yes. I will discuss non-ampullary duodenal nets. The incidence for 15-fold increase in the incidence of duodenal net since 1970. Duodenal net accounts for only 2.6% of GI nets. They are mostly non-functioning, located in D1, single and grade 1. These are subepithelial or epithelial tumors. So yield of endoscopic biopsy is very high. These are the screening tests: serum chromogranin A, gastrin to rule out gastrinoma, CT scan or MRI if lesion is 5 to 10 mm, DOTA PET scan if lesion is more than 10 mm, EUS to assess the size, muscle invasion, and lymph node metastasis. Now, these are the lesions which are amenable for endoscopic treatment. If the size is less than 10 mm, depth of invasion confined to submucosa and well differentiated because they have low potential for metastasis. Now, size matters. If the size is 10 mm, the lymph node metastasis is 14%. If it is 20 mm, it becomes more than 50%. So the size is important. Now, there are many techniques for the endoscopic resection, like a snare, EMR, ESD, or full thickness resection, clip assisted or device assisted. But there are no consensus or the guidelines for the different approaches. So let's first see the different techniques. Now, this is the classical pale lesion in the bulb. Is easy technique, just inject and cut. But EUS is a must. You must show that the muscle is free. This is the easiest of all the techniques, band and slough. Band without resection. If the band is not completely encircling the lesion, place another band. Keep only 2 bands on the cylinder to get the unrestricted view, and use freshly loaded bands. Biopsy should be taken before bending, of course. Now, this is band EMR. After marking, inject the saline and apply the band. Insufflate the lumen sufficiently so that muscle layer is forced out to prevent the perforation. Wait for more than 1 minute so that band is completely encircling the lesion to avoid a positive vertical margin. Shake the snare 2-3 times to ensure that muscle is free. Current setting is 316. If more than 4 seconds is required, that means you have caught the muscle. If you cut above the band, perforation rate will decrease, but the complete resection rate also will decrease. And always, as Jahid told, always close the defect. This is the complication of band EMR. Perforation. I think every unit which is dealing with such procedure must have OTS clip, either padlock or the Ovesco. And these perforations are circular, so it is very easy to close them. Just apply the clip and the job is done. This is bending without resection and single incision needle knife assisted biopsy, sync biopsy. First US is done, and after bending, use the needle knife. I think this is combining therapeutic and diagnostic efforts, both together. This could be a viable alternative to EUS FNB for the lesions less than 20 millimeter in size. Can be done in routine endoscopic and there is no advanced equipment is required. This is another technique. This is the ESD. This is really challenging in duodenum because of the narrow space, and it is the curved space in the duodenum. It is not straight. There is rich vascularity also. Wall is very thin, so the chances of perforation is very high. Also, there is poor lift due to Brunner's gland present in the submucosa. So obviously, it needs a very high level of skill. This is useful OTSC assisted endoscopic resection when muscle invasion is suspected. Clip is implanted prior to resection by hot snare, thus reducing the risk of perforation and achieving a deeper resection. This is gastric full thickness resection device. The cap is 19.5 millimeter, depth is 23 millimeter, and the channel size must be 3.7, so that you have to use therapeutic scope. It has integrated snare and the tissue grasper to hold the lesions. Now let's have evidence for clinical application. This Korean study compared band EMR versus conventional EMR for duodenal rate. You see the resection rate with the band EMR was much high, en bloc 100%, complete 85%, It was less with the conventional EMR. There was no recurrence for 2 years. So they concluded ligation-assisted EMR showed a higher complete resection rate than the conventional EMR. This original paper from USA, band and slough technique, used in 4 patients, 1 session, mean number of band used were 2.75, no recurrence for 2 years, and no complications. This is the largest study with longest follow-up till date. It is still in press. The outcome of endoscopic resection for well-differentiated nets, EMR, ESD, and EFTR, when muscle invasion was detected during ESD, all 3 techniques were used. Out of 78, 36 went for EMR, 36 ESD, and 6 EFTR. 10 had non-curative resection, 4 underwent surgery, 74 patients were followed up, 1 developed recurrence after 3 months of ESD, 73 patients had no recurrence for a median follow-up 5 years, longest follow-up was 12 years. So they concluded endoscopic resection is safe, effective, and provides a favorable long-term outcome for patients with well-differentiated duodenal net without local or distant metastasis. The last study is really a thought-provoking study. Clinical outcome after incomplete resection. 58 patients were taken. They had incomplete resection. Resection technique, all techniques, forceps, snares, EMR, ESD were used. 81% had positive margin, but recurrence was very low, 8% in 3 years. So there was no difference among various techniques. Their final statement was, even after incomplete endoscopic resection, recurrence was low, irrespective of the positive margin and the kind of endoscopic resection technique used, and it does not affect patient's clinical outcome. So to conclude, ladies and gentlemen, this is the proposed algorithm. This is my last slide. EMR, ESD, EFTR, when to choose what? If the size is less than 5 millimeter, endoscopic resection by forceps snare is sufficient. Its size is 20 mm, surgery should be the answer. Between 5 to 10 mm, EUS must before resection. In selected cases, 10 to 20 mm can also be considered, of course, in advanced center with the proper skill. If low-grade tumor, muscle is free, lymph node negative, if answer is yes, you can go for band EMR or 5 to 10 mm lesion. If it is 20 mm, 10 to 20 mm, ESD or EMR is the answer. If the answer is no, if it is a muscle invasion, lymph node metastasis, then the surgery is warranted. If low-grade tumor but without lymph node, muscle is involved, then you can go for full thickness resection. For surveillance, there are no definite guidelines. Some societies say annual, some societies says biannual, Japanese do annual. If there is some recurrence, then you go for surgery. Thank you.
I think the session is open for any questions. Dr. Rahul, one I want to ask you. You said about the single polyp. If there are, say, 2 or 3 polyps, then how do you approach? The approach is same or any different?
Good question. If there are more than 1 polyp, then you must rule out MEN, the multiple endocrine neoplasia. You should rule out the other site also are involved. Most of the time, these multiple duodenal nets are the part of MEN syndrome. So that is very careful. You must do DOTA scan. You must see there are no local or distant metastasis. Only then you contemplate endoscopic therapy.
Yeah. So in the algorithm, we see histological grade and presence of absolute lymph node. Does location in duodenum also decide by which therapy to choose?
Less likely, because sometimes if it is just near the pylorus or touching the pylorus, then the resection can be difficult. These are all about non-ampullary duodenal nets. But even if it is in D1 or D2, location hardly matters. 90% of the tumors are located in D1, and they are mostly non-functioning low-grade tumors. But if they are higher grade and if the metastasis is there, local recurrence, muscle is involved, see, you have to take it in case-to-case basis. One size doesn't fit all.
Yeah, Dr. Prasad, and congrats for a beautiful lecture. My comment was on the duodenal neuroendocrine tumors. So if you cannot perform an EST for fear of perforation, the best thing to do will be to do an Ovisco clip. Once it heaps up, usually the EFTR device is expensive, difficult to locate and rotate below the pylorus. So the best will be to deploy a visco, and then before you snare it, just apply bands. The bands will heap up the tissue, and then you can snare it. Then you get a total.
Applying a band after Ovesco
After
is
Ovesco,
very difficult. It will be very difficult because it will be thicker. So
Yeah.
why to apply band at all? Why not to resect it?
We
That's what I showed.
We submitted this. We had a paper in ACG also on this 28 cases of duodenal neuroendocrine tumors using Ovesco EMR, resection. So we
But
found
the data had shown that band EMR is better than anything else. I showed it. Ligation assisted is better than EMR.
True. I know. I agree.
Okay, excellent talk. I just one question. What is the natural history of this duodenal net? You must have done review.
Yes, the natural history.
If you don't take them out, what
Yes,
happens?
yes. If they are, this is one of the, because of time I couldn't show that paper also. If there is that lesion is less than 5 millimeter, there are now some thoughts, some school of thought says that you just follow them up. And if they are growing and you do biannual survey, if they are growing in size, obviously they are malignant tumors. Later on, they will turn into the full-blown malignancy with local and distant metastasis. So all duodenal net has to be removed. This is the bottom line. Now, if the tumor is less than 5 millimeters, say age is 60 plus, you can have another option of following up. If they have coagulopathy, associated morbidity, unfit for endoscopic dissection, you can follow them up biannually or 3 years. The studies have shown even after 12 years, once you resect the tumors, recurrence is 0. So they are very indolent tumors, slow growing tumors, but they have to be removed.
My question is to Dr. Pankaj. Pankaj, you showed that the way we handle the CO2 inflow, we have such advanced technologies, TXI and RDI, and whenever it is a question of CO2 insufflation, we are using either gauze piece or arterial forceps. Why is it not an integrated part? Because nobody will do third space procedure without CO2. So why is it not an integral part of the machine? We are using very crude method of tying it with gauze piece or using arterial forceps.
Yeah, unfortunately, like the laparoscopic surgeons, the machines, CO2 insufflators available to us, even the Olympus high-end machine, they have tubes which are ultra low flow or low flow and other machines. But the problem is even the ultra low flow is giving such a big flow, and especially when you are doing in internal. So there is no mechanism which has been developed. I think that is the need of the hour, that for us to improvise something.
Yes. Absolutely, should be a part of the machine.
Yes.
In which the
Just
total
to add
flow
that,
has to be regulated.
Just to add that, Pankaj, we use 3-way stopcock in between.
I showed that
so
also,
that is
because
also,
in some machines you can use, in Olympus I think it is not very feasible to use that. So, yeah, so that's right. So we have to have insufflators like they do in laparoscopy, where you can control or reduce the flow to a minimum.
Shouldn't it be a part of the integral part of the machine?
Absolutely,
process,
absolutely.
Rather than
Yes.
just trying
And
to.
that is where I think the companies have to work, and even we have to brainstorm with them sometimes if we get a chance.
Sir, I have a question.
One more question.
I'm Mohan Prasad here, on the other mic, Pankaj.
Yeah.
Yeah. Okay. See, you were talking about making another nick on the gastric side for removing the stir. So once you dissect it out and it's inside the tunnel, you can even cut it with the snare and remove it. So what is the point against it?
Yeah, that is also a possibility, but sometimes it is too big. And to cut the tumor in the tunnel, you have to have a part of the tumor attached to the muscle. Once you have removed the tumor, dissected the entire thing out, the current will not pass through because it doesn't have attachment.
It does pass.
But it is very difficult. So this is a technique for very big tumors, which may not even after cutting come out.
You don't need one more nick on the gastric.
Yeah, it's obvious, but this is just one more technique. Otherwise, you can just resect it in pieces and take it out.
My question is to Dr. Pankaj. I am a surgeon. There was a comment about that draining the capnothorax and capnoperitoneum and capnopericardium. So how do you drain that?
We usually use capnopericardium is very uncommon. Capnoperitoneum is the most common because of this. And what we do is use a 16 gauge intracate, just put it on the right upper quadrant and which is partially filled with saline and allow continuously to drain out.
So, I mean, every time you need to drain it. I mean,
I don't. No. This is a rare complication. If you have
no,
a very
if,
low,
if it is there, so every time you drain it, I mean,
if it is causing problems to the respiration,
selectively,
yeah.
you do it
If it
selectively.
has any ventilatory side effects, if the anesthetists feel that the EtCO2 is rising and they have difficulty in ventilating, that is the only
in the
time.
thorax, this way, I mean, this way of draining will be very difficult. With
No,
the help
it
of
is not very difficult. If it happens,
with the help of a needle in thorax.
yeah, you can do it. Thorax usually doesn't happen. Whatever happens is in peritoneum.
So
Right?
you do it selectively.
Yeah.
Thank you.
Dr. Pankaj, one more question is, as you said, it should be removed as a single piece. And I think this is because the tumor cell gets spillover. That is the reason probably recurrence becomes higher.
Yeah,
and it should be
especially
single
for
piece.
gysts.
But my
When you
question,
are
please.
yeah, please.
You go ahead.
I think the gysts, it is always better to have a non-block resection. Leiomyomas, you can do a piecemeal resection once you have taken it out. But gysts, it is always preferable to have because it has oncological implications.
So my question was this, that during phase of resection, what all precaution you take when you want to take, other than damaging the capsule, what extra precaution you take to avoid spilling over of the, especially in patients when you are managing gysts. So what all precaution you take during resection?
No, I think as I told you, we always use an insulated tip knife so that our cutting knife never touches the capsule. That is the most important thing which we do. And probably we would keep a small layer of the submucosa around the capsule and rather than being right on the capsule.
And last question, Pankaj. My question is, all the series of stir for esophagus and as well as the G junction, the basic histopathology is leiomyoma. But most of the leiomyomas do not need treatment. So
Absolutely.
are they being unnecessarily resected?
That is what I showed in one slide. That unless and
Unless
until
and most of the leiomyomas cannot be symptomatic.
Absolutely.
Why do we remove that?
No. It is absolutely imperative that you don't remove unnecessary leiomyomas. Just for the sake of practice, you may not do it. Absolutely true.
Just one last question, Dr. Pankaj, please, if time permits. You have shown that in your personal experience and opinion, till what distance from G junction should we consider STR instead of ESD or other methods? Also, till what size of the lesion would you prefer STR?
Size would be 3.5 to 5 maximum.
Because it causes problems in extraction.
Yes.
And you
And from the G junction, the distance doesn't matter. It is the direction in which you have to make your tunnel. So if it is on the lesser curve going straight down, you can resect. But going on the
lesser
greater
curve will be, I think,
lesser curve,
easier.
you can definitely
Much
resect.
easier, even if it is distant
Greater
from the
curve
G
is not easy. You have to do a ESD in retroflexion then.
Thank you.
Thank you for the excellent session, members of moderators, chairperson, and the speakers. We'll now have a tea break for 10 minutes. We'll gather again for the next session. Moderators for the next session, Dr. Arvind Gubbi from Gubbi's Gastroenterology Center, Bangalore. Dr. Naresh Bansal from Sir Gangaram Hospital, Dr. Ramchandra Soni from Sarvodaya Hospital, Faridabad, Dr. Jeevan Thapa from Pokhara Academy of Health Sciences, Kathmandu, Dr. Deepak Lahoti from Max Super Specialty Hospital, New Delhi. May I have the moderators on the stage, please? The chairpersons for the next session, Dr. Dipesh Sood from Shahid Bhagat Singh Polyclinic, New Delhi, Dr. Sagar Podiyal from NP Narayani Samudayak Hospital, Kathmandu, Dr. Rajdeep Singh from JP Medical Center, Chandigarh, Dr. Bikal Ghimire from Tribhuvan University, Kathmandu, and Dr. Ajay Kumar from GB Pant Hospital, New Delhi.
Ladies and gentlemen, it's an honor to invite my good friend Dr. Akash Shukla, who require no introduction. He's a director and senior consultant in the Department of Hepatology, Sir H, in Reliance Foundation Hospital and Research Center, Bombay. Akash, over to you, sir.
Good morning, everybody. The outset, I must thank Dr. Arora for inviting me here. So we'll discuss vascular liver disorders management. Unfortunately, for want of time, I will not be able to cover everything. So we'll try to cover Budd-Chiari syndrome and portal vein thrombosis. So when should we suspect Budd-Chiari syndrome? So in any patient who has got a chronic liver disease or an asymptomatic patient with chronic liver disease, Budd-Chiari syndrome remains a differential diagnosis. We do have a scoring system to suspect Budd-Chiari syndrome, but I think if you have a patient who's got a high protein ascites with a low cell count, the first differential diagnosis is Budd-Chiari syndrome. So I think this is the key message. So there are several prothrombotic disorders. The left is from the review article written by Professor Patrick Kamath in NEJM in 2004. But of course, you must do those prothrombotic disorders evaluation which do have treatment implications like myeloproliferative neoplasms, PNH, antiphospholipid antibody, protein C, hyperhomocystinemia. And these patients should definitely consult a hematologist. So these disorders are the ones which we need to really take into account. What about prognostic indices? Once you have diagnosed a patient, how do you prognosticate? Several prognostic scores are there, like the Clichy score, the New Clichy score, the Rotterdam score, the BCS TIP score. Unfortunately, all of them prognosticate cohorts of patients and are not good for prognosticating individual patients. But the closest that comes to prognosticating individual patients is the Rotterdam score and the Clichy score. Let's come to the actual treatment of Budd-Chiari syndrome. The EASL guidelines describe the stepwise approach. You start with anticoagulation and the medical therapy. Those patients who do not respond to this, you do angioplasty or stenting or thrombolysis of the hepatic veins. If the patient doesn't improve, you do TIPS. If the patient still doesn't improve, you do transplant. So we evaluated this in a prospective study of 138 patients who were put on anticoagulation alone. And we saw which patient responded and which patient did not respond. And although a large proportion of patients had initial response, 1/3 of these patients actually lost this response later, mostly in 1 to 2 years period. Those who lost their initial response had a high mortality. And presence of ascites at baseline was associated with loss of response. So patients who were symptomatic at the onset, even if they responded initially, they had a high risk of relapse of Budd-Chiari, and this relapse was associated with increased mortality. So instead of anticoagulation, can we use DOACs? So those who are CTP-A, there is no problem. Those who are CTP-C, we should not use. What about those who are CTP-B? There we should use with caution. Similarly, patients with GFR less than 30 and dabigatran especially in patients with GFR less than 50 is best avoided. Rivaroxaban is best avoided in patients with CTP-B and C both. DOACs should not be given in presence of antiphospholipid antibody, and we should have access to reversal agents to treat the toxicity. What are the principles of interventions in patients with Budd-Chiari syndrome? So up to 20% of patients with BCS have short segment thrombosis or ostial obstruction of hepatic veins, and this gives a unique opportunity to recanalize the hepatic veins and therefore restore physiological flow. And therefore, hepatic vein angioplasty recanalization is the preferred invasive treatment for us in Asia Pacific region for short length thrombosis or ostial stenosis. Whenever we do a angioplasty, if we do a stenting along with it, it has shown to reduce reintervention and improve the long-term patency. Those patients who require a derivative therapy, TIPS is the treatment of choice. And therefore, if you look at the APASL guidelines of 2022, if there is a modification. So those patients who come with acute Budd-Chiari syndrome, if they fulfill the criteria of acute liver failure, then they should be listed for liver transplant. While liver transplant is being tried, in the interim period, we can try thrombolysis or TIPS. Those acute Budd-Chiari who do not fulfill the criteria of acute liver failure, those patients may be managed with thrombolysis or anticoagulation, and if they do not respond, then TIPS may be done. What do you do for patients with subacute or chronic Budd-Chiari? The first step is whether they are symptomatic or asymptomatic. If they are asymptomatic, then we can give them medical therapy alone. And if they get loss of response later, then radiological intervention or TIPS may be done. If they are symptomatic, then you see whether they are amenable to hepatic vein recanalization or not. If they are, then you don't try just the medical therapy. You would straight away take these patients up for hepatic vein recanalization, because that is what restores physiology. If not, then before doing TIPS, you'll give a trial of medical therapy. If you get a response, we continue. If you do not get a response, you do TIPS. Those patients who do not respond to hepatic vein recanalization, you can offer TIPS. And transplant is for those patients who do not respond to TIPS therapy or who are not eligible for TIPS. Coming to portal vein thrombosis. The diagnosis is dependent on radiology. So based on ultrasound, CT and MRI, the first step is to differentiate whether you are dealing with a malignant thrombus or a benign thrombus. Once you have made this differentiation, then you try to differentiate whether this is an acute thrombus or a chronic thrombus, or a recent thrombus or a chronic thrombus, based upon whether it is T1, T2 hyperintense or T2 hypointense or T1 hypointense and T2 hyperintense. So MRI is the best modality for differentiating between these three. Do you do thrombophilia workup in patients with portal vein thrombosis? For childhood onset EHPVO, no. It's extremely rare to have a thrombophilic disorder. For adult onset portal vein thrombosis, yes. Portal vein thrombosis in the presence of cirrhosis, probably yes. Various combinations of risk factors may present. Therefore, if you have identified one risk factor, it does not deter you from doing a complete workup, because you may have more than one etiological factors. What about anticoagulation in portal vein thrombosis? In the absence of cirrhosis, portal vein thrombosis rarely resolves spontaneously, and therefore anticoagulation should be started at therapeutic dose immediately at diagnosis. What do we start off with? Low molecular heparin and switch to vitamin K antagonists when possible. DOACs may be considered in selected cases, like we discussed according to the CTP status. The minimum duration of anticoagulation should be at least 6 months. Beyond 6 months, long-term anticoagulation is recommended in patients with underlying prothrombotic states, and even in those who do not have underlying prothrombotic state, one must still consider giving anticoagulation. If anticoagulation is discontinued, then we must do a D-dimer level 1 month after the discontinuation. And if this is less than 500, then you can reassure yourself and the patient that the risk of rethrombosis is low. Can we start anticoagulation in high-risk varices, or can we do EVL in patients who are on anticoagulation? The beta blockers may be initiated before you do the band ligation. EVL can be done if the beta blockers are contraindicated. Anticoagulation should not be delayed for eradication of varices. The benefit is lost if you wait till the eradication of varices, and there are several studies which have shown that you do not need to discontinue the anticoagulation when you are band ligation. This was one of the first studies, and there are at least 4 subsequent studies which have shown that you can safely do band ligation while the patient is on anticoagulation. When do you do interventions in patients with portal vein thrombosis? So we do mechanical recanalization. The most effective mechanical method is balloon angioplasty. In those patients who have already undergone a prior angioplasty, and if they have a stent in place, then you can go through the tips, do a thrombus aspiration, or you can pull and retrieve the thrombus with a balloon. If the portal vein branches are occluded, then TIPS is preferred over others, although it makes doing the TIPS much more difficult technically. What is new in the nasal guidelines? The indications of portal vein recanalization may be considered in patients who have acute symptomatic portal vein thrombosis with persistent symptoms despite adequate anticoagulation, acute symptomatic PVT with persistent thrombus if the main PV is thrombosed despite adequate anticoagulation, but the primary and the secondary branches of PV are patent. And this should be attempted even in the presence of mild symptoms. Patients should be referred to expert centers for these procedures. PVR TIPS is recommended in patients who are listed for transplant with thrombosis of the portal vein trunk without recanalization or anticoagulation. And if you are doing this, then we should avoid putting the stent in the main portal vein if they are transplant candidates. To summarize, my dear friends, portal vein thrombosis is often associated with thrombophilic disorders. The most acceptable and clinically relevant classification of PVT is the one by Northrop et al., which is the ASLD classification and also adopted by the Bovino. Thrombophilic workup is warranted. Anticoagulation should be started immediately, and radiological interventions should be for those patients who have refractory symptoms. Thank you very much, and I'll take this opportunity to invite all of you for the APASL Single Theme Conference and the Build 3.0 on 7th to 9th February 2025 at Mumbai. Thank you.
Next talk is on chronic hepatitis B virus. It's a controversial and interesting topic. It's treating all the new mantra. I invite Dr. Vivek Anand Saraswat, Professor and Head, Mahatma Gandhi University of Medical Sciences, Jaipur, India. Sir.
Good morning. Thank you, Anil, Ashish, and Praveen. I must say the AAP in Gangaram is doing much better than AAP in Delhi and Punjab. So my topic is going to take up this issue of should treating all be the new mantra for hepatitis B. Now, why are we talking about treating all today? Let me take you back to this, the global health sector strategy goals that were enunciated in the World Health Assembly in 2015, which targeted a 95% reduction in HBV incidence and 65% reduction in mortality by 2030 compared with the 2015 baseline, and the absolute elimination targets of an HBV incidence being reduced to 0.1%, which would be from 2.2 to less than 0.5 million new cases in newborns, and HBV mortality of less than 4 by 100,000, which is an extremely tough target to meet. And today, where are we? If we look at what is happening from 2015 onwards, the curve is downwards, but we are still very far from reaching the defined goals. There was a lull during the COVID time when there was a setback. Now things are picking up. And this year in 2024, WHO has enunciated expanded guidelines for hepatitis B. What have we been doing all these years? If you look at the natural history of hepatitis B, once an infection becomes chronic, which depends on the age of acquiring the infection, hepatitis B goes through various phases from phase 1 to phase 5 as shown here, with the DNA and the ALT level fluctuating as per this cartoon and the viral markers changing and the viral load changing as shown here. And as we all know, the optimum timing of treatment is in phase 2 and phase 4, that is the phases of immune clearance and reactivation. Whereas in phase 1 and 3, the conventional understanding has been that we do not treat these patients, which means that only 1 in 5 people who are HBsAg positive actually are eligible for treatment according to the existing guidelines. So the expanded guidelines which the World Health Organization has come out with for chronic hepatitis B are of various categories. What they are saying that we should be treating all HBsAg positive who have either F2 fibrosis or cirrhosis based on liver stiffness assessment as shown here, regardless of the DNA, ALT, and HBE antigen status. This is one category. By and large, this includes those we are treating already, phase 2, phase 4, but it also includes patients who are in the gray zone of phase 3, which I'll come to in the subsequent slides. Then special categories, those with co-infections, comorbidities, a family history, extrahepatic manifestation. These are also now recommended, regardless of their DNA, ALT, and E antigen status, should be offered treatment, which was part of previous guidelines, but then this is now being emphasized more in the present set of guidelines. Finally, in patients, only those with raised ALT and raised DNA above 2000 IU per ml, treatment is being recommended. And this may include patients in phase 1, phase 3 in the gray zone that I will come to in a little while. In the rare situations, in resource poor areas, even raised ALT has been recommended, but that has its limitations. And using these guidelines, we may hope to increase the number of people who are eligible for treatment to up to 50 to 60% of all surface antigen positive individuals. On the other hand, the Chinese and several workers, including people from India, have been suggesting why not treat all, like we treat in every infection. That is, test all for this triple set of antigens, vaccinate those who are negative, check DNA in those who are positive, and treat all those who are DNA positive, which will include phase 1 and phase 3. And surveillance depending on the stage of liver cancer. The results of the Chinese approach are not really in the public domain as yet, but the recommendation is published and is out. Now, what are the implications of these guidelines? What we know that true immune tolerant people as described here do exist in literature in big numbers, that is persistently normal ALT, E positive, high DNA with minimal inflammation. And these we know that treating them is not necessary because paired biopsies have shown very slow, if any, progression for long periods of time, and that they spontaneously achieve immunoclearance. And even if we were to decide to treat them, we can achieve E antigen seroconversion and even HBV DNA suppression in a small minority only. So they don't need treatment, and treatment, if used, may not work in them. However, there are selected patients, and that has been the reason of controversy lately, where in the immune tolerant phase also one may have to treat, and this depends on the age, E antigen positivity, and some of the criteria that I mentioned earlier: presence of advanced fibrosis, a family history, extrahepatic manifestations, pregnancy, and immunocompromised. And this subset of immune tolerant phase would be about 10 to 20% of all immunotolerant people, and these people would be considered eligible for treatment, although DNA and ALT cutoffs are not well defined in this population. So selected patients, even in the immune tolerant phase, may benefit from treatment, but the large majority may not. Similarly, coming to inactive carriers as defined, as shown here, low DNA, normal ALT, E antigen, as surface antigen levels are low. They may or may not have fibrosis according to various guidelines. And here again, there is controversy. Some guidelines suggest that conditional treatment may be offered in some of these, while others say that they do not need treatment. Why is this confusion? It is because of this phenomenon of gray zone carriers, that is E negative, anti-E positive, low DNA, low ALT. These people are generally considered to be in the inactive carrier phase, but if you look closely, there are subsets, the gray zone 1, 2, or 3, where DNA may be low, but the ALT is high. DNA is on the higher side, but the ALT is low, or both are raised. This is after ruling out confounding factors that are shown in this box here. And this is the algorithm suggesting treatment in this group, which I will not take you through, except to point out that there is clear-cut evidence that in gray zone carriers, there may be benefit from treatment with documented histologic improvement. And interestingly, these patients may form more than half, the gray zones 1, 2, 3 of the inactive carrier group. So as many as 53% of what we call inactive carrier may actually benefit from treatment. So as far as our current knowledge and the currently available treatments go, the vast majority of the true immune tolerant do not need and do not respond to therapy. So probably we should wait for new generation drugs or combinations before offering them treatment, whereas In the inactive carrier, as many as half are likely to benefit from therapy, and in the others, at least you achieve DNA suppression, which you fail to achieve in the immune tolerant population. So there seems to be logic behind the expanded criteria, but results and evidence needs to be put out. Now, why should we treat all? What is the point for offering the logic of treating all? What is said is that if you treat all and achieve sustained viral suppression, you will avoid many things. However, this may not be true for the too immunotolerant people, and that is you avoid progression to end-stage liver disease, cirrhosis, and liver cancer, avoid horizontal transmission, and avoid costs, which is quite significant, of regular monitoring, which most guidelines suggest of those who are not offered treatment. If you were to treat all, you would not be spending money on monitoring them. What are the cons? Well, first of all, before you say treat all, you better find all. What is going to be our strategy and how easy or difficult will it be to find all? I'll just show you. The cost of treating all is not insignificant, and it is not clear who is going to pay for this treating all. Availability, reimbursement, reluctance to use generics are many factors. Finally, and most important is, in an asymptomatic person who has some mild abnormal tests, how can you convince and ensure compliance in all? You may offer them even free treatment, but you may not be able to make them comply, which is a good experience in India in various settings. And emergence of drug resistance may be a problem. Why is finding all such a challenge? According to the latest data, 3.2% of the global population, 254 million chronic HBV are out there, of which 2% of the Indian population, that is 29 million, are present in India, accounting for significant morbidity. And the latest data from the Polaris group as well as from WHO suggests that we have not been able to find more than 13% of these 254 million, and only less than 3% have been linked to treatment. The massive burden of this is in the poorest parts of the globe, where the infrastructure and the expense both are very challenging. Now, what is going to be the cost of treat all? Well, some data, these are recently published data from various parts of the world in the high income groups, USA, Saudi Arabia, Korea, UK. This is the cost of ICER per DALY, that is the incremental cost effectiveness ratio per disability adjusted life year averted, that is saved by treating all. Is you can look at the costs here, and they are extremely high. These are Western data, but they are considered cost effective because they are less than 50% of the per capita income in those parts of the world. However, in countries like the UK and in low income groups like the Gambia, this is just not cost effective, even though the cost may be much lower. In fact, it's worth going through this study from the Gambia, which came out recently. They modeled a cohort of 5,000 young adults with 4 different strategies, which are shown here. But just the last couple of slides. And basically, what they showed was that the cost of the ICER daily that I just mentioned, depending on various strategies, is shown here. And this is just not cost effective for Gambia, where the threshold is as low as $352 and the cost is $5,000. Similarly, the cost for willingness to pay thresholds for an year of life saved and a year of DALY avoided are prohibitively high. However, in countries like India, where the costs of therapy are far lower, testing may also be much lower, this equation and this calculation needs to be done again. But still the question mark remains, will it prove cost effective or not? Finally, we have the risk of drug resistance emerging. TAF and TDF resistance has been already shown to be emerging in the HBV plus HIV population of co-infected people. With no other drugs in the pipeline, one needs to be cautious about this risk happening. And there is a major question mark on the compliance of asymptomatic people. What may happen is stop-start treatment, which will actually result in the emergence of resistance in our part of the world, where government supplies of drugs, 1 month they are there, 1 month they are not there, inevitably means that there are gaps in treatment and nobody is going to buy these medicines on their own in the population. So these things have to be considered before we consider treat all possibilities. So in the end, treat all with CHB. What are the points in favor? It may reduce the risk of progression to end stage in cancer and reduce horizontal transmission, reduce cost of testing as shown here in various categories of individual, and you may have a lower cost of treatment in these people, and we have effective and safe therapy. So we can consider treating all, provided we can ensure compliance in all. However, our case finding has to improve dramatically. 85, 90% of patients are just not been identified as yet, and 97% are not currently being treated. Guideline relaxation may improve that, but by itself will not be sufficient to provide them treatment. And eventually, robust monitoring strategies may have to be implemented for ensuring linkage to treatment and compliance with medications, if that is at all possible, in parts of the world like Africa and India where we need it. I'd like to thank Dr. Anil Anand for his inputs, and thank you all for a patient hearing.
Thank you, Dr. Saraswat, sir. We'll take the questions at the end. May now request Professor Uday C. Ghoshal. He's the President-elect of the Indian Society of Gastroenterology and the Chief Gastroenterologist at Apollo Hospital, Kolkata, to deliver a talk on assessment of intractable gastroparesis.
Thank you. At the outset, I'd like to thank Dr. Arora and his team at Gangaram for giving me this opportunity. These are my conflict of interest. So let us look at the physiology of gastric emptying. Physiology of gastric emptying is quite different for liquid and solid. When we drink liquid, typically the oblique muscle of the stomach contract, like circular as well as longitudinal muscle, and the oblique muscle create a tunnel along the lesser curvature, and that means the liquid should immediately empty out. But it doesn't happen because the fundus relaxes by vagal activity, and that keeps liquid for about 15 to 30 minutes in the stomach, beyond which it empties. On the other hand, look at the solid emptying. When we eat, solid comes to the antrum, obviously. Now the pylorus immediately closes, keeping only 1 to 2 millimeter channel. Now in the antrum, there is a continuing contraction, and this leads to particle formation in the solid. And these particles, when they are 1 to 2 millimeter in size, they empties. And therefore, 90 to 110 minutes is the emptying of the solid. Now, when we are assessing gastroparesis, all patients must undergo an endoscopy. Why? Because the endoscopy has to exclude a mechanical obstruction. Some groups suggested that if you see excess residue in the stomach in the first state, this is suggestive of gastroparesis. Obviously, yes, but has a very poor sensitivity and specificity. It may also show the cause for gastroparesis. So what is the gold standard diagnostic test for gastroparesis? This is gastric emptying for solid and not for liquid. Because when somebody develops vagal neuropathy, their liquid emptying can become faster because the fundus become tonically contracted. Typically, liquid emptying is done by 111 indium, but solid emptying is done by 99 technetium sulfur colloid. And what happens in the West, they will use chicken meat to do that. But in India, many people are vegetarian. So therefore, we have used wheat flour with technetium, even Italy with technetium, and we have standardized this. Now, what is the normal? At 2 hours, more than 60% retention means gastroparesis. And at 4 hours, more than 9% retention means gastroparesis. The another test is electrogastrography. Here, we put 3 electrodes. Now, these 3 electrodes, obviously one of them is a reference electrode. So with 2 electrodes, you are studying the electrical activity of the stomach. Remember one thing, the EGG was developed long time ago, but it does not really come to clinical practice so much because people were doing resting EGG. Nowadays, the current EGG protocol is we do not do resting EGG. We do a resting EGG for 10 minutes, then the fellow give a liquid volume that is called water load satiety test, and then continue to do EGG for subsequent 30 minutes. And in fact, this is one of our paper which is currently under review, in which we showed that resting EGG is not very useful. But when you look at the change in the pattern following intake of the meal, for example, liquid, which is called power change, and power change has greater diagnostic ability than just resting EGG. 3-electrode EGG has a limitation. So therefore, can we do more electrode with more electrode? And this is O'Grady from Netherlands, New Zealand. O'Grady from New Zealand, who developed this system where he used 64 port to map the entire stomach, and this is called gastric allometry. And there are now multiple studies to show gastric allometry may be better than 3-lead EGG, and we are trying to get gastric allometry in our setup. Now, antroduodenal manometry we have done quite in good number, and we published extensively, and this is very useful for assessment of gastroparesis. What it does is, you measure the fasting activity of the stomach, like migratory motor complex shown here. Subsequently, you give a meal, and then you study post-meal activity for another 1.5 hours, and at the end, you give an injection of octreotide to induce M.I.C.E. and see what is happening. Now, currently, antroduodenal manometry is done also like esophageal manometry, like similar to Klaus plot, and there are multiple studies now to show antroduodenal manometry is very effective to show that antral contraction and antroduodenal coordination is defective in many of these gastroparesis patients. Now, ultrasound gastric emptying is another method where you measure the stomach by ultrasound, and subsequently you give liquid, and then over a period of time you see the emptying of that liquid from the stomach to see how the stomach is getting reduced in volume over time. But let me tell you, compared to scintigraphy, this is not a great test because stomach is a very complex organ. Therefore, assessing its volume by ultrasound is not very easy. Now, wireless motility capsule was a technology available in the past. Currently, FDA has disapproved it. Therefore, it will not be used anymore. And in this, what we do is that somebody ingest a capsule, and this is a motility capsule. It gives us pH, it gives us temperature, gives us pressure, and by these, we can actually see when the capsule entered from the stomach to the duodenum. But remember, this emptying is different from liquid emptying and solid emptying. Solid emptying is a nutrient solid which will have a very active process, like as I explained, whereas liquid emptying is also different. This is a foreign body emptying. So truly speaking, it may not translate to exact physiology. And because the FDA approval has been taken away for this, recently a technology which is developed by Australia and UK, we did a study, and probably it will be through in FDA, I don't know, maybe time will tell us. This is called Atmo capsule. Atmo capsule does not give the data on the pressure, but it gives data on the temperature, pH, and also hydrogen gas, by which we can study intraluminal dynamics and emptying like motility capsule. Colon transit study, which is done for colon transit assessment, can also give assessment of gastroparesis. In fact, this is a transit marker that we patented, and now it is under DCGI approval process. Maybe we'll get it very soon. And you can see one of our patients of gastroparesis, when we tried to assess the colonic transit, actually shows all the markers are in the stomach. So therefore, this also can be in future a method to assess gastroparesis, and there is a paper on this in Digestive Disease Science. Many people will use barium to assess gastric emptying. Barium emptying is really a poor way to assess gastric emptying. So I have put this slide here only to say that please do not rely on the data of gastric emptying based on the barium. Etiological investigations are very, very important. Once you have established the diagnosis of gastroparesis, do all the etiological investigations such as blood sugar, serum calcium, TSH, anti-SCL70 for scleroderma, CPK and blood lactate for mitochondrial myopathy and dystrophies, anti-Hu antibody for paraneoplastic condition, rectal biopsy and abdominal fat pad biopsy for amyloid, and anti-TTG for celiac disease, because all of these conditions can present with gastroparesis alone. Only thing is, one of the reasons why gastroparesis was not reported very commonly from this country and maybe many centers in Asia is because of lack of awareness. In SGPGI's 20 years, we compiled the data of 60 patients. And we found those in whom secondary cause for the gastroparesis were there. They were recognized quite early. But when this was primary gastroparesis or pseudo-obstruction, they were not recognized for a long time, and they were mislabeled as IBS, functional dyspepsia, and so on. And in response to that, we did a questionnaire study among gastroenterologists in India, and we framed the questionnaire in such a way to assess their KAP, that is knowledge, attitude, and practice. And we realized the KAP survey clearly depicted that if it is primary gastroparesis, they are not aware. In fact, many will believe that a diabetic have dyspepsia, think of gastroparesis, but a person who is non-diabetic have dyspepsia, don't think about gastroparesis, and therefore our antenna should be up to diagnose this condition early, because outcome is dependent on early diagnosis. Thank you so much.
Thank you, Dr. Ghoshal. The session is open for any questions.
I have two questions, one to Dr. Akash and one to Dr. Saraswat. So, Dr. Akash, once a patient of cirrhosis comes to you for evaluation and he's asymptomatic, you are just evaluating him, and you found a partial portal vein thrombosis and you have ruled out HCC, will you still anticoagulate him because he's asymptomatic, you don't have any procoagulant disorders and all?
So the question is, if a patient has partial portal vein thrombosis, asymptomatic, probably recent, are we going to anticoagulate or not?
We are not sure whether it's recent or not.
Okay. So I think that's the first question, if it's recent. And when we say partial, if you look at Northup's classification, it is basically more than 50% thrombosis is what they call as partial. So if it is more than 50%, by and large, you would think of anticoagulating these patients if they are candidates for transplant. If it is a chronic thrombus, as I showed in my slides, how you can differentiate between acute and chronic, then the benefit in such a patient is limited if they do not have underlying thrombosis or if they're not candidates for transplant.
Okay. One question to Dr. Saraswat. So when deciding on treatment of immune tolerant phase, there's a group of young adolescent or young adults who otherwise may not merit treatment, but these are the people who would be spreading HBV too much because these are young adults. They may be donating blood, they may have multiple sexual partners and all. So can we bring down the cutoff of treatment further?
See, the immune tolerant, the group that I talked about, one is for the patient. Now you're talking not for the patient, but for benefit for others.
Society.
The therapy then has to be effective. Your treatment should be able to make them aviremic. Then there may be a case. But at least what are the available earlier studies do show that only a small proportion after a prolonged period of therapy, about 1 in 4 or 1 in 5 became aviremic. So I guess more work with the more recent generation of the current antivirals to see how effectively you can achieve aviremia. First question, that has to be answered. And then the next question is, prescribing and theoretical reasoning is great. Do you think this young fellow who's going to be up and about all over the time is going to be compliant with therapy for long periods of time for the rest of his life, for the benefit of others? That is the big question mark on how successfully will the treat all mantra work. So that's what I can tell you.
Yeah, Vivek, I have a couple of questions myself. Number one, I'd like to point out one thing that everybody is saying about the cost of monitoring, and by treating, you're actually reducing the cost. I don't see any reason how treating can reduce the cost of monitoring. The cost of monitoring is identical whether you're treating or not treating. You're following them up with a periodic blood test or a liver scan or whatever it is. I would really feel, I'm seeing it repeatedly being presented.
This is in multiple presentations and multiple people who are talking about are mentioning this, that it will reduce the cost of monitoring those not being treated. I think I fully agree with you. I didn't have time in my slides to go into that aspect. If you put a patient on treatment, do you then forget it?
Obviously.
You're not going to monitor him? That just doesn't happen. So you are monitoring for either a phase transition or efficacy, but monitoring is monitoring.
It's not self-limit. It's not a limited period treatment. The second point is, okay, look at it. Now I'm saying, okay, fine, you want to expand the indication. I look at it from the other point of view. If your patient has normal fibroscan, normal LFT, normal, what would be your threshold in terms of age and DNA to initiate treatment?
Normal ALT, normal
fibroscan.
Normal
fibroscan. Platelets normal. LFT normal.
What is the indication to start first?
What
not
level
just
of DNA and what age would you say treatment is justified?
I guess we're talking about the phases. You have to be clear which phase he is
Whatever
in.
the phase.
If he's in the immune tolerant phase, we have already discussed. I think I still believe that only a minority of people in the immune tolerant phase, and those who are probably transiting to a phase 2, but our tools don't allow us, they are the ones who merit treatment. For the others, I think I'll have to wait and be sure that they are either in phase 2, 3, 4. When phase 3, as I said, we can probably consider them for treatment because you do achieve aviremia and that half of them anyway benefit from treatment.
So what level of DNA would you say in phase 3 would justify treatment with a normal LFT and normal fibroscan?
Question not answered. I think what you're saying is that regardless of DNA, ALT and E antigen, if there is F2 fibrosis, you're going to treat them. If there is not, then they may be true immune tolerant and you would not treat them because they are not progressing, not for themselves.
So you're treating for the prevention of progression of liver disease, not the virus.
Or
if the patient doesn't
for
have
community
significant liver
benefits,
disease, you
for
don't.
prevention of spread and horizontal transmission and those things, which again are very, very soft indications, but yes, that's what people talk about.
Sir, we started treating HBV, then initially we thought that immunotolerant patients are not going to respond well and they're going to relapse. Then we changed the direction, we expand the indication, we defined elimination by 2030. But that will happen only in utopian world. In real life scenario, is that going to happen or we have to stick again to prevention of transmission and vaccination?
I think 2030 is too ambitious. We'll be very far from achieving goals by 2030, maybe 2050. And if we have better tools than what we have today, if it's only going to be Entecavir, TAF, TDF, probably even that is going to be a distant goal for the various reasons that we have said. One is the large number, the other is the cost, the third is the issue of compliance. How do you ensure people will comply with treatment when they are not symptomatic? And you may tell them HIV, you tell them other things, but HIV and other conditions, you have an imminent risk of death if you do not get treatment, which is not the case. 30, 40 years later, the person who is completely normal liver with HBV may have a risk of death. So, I mean, that is too abstract for people to get into treatment.
Secondly,
So,
do we need to redefine our immunotolerant? Because at one point we are saying that they are immunotolerant, in other breath we are saying that they are F2 fibrosis. So are they really immunotolerant or we need to redefine?
I think what is true immunotolerant, I tried to show persistently normal ALT, high DNA, normal histology or no fibrosis. They do not benefit from treatment. However, the currently available tools we use are not very sensitive to differentiate between the phase transition from phase 1 to phase 2. And as a result, with the existing markers, many of them get mislabeled as phase 1 immunotolerant when they're actually transiting to immune clearance. So I think that there is a need to refine these tools further rather than simply apply the old available technology.
Thank you. My question is to Dr. Akash. If someone develops or has extension of thrombosis, even a patient is on DOAC, are there any guidelines to change the one DOAC from one to other?
So no, there is no data on this. Absolutely no guidelines, no data. I'm not aware of any literature. Also, I think if, again, this is not evidence-based, if the patient progresses on DOACs, I think we'll look for causes of the progression. One of the common things is antiphospholipid antibody, because they are inherently resistant to DOACs and compliance. And I think these are the patients where you may consider shifting to low molecular heparin, at least for the interim period, and then probably shift to vitamin K antagonists.
Is there any comparison between conventional anticoagulants and DOACs?
Head-to-head trials? No.
Does the DOAC dissolve the thrombus or it prevents the extension of thrombus?
No, they are all exactly the same. They just prevent the extension of thrombus, and if there is a spontaneous recanalization, then they assist in maintaining the recanalization.
So do you see the recanalization of the portal vein, the thrombus completely gone?
Yes, we do see that.
Last question, please. I think we are running short.
Dr. Akash, so you mentioned working up all these patients with cirrhosis, probably yes, for hypercoagulable state. So will this be fallacious? Most of the hypercoagulable, these coagulation markers are synthesized in liver. Number one. Number two, in patients who have recently bled, say 2 weeks back, and now you detect portal vein thrombosis, how do you go about not eradicating the varices and just continuing with the anticoagulation?
So I think both important questions. So the first question, how do you really interpret the thrombophilic states in patients who already have cirrhosis? Because they are likely to have low protein C, and antithrombin 3 levels. So what you look for is if you have a disproportionately low 1 out of the 3. So if you have, let's say, 50, 60% of or 40% of protein C, protein S, but the antithrombin 3 is less than 20%, then you would think that you're dealing with the in children. What we would do is we check the parents. If one of them has the deficiency, or if you have siblings, you can test the siblings. So those are the ancillary methods of confirmation. With regards to the second question, if the patient has had a bleed 15 days ago and now comes with a portal vein thrombosis, these are the patients where they would be treated with band ligation and the anticoagulation would be started in these patients.
And probably many of these patients would be headed for TIPS itself right from the indication of bleeding itself.
So TIPS,
it might be difficult to
so
control
TIPS
bleeding.
Would be as per, absolutely. So the TIPS would be for management of the bleed as per the standard guidelines, but not so that we can start anticoagulation.
Thank you, Dr. Akash, Dr. Saraswat, and Dr. Ghoshal. We had a fantastic discussion.
Thank you all the moderators, the chairperson, and the speakers for the excellent session. So there's an important announcement. The hotel checkout time is 12:30 p.m. So I would request everyone to do the checkouts prior to the set time. So coming on to the next session, it is titled Endoscopic Innovations, Managing Small Bowel Stricture and Sessile Serrated Polyps, and Managing Post-ERCP Pancreatitis also. There will be 3 speakers in this session. May I invite the moderators for the session, Dr. Ram K. Gupta from GR Medical College, Gwalior, Dr. Subhash Bhattarai from Manipal College of Medical Sciences and Teaching, Pokhara, Dr. Hari Prasad Yadav from Medanta Hospital, Indore, Dr. Santan De Sarkar from Kanishka Multi-Speciality Hospital, West Bengal, and Dr. Yogesh Savaria from Rohtak. The chairperson for the session, Dr. Tarun Vashne from Hiralal Super Speciality Hospital, Aligarh, Dr. Pradeep K. Kafle from Tribhuvan University Teaching Hospital, Kathmandu, Dr. Sadiq Akhtar from JN Medical College, Aligarh, Dr. J.S. Bhogal from Metro Hospital and Heart Institute, New Delhi, and Dr. Rahul Pathak from Tribhuvan University Teaching Hospital, Kathmandu.
First speaker of the session, I invite Dr. Ajay Kumar, the Chairman and HOD, BLK Max Institute of Digestive and Liver Diseases, Chairman, Pan Max Gastroenterology and Hepatology, New Delhi. Dr. Ajay Kumar, please.
Thank you, Mr. Chairman, and thank you, Anil, for giving this opportunity back again here. Well, friends, the topic assigned to me is small bowel strictures, endoscopic management. Well, first of all, let's see what is the definition of small bowel stricture. And we have to look at 3 factors. And one is, yes, I got. We have to look at the narrowing of the lumen by about luminal diameter reduction of at least 50%. 2, you have to look at the thickness of the bowel at that particular level, it increases by 25% increase in the thickness. And third is pre-stenotic dilatation. It's roughly about luminal diameter more than 3 centimeter. So to label a small bowel stricture, we need to fulfill these criteria. The number of causes that you are aware of, but in practical sense, we focus when we talk about endoscopic experience is more in the tuberculosis and Crohn's disease, more so in Crohn's rather than tuberculosis. And other than anastomotic and all, there is a good experience, but still the results are not satisfactory. The Crohn's disease, we need to understand that almost with the European and USA data, that over 20 years follow-up, almost 60% will develop stricturing disease. Question is, when do you intervene? I mean, do you intervene the moment you diagnose, the moment, like one has to look at it? The answer is, all symptomatic cases need intervention. That's something which is well accepted. And all those who need intervention are not necessarily the right cases for dilatation. So we need to select the right cases. And here on the right side, if you look at this column, the lesions to be avoided, that they have to be, if they are predominantly inflammatory, which I'll talk briefly following this, then we need to first look at the medicines which can handle the inflammation. Strictures should be around 4 or 5, less than 4 or 5 centimeter. Of course, if there is a suspicion of malignancy, you don't touch them. And if they are angulated strictures, multiple strictures with angulated lumen, or there are luminal abscesses, fistulas, you all avoid. So it's a very important to select the right cases. And the second issue is the inflammatory or fiber optic, which I just briefly mentioned. The question comes, how do you do that? Predominantly inflammatory stricture may respond to steroids or biological therapy. Fibroptic stricture does not respond to the medical treatment. And that's the reason it's important to differentiate. The modalities with us are CT enterography, MR enterography, and ultrasound. The different images, right from ultrasound on the left to the MRI in the last, and these are different. They talk about thickness of the epithelium, stratification on CT scan, and at the same time, enhancement, hyper enhancement of the bowel wall. And if you look at the sensitivity and specificity, go to the last column, all are in the range of around 80 to 90, nothing is perfect. Ultrasound is an evolving technique, but it has inherent disadvantages because of if they're deep in the pelvis, you will not be able to access, or obese people, you may have difficulties. So the message is that none of the current cross-sectional radiological modalities give appropriate quantification of fibrosis. At the same time, it's absolutely necessary to do a cross-sectional imaging before you take up any patient for any endoscopic intervention. I just talked about that all symptomatic strictures will need intervention. Question comes, what about asymptomatic strictures? Asymptomatic strictures, they say the arguments are that 17% of Crohn's strictures can be asymptomatic. And if you look at Beauchamp's theory, that he says no stricture, no fistula. So if you leave even an asymptomatic stricture, and in future, there are high chances of them developing fistula, abscesses, and so on. And that's the reason the message coming from that initial message, there are no data on that we should be dilating asymptomatic stricture, because it can ultimately lead on to acute partial obstruction, could lead on to abscess and fistula when you will not be able to intervene. Success rate is better in these as compared to those who have pre-stenotic dilatation. And as far as the tuberculosis, the common cause with us, but even today, let me reiterate, today we see, even in Indian population, we are seeing more of Crohn's strictures than tuberculosis strictures. But if you look at the tuberculosis, we have no data to show whether we should be touching the asymptomatic strictures. As far as the methods of intervention, balloon dilatation is the best treatment. And here one can keep on talking about, I have already given you the criteria that they have to be less than 4 or 5 centimeters, single ones, and you need to, it should be retrograde or antegrade. I'm not going to the techniques of that. The questions here is, the main question here is how much to dilate. Now, when you go in, the general thing is go about 1 or 2, but put a balloon 1 or 2 millimeter more than what you're seeing at. And once you negotiate that, then you go 3 diameters up. We use a CRE balloon for that, and you should say you start from 12, then you can go up to 15. So, but what is the maximum? Very limited data, but whatever data is, that balloon size of 16 to 18 millimeters seems to provide the best results. So that's the answer to the question, how much to dilate. The success rate, technical success rate is almost 90%. Immediate clinical efficacy is around 80%. But at the same time, that is not the end of it. Rate of dilatation at 2 years is around 70%, and rate of surgery at 24 months around 43%. On an average, if you do the dilatation in the right cases, very important to learn, then you can avoid surgery in almost 60 to 70% of patients in this group. Of course, then there are complications, about 3 to 4%, like any such procedure, bleeding, infection, or perforation, but most of them are managed conservatively. Very limited data on tuberculosis. They develop symptomatic tuberculosis strictures develop in more than 1/3 of patients within 10 years of the disease onset. Endoscopic balloon dilatation is again safe, less invasive, and more effective modality than surgery. The data from PGI Chandigarh of 30, published by Vishal, of 30 patients and showing technical success in 88%, in clinical success in 82%, we definitely require much more data on that. If you look at the systemic review on the double balloon enteroscopy assisted small bowel strictures of mixed etiology, it's a mixed etiology. 13 studies, 310 patients, follow-up of 32 months, long-term success without need for surgery, almost 80%, with acceptable complication rate. The other technique of stricturotomy is like something like what you do in an esophagus, that you do the needle knife therapy, cut the edges of the stricture. You have to select the right patient for that, and then do the dilatation after doing the radial incision and cutting. And it is a promising technique, but it needs further data. It's just to show you the video to show how it is actually done. I think all of you are aware how we do it especially in esophageal strictures, and where you find something like projecting in the lumen, you have a safe area to cut. And once you achieve that, so it gives you a good lumen. The meta-analysis of stricturotomy, 10 studies, 330 patients, 42% patients had IBD. Majority of strictures treated were anastomotic, and they were located at the colorectal anastomosis and gave a technical success of almost 98%. So a very promising technique. And then there is another technique of stricturoplasty, where to keep the lumen open, when you do the stricturotomy, you apply the clips on that, and it recreates the passage. And then the next modality that can be used, which is still evolving, is enteral stents. I must reiterate, very limited data. And here it is not something which you keep forever. You keep it for 1 week and then remove it. And if you look at the technical and clinical success, is around 80 to 90%. And this is associated with migration, fistula formation, and perforation. So friends, this is my last slide to say the take-home messages. The most important is the right selection of patients according to the clinical criteria and imaging findings. And cross-sectional imaging is a must before you take it up. Balloon dilatation is safe and effective in the right selected cases. Recurrence in every second case, but frequently responds to redilatation. It avoids surgery in approximately 75% of cases. Stenting is still experimental and needs further evaluation. Surgery can be restricted to patients where it is contraindicated or there is endoscopy failure, and multidisciplinary team approach is advisable. Thank you very much.
Thank you, sir. We'll take the questions later on. And next, I invite Dr. Sandeep Pal, consultant, Narayana Health Hospital, Kolkata. He'll be speaking on can hybrid EMR obviate the need for ESD in sessile serrated polyp. Dr. Pal, please.
Good afternoon. First of all, I would like to thank Dr. Anil Arora and his team for this invitation. So my topic is, can hybrid ESD/EMR obviate the need of ESD in lateral spreading polyps? So this is a new concept, not much paper is there. So EMR, the technique which we do day in and day out, that was described first in the 1990s in Japan. And in 2000s, the concept of ESD came. So later on, like when it comes to endoscopic resection, ensuring complete lesion removal can be a challenge. Now there is this new concept, the hybrid ESD-EMR technique, which can be a game changer. So with larger polyps, the conventional methods like ESD or EMR can be problematic, especially with flat, slippery lesions. It's common to only capture a portion or experience slippage. So en bloc resection for lesions more than 2 centimeters is difficult to achieve with EMR, and the resection is usually conducted in a piecemeal fashion, but in that the histological evaluation is imprecise and has a higher local recurrence rate. So ESD can achieve higher en bloc and complete resection rates, but it's time consuming and is challenging technically. So this concept of hybrid ESD has come. It is a modified technique that has been developed to overcome these problems. And hybrid ESD, it combines the advantages of EMR and ESD, and we use a snare here to cut the lesion. So hybrid ESD can also be used as a rescue method for difficult cases. When you have started an ESD and you get stuck, sometimes we do this hybrid ESD also. So it can be, there are two methods which have been described. One is pre-cut EMR. Pre-cut EMR is just you make some incisions around the lesion without proper dissection. And that method is called pre-cut EMR. And hybrid ESD is defined as the technique in which the submucosal layer is consistently dissected and snared after the partial ESD procedure. So this is the procedure step by step. First we create a submucosal cushion using injection, then use a knife to make a circumferential incision around the lesion, and then achieve dissection using EMR to complete the removal. So it enhances the R0 resection of the lesion's lateral aspect. If executed correctly, it secures a full vertical resection also, and it can be used in various lesions like lipomas and tumors. So a recurrence risk with en bloc resection is significantly lower than that with piecemeal resection. And in a study of around 137 lesions by Okamoto et al., 27 lesions where planned ESD was switched to hybrid technique later on. The en bloc resection rate fell from 94% to 66%. So in another study by Yamaguchi et al. Published in Clinical Endoscopy, he described three methods: rescue hybrid ESD, standard hybrid ESD, and the conventional ESD. So the problem with these methods is the problems with rescue and the standard hybrid ESD is that the en bloc resection rates are very low. Like if we do a rescue hybrid ESD, the en bloc resection rate is around 48%, whereas with hybrid it is 78%, and with the conventional ESD, you can achieve a 97% complete resection, en bloc resection. And in hybrid ESD, it is important to trim and dissect the submucosal layer as much as possible, allowing proper snaring, and closure should occur without significant distortion of the lesion surface. Because capturing too large portion of the submucosa can deform, there can be a risk to the injury to the muscularis propria. It can also lead to fragmentation of the lesion. So what are the indications? When do you think of doing hybrid ESD or rescue ESD in lesions which have got severe fibrosis, or where the procedure time is very prolonged, when during ESD perforations have occurred, or if there is massive bleeding, or if the patient has become unstable? We want to finish up, and because with hybrid ESD, the procedure time is less. So this is the procedure. So this is a lesion. So first we inject around the lesion, and there are two procedures you can do: hybrid EMR or hybrid ESD. Hybrid EMR is just without proper dissection. We just put two incisions and apply the snare to dissect the lesion. Whereas in hybrid ESD, you do a proper dissection and then resect the lesion. This can again be standard hybrid ESD, where you plan priorly to do the hybrid ESD, and sometimes when you are stuck, you do hybrid ESD. We do many a times, we do this, which is known as the rescue hybrid ESD. So this is the, I'll show you two videos of how you do it. So this is a laterally spreading lesion in the colon. So the usual, we do an injection first, then with the dual knife, or we make a circumferential incision around the lesion. So after making a circumferential incision around the lesion, try to dissect as much as possible so that when we apply the snare, a minimum tissue is left in the submucosa, because that leads to complete removal without any chance of piecemeal resection. So then we apply the snare, and this is how the snare is applied. Then we apply the snare, and then we cut the lesion. The only thing is the size. So if the size is very big, and if we don't do proper resection, then there are chances of piecemeal resection, which we don't want. So as much as possible, dissection should be done, and then the snare should be applied. So now I have to, because there are not very much data available about this technique, there are a few studies which I would like to show. Like this is a study of hybrid ESD. It's an alternative resection modality for large laterally spreading tumors in the cecum. As we know, doing conventional ESD in cecum can be challenging. So in this study, there are very less number of patients, 27 patients underwent conventional ESD and 35 hybrid ESD. And the results, if you see, the procedure time was significantly lower in the group which underwent hybrid ESD, and the en bloc resection as well as the complications were same in both the groups. Similarly, another study where this hybrid ESD was done for rectal neuroendocrine tumors. Here also they have shown that the procedure time was significantly lower in the group which underwent hybrid ESD, and the rest of the things like en bloc resection and the complications were comparable in both the groups. Next, coming on to the third study, this was a hybrid comparison of, again, hybrid and conventional ESD for early gastric neoplasms. This was a multi-center randomized controlled trial. Here there was comparison between both the techniques, and here what we see the result, the procedure time was significantly lower in the group which underwent hybrid ESD, and the complete resection rate and the adverse events were again similar in both the groups. This was again similar study. I will skip this. The results were same. And this is a systemic review and meta-analysis of upper GI lesions, gastric lesion, which again showed the same thing. The procedure time was significantly shorter for hybrid ESD, whereas the en bloc resection rate, here the meta-analysis had shown that the en bloc resection rate was better with conventional ESD, whereas the complication rates were same in both the groups. Similarly, there was another meta-analysis for the lower GI lesions, the colorectal lesions. This is a large, around 751 patient. Average lesion size was around 3 centimeter. Here also they showed that the procedure duration was much shorter in hybrid ESD, but again en bloc resection was better with conventional ESD, but the complication rates were same. So my take-home messages from this topic is the hybrid ESD EMR endoscopic resection technique marks a significant stride forward in the realm of endoscopy, promising a safer and more efficient method for healthcare professions. And hybrid ESD is faster and less technically demanding than the conventional approach. However, en bloc resection can be lower in hybrid ESD, but it is an optimal strategy for endoscopists who are still on the learning curve of submucosal dissection. And rescue hybrid ESD for difficult or complicated cases is useful for avoiding surgery. So coming to the question, my topic, can hybrid ESD or EMR replace ESD, conventional ESD? Yes, definitely yes, for smaller lesions. How small? These studies have shown up to 3 centimeter. And hybrid ESD has a lower en bloc resection rate for large lesions, and hybrid ESD is preferable in patients, in lesions which have poor accessibility, poor visualization, and which has got a submucosal fibrosis. Thank you.
Thank you, Dr. Kar. Now I invite Dr. Manu Tandon, known to everyone, from AIG Hyderabad. Manu sir. Will be speaking on management of post. Manu sir will be speaking on management of post-ARCP pancreatitis.
Yeah, I won't actually call it management. Prevention may be the better word. Thank you, Anil, Praveen, Ashish, and the rest of the team for this privilege. Since we have 10 minutes, this is a topic none of us would like to face in clinical practice. We have just 10 minutes. What I'm going to do is tell a statement, see what is the evidence, just 1 or 2 studies, and what is the consensus guideline. So we'll begin with defining post-ERCP, I have purposely put Peter Cotton's classification because all of us follow the new Atlanta and know mild, moderate, and severe. Many years, 2012 is the modified one. 20 years before that, this was put forward by Dr. Peter Cotton. Less than 3 days, no intervention, between 3 and 10 days, or more than 10 days with intervention or death, mild, moderate, and severe. And how do you define? New onset pain with a threefold rise. And this is the pyramid which shows that almost every amylase itself is not the criteria for diagnosing PEP. Everyone almost universally will have hyperamylemia, and only a few percentage of them will go to develop acute pancreatitis, and even fewer severe pancreatitis. What about our incidence? This is 20 years ago. The incidence 10% overall and not changed much. This is a very new study. In normal risk population or overall, it's 10%. In high risk, it is 15%. I personally feel this is a little higher than what we face, but then we have not published our data, so we accept this. So there's been no real change in the overall incidence of pancreatitis. And based on this data, the American Society, their guidelines both from European and American, I'm quoting the American more because they have come in 2023, just last year. So we'll take evidence from the newer guidelines that have come. So what can we do to prevent? Select the patient, pre-procedure and peri-procedure. This is what all of you need to know, especially the youngsters who are beginning to practice ERCP in a big way. This chart is known to everyone. It's a busy slide. We know the factors that are patient-related and procedure-related, definite and risk. I am not going over it, but tell you very briefly, if you have a female with a low bilirubin, with SOD, with a difficult cannulation, you have a 40% chance of developing pancreatitis. Martin Freeman's article, NEJM 96, I think made us all aware that this condition is there and is dangerous. So how do we go about stopping this? Select your patient properly. I didn't go through that. Again, I told you for lack of time. What do you do pre-procedurally? Two things. First is rectal indomethacin, which this classical study, Joe Almunzer from Peter Cotton's area, Charleston, published this famous study in NEJM, where he quoted that following 100 milligrams of rectal indomethacin. Mind you, rectal, and we've asked this question and there's no satisfactory answer from the author himself. Why rectal? Why not IV? Why not IM? He says absorption is better, and I'll leave it at that because I personally asked him this question. The ERCP rate is much better, the severe ERCP even lesser. It is a must. And subsequent studies or studies prior to that also showed that all of them favor NSAIDs. Question asked is, we don't have rectal indomethacin. This is a study which showed that if you don't have rectal indomethacin, any of these compounds can be used, and this is the percentage that was being used in the various studies. Again, the forest plot, post-ERCP, meta-analysis failing. Oh, sorry, I'm going back. So the universal recommendation is everyone today, the big Chinese studies, 4,000 patients should receive rectal indomethacin. Study, this was the guideline earlier and the guideline today. We follow it religiously unless this is just a stent removal for any procedure done, cut or placement. We use rectal 2 tablets, 100 milligram, same from the European guidelines also. Hydration is the next big topic. Now there may be a debate here because Professor Medira's article, that waterfall study, showed that aggressive hydration is harmful in established acute pancreatitis. There was no study in prevention of PEP. I am giving the data which is for prevention of PEP. There's no study in established, for aggressive hydration in prevention of PEP. So this is aggressive hydration, 3 ml load followed by the standard bolus. Standard hydration, there is no loading, 1.5 ml per kg, peri-procedural 2 hours either side of the procedure. And different studies, again from the guidelines, showing that it achieves better results as compared to no hydration or moderate hydration. This is the latest 2023. So we did a study. This was a multi-center study with John Hopkins, and we found out for our population roughly about 1500 ml of ringer lactate of the solutions we preferred ringer lactate did a good job in preventing pancreatitis. The recommendation, of course, is that use hydration in the peri-procedural period. The next important thing is stenting. Pancreatic stenting, one of the earliest studies was from Tarnowski, showing a wonderful response, prophylactic PD stenting, and subsequent studies showing all of them favor prophylactic PD stenting whenever there is a problem. And the same has continued till today. And what do we do at our institute? We put a small stent in anyone who's at high risk. We'll come to that again. We do an X-ray 7 to 14 days. We cut off the inner flap so that it can spontaneously drop off. If it doesn't drop off after 14 days, you may pass an upper GI scope and remove it. Comparisons have been done. Slightly better response rate when pharmacology and PD stenting was combined. And now there's a network meta-analysis comparing all the three, hydration, PD stenting, and NSAID, showing that a combination may help, especially in high-risk patients. What do you do for cannulation? Prefer to use a wire. And wire-guided cannulation is always better. The incidence of PEP is much lesser. And so there is a clear-cut recommendation that prefer wire-guided cannulation over the contrast-guided cannulation. And the same thing is being used, I think, in most of our centers. Manoj is going to talk on the number of attempts at the pancreatic orifice, but very briefly, I'll tell you, the greater the number of attempts, the greater the time that you spend, the higher the risk of pancreatitis if you keep fingering the pancreatic orifice. So minimize both the number of cannulations, time, and this. If your wire is going in, prefer to put a stent inside. Finally, acinerization. Ask your assistant not to inject very strongly. Many prefer to do it themselves. See the difference, the first to the last. In the last slide, the entire PD and the SNI are filled up and the PEP rate is close to 9. In the first one, there's minimal cannulation, less than 1% to 3%. So your assistant is as important as you. So avoid, these are the guidelines, something which I have summarized for what I have told you. Not only you need to be good, you need to have a good assistant also. That is the basic summary. So what is the eventual aim that we are aiming at? A good unit should have a successful cannulation rate between 90 to 95 and a complication rate which is between 5 to 8%. Less than 200 units, we call cases per year, we call them less experienced. You see that the complication rate is higher and the failed cannulation rate is also higher. So experience counts. And this is what will help in PEP. So summarizing, proper selection is very important. Pharmacotherapy, pre-procedural NSAID, half an hour to 1 hour before the procedure. Peri-procedural hydration, prophylactic stenting whenever required. Maintain the hydration adequately. We, in our unit, especially for high-risk patients, start them on IV, put an NSAID, and if possible, put a pancreatic stent also. Remember, prophylaxis is the only cure. There is no cure in PEP. You prevent it, after that, you manage it. If it does still occur, you manage it like any other pancreatitis. So the final two slides, ERCP, Peter Cotton's famous words, most dangerous for people who least require it. And to paraphrase Nike, just don't do it. So unless there is an indication, don't do the procedure. Thank you very much. I have missed that slide, but I'd like to invite all of you 10 days from now AIG Live, Hyderabad, 19 to 21st. All of you are welcome. The champions are sitting. They will be performing the cases 10 days from now at Hyderabad. Thank you very much.
Thank you, Dr. Manu Tandon, sir. And all the three lectures were very good. And, as I am instructed by organizers to skip the question and answer session. Thank you, everyone.
Thank you all the speakers, moderators and chairpersons for this insightful session. Moving on, our next session is From Myotomy to Fistulas, Settling Debates and Advancing Endoscopic Surgery. For this, as moderators, I would like to invite on the stage Dr. Shrikant Mukevar, Midas Multispecialty Hospital, Nagpur, Dr. Amit Sachan, Bareilly, Dr. Monty Bhagat, Khetarpal Hospital, New Delhi, and Dr. Bipin Shrestha, Nepal Police Hospital, Kathmandu. And to chair the session, I would like to invite on the stage Dr. Anil Rastogi, Satyam Gastro Center, Meerut, Dr. Ravikant Kumar, Medanta Hospital, Patna, Dr. Ankush Bansal, Joshi Hospital, Jalandhar, Dr. Anuj Parajuli, Hams Hospital, Kathmandu, and Dr. Elena Basnet, Kathmandu Model Hospital, Kathmandu.
Well, welcome to the pre-lunch session. At the outset, on behalf of moderators and chairpersons, it's a great opportunity for us. Thanks to Anil and his team for inviting us. I think without wasting time, I would like to invite the first speaker, Short versus Long Myotomy in Poem. The first lecture will be endoscopic luminal surgery. Who should step it for it? Dr. Surinder Singh Rana. Surinder Singh, who doesn't know Surinder Singh? He is one of the expert endoscopists, including have a lot of knowledge about pancreatic diseases from PGI. Thank you.
Thank you, sir. At the outset, I would like to thank Dr. Anil, Dr. Ashish, and Dr. Praveen, and the organizing team for this opportunity, and also giving me a challenging topic. Certainly from an academician, I have been given an administrative role to say that who should do an endoscopic surgery, and that to a person who has very little experience in endoscopic surgery, mainly in pancreatology. But then looking at this question, it is a simple question. The one who is adequately trained should be doing the procedure. So why there should be a debate or a talk on this question? But then these procedures are the ones which require high level of training. They are time consuming, both from the learning perspective as well as requiring the skills which are to be maintained. This requires an adequate number of procedures to be done regularly. And then they have a potential to cause significant and serious complications. So with this background, this is obvious that who should not be doing it. The one who is time challenged, who doesn't have a time to do the procedure. And this is quite important. I always say not for faint-hearted, because higher complication rates, and we should be willing to accept it. Most of the gastroenterologists are a little less willing to accept complications happening in a procedure, which surgeons do accept that it's a part and parcel of the trade. Not for uncommitted, the one who is not committed should not be performing, and not for untrained. And then finally, not for endoscopists without expert surgical and interventional radiological support, because that's must when you have complications. So looking at the other way, it should be done by experts who have time, patience, skill, and support system in place. So that's a one-line answer to this question, that who should be doing it. But I'll little go into the evidence also to say that who all should be doing it and what are the pros and cons of getting into this trade. It's more of surgical skills, less of endoscopic skills. So we as a gastroenterologist are trained on endoscopy, less of surgery. There are narrow confines of intraluminal surgery. It requires more experience, more expertise. Angled instrumentations for which we are not so tuned as a gastroenterologist. And then there are relatively uncommon indications limiting opportunity to practice, especially at low volume centers. And these technologies have developed once there is a talk about cutting healthcare budget. So you all need to be prepared looking at the financial aspects of getting into this trade. So who should be doing this procedure and how it should be taught are the questions which are to be debated. In next few couple slides, I'll just go through them. Now, it's a competitive world. We all are in a competitive world, and then, it's very difficult to preach what you should do, what you should not do, because ultimately it boils down to surviving in competition. It is competitive healthcare and a complex environment, and it is not uncommon. We have seen even general practitioners doing endoscopy. So you want to develop additional competence in evolving and technologically advanced areas of gastroenterology. So that will probably enhance your value provider. So what I'll go through is I'll talk about my personal experience and whatever is published to tell that how should we going about this question. First and foremost is learning experience. We all know about when you learn a new procedure, your performance tends to improve with time. With more procedures, you tend to improve. This is what is known as a learning experience. And the more complex the procedures, you will have a more gradual learning curve. That means you will require more time to get an expertise in this procedure. I'll just take up this one study about ESD. You just look at the experience and the outcomes. So in this study, the authors divided the experience of the operators into blocks of 50 cases each. So your N block resection increases from 76% to 98%. That means after 250 cases, you have reached that level of expertise. R0 resection, 45% to more than 95% after block 8. So it requires more number of cases to be done to have an R0 resection. And then the resection speed, again, it varies with the number of procedures and the organ where we are doing the procedure. So all these things require investment in time. Then other problems are there is a variability in preliminary training of an endoscopist. A person who is an experienced endoscopist will learn the procedure much more quickly than a person who has just finished his training in gastroenterology. Then whether you are getting trained with or without mentoring, it is a longer learning curve. It requires more time. And then if you are practicing in low volume centers, again, the learning times increases. It's very difficult for you to maintain the skills. So who should go for it is the one who has got a good therapeutic endoscopic skills. So once you have finished your gastroenterology training and you are into therapeutic endoscopy, you would be able to judge your endoscopy skills. Then once you have good skills, you need to have time to learn. If you are busy in practice, you can't spare time. It's very difficult for you to learn these procedures. And then finally, you should have sufficient number of cases, one, at the center where you are getting trained, and secondly, at your own center, so that whatever you have learned, you are able to maintain that expertise. Now, this differs in academic and private settings. In academic settings, your time is divided between patient care, teaching, research, and administrative duties. Workloads can be demanding, especially if you are involved in research. And then what happens is most of us in academics subspecialize and become an expert in particular area. And in that setting, it is not possible to become master of everything. So if you want to pursue a career in endoscopic surgery, you have to be pursuing only endoscopic surgery and not doing pancreatology also or endoscopic ultrasound also. So you have to, expertise in one field in academic. But in what happens in private practice, you are more focused on clinical care and procedures. Primarily focuses on clinical skills and building the patient base. And the practice has to provide for its running cost and overhead charges and is a balance of productivity versus expenditure. But in private, the number of procedures are limited and most practices and hospitals don't want to invest in equipment which are money losing and time consuming. For example, you have a 3-hour slot of doing a procedure. It will be more judicious financially to do more endoscopy and colonoscopies than doing a single endoscopic surgery. So here, the question arises of financial viability, number of cases, which are probably possible only in big corporate hospitals. Solo practice, it is a little difficult. If you want to do these procedures in solo practice, you really have to love to do these procedures. Ultimately, there is no financial gain. There is also risk of financial litigations. And since you are in a solo practice, you are more likely to lose these litigations. And gratification probably only comes from being able to do these procedures and probably recognition by your peers. You have to understand the time spent in advanced procedure is quite substantial and it generates less income than the standard procedures. So here it's a personal choice. If you are willing to take these risks, you can do these procedures. Then finally, the question is there an employment market? We don't have any studies from India, but this was a study published in US where they showed that patients who have been trained in advanced procedures 46% respondents were found to find finding it difficult to get a job, and almost 80% felt that job was saturated, and most responded that the market was saturated in both academic as well as private practice, and inability to find an academic position for nearly 6 months happened in majority of respondents, which ultimately led them to working in community practice where you have insufficient time and insignificant trainees to do these procedures. When you have a multi-speciality private practice in suburban environment, you are more likely to do general gastroenterology rather than advanced procedures. And we have to understand that advanced procedure does not necessarily translate into higher income. And in many of these hospitals, the income is based upon the number of patients you see or number of procedures you do. And then the malpractices and liability insurance premiums are other issues with these advanced procedures. And that's not all. This is a study published in American Journal of Gastroenterology, which showed that the people who do advanced procedures are having increased level of stress and burnout. So that's again the flip side of doing these procedures. So these are the last two slides. When should you step in? The answer is yes, if you love challenge, happen to either not mind the decreased income or be in professional situation in which your income is not affected by the kind of procedures you perform. If you are in academic field, you are interested in this field, then you are involved in research, then you should get into this because this will help in development of newer procedures. If you are in a single specialty group practice, you probably might be adding a valuable resource to your practice. But if you are preoccupied with the generation of income from your work, if you do not want to be involved in complex procedures, if you are concerned with possible increase in liability, and if your research interest is not endoscopic surgery, then you should not be venturing into this field. So finally, to summarize, the things which you need to consider is sufficient time, adequate training, proper setting, ability to withstand the stress, and should be prepared that it compromises with the quality of life. So to conclude, when there are real financial implications and employment restrictions, endoscopic luminal surgery remains unique and rapidly progressing field. It enables performance of satisfying, exciting, and rewarding procedures and techniques that push the boundary how GI disease is managed, and developing additional competence in technology advanced areas will enhance your value as a provider, but it will always not translate into financial benefit. So to conclude, we should not be getting into a rat race. We should choose to pursue what we like the best and we are best at. Thank you so much.
Thank you, sir, Dr. Surinder Rana, for that very insightful and soul-searching talk. Next, I have great pleasure in inviting Dr. Praveer Rai, who is professor and head at the SGPGI, to speak on short versus long myotomy in POEM.
Very good morning. I'd like to thank Dr. Anil, Dr. Ashish, and Praveen for this wonderful opportunity. So I'll be talking about short versus long myotomy in POEM. Is the debate settled? So POEM was introduced around 10 years ago by M.I.C.E. et al., published in Endoscopy 2010, and it's now the standard of treatment for eclasia with comparable efficacy to surgery. And since the original description of the POEM technique, it has very few substantial modifications. The length of myotomy in the initial study, which was done by M.I.C.E., was 8 centimeters, out of which esophageal myotomy was 6 centimeters. Subsequent study described more or less similar length of myotomy. So this was the first paper by M.I.C.E., and if you read this paper, the initial 7 cases that he did between 2008 to 2009, if you see the length of myotomy in the initial 7 cases was only 4 centimeter, that is esophageal myotomy, while the length of gastric myotomy was 1 centimeter. However, he changed this technique after 7 cases, that is in 8 to 17 cases, he changed his technique where the gastric myotomy length was increased to 2 centimeters, whereas esophageal length was doubled to 8 centimeter rather than 4 centimeter. So what they recommended is that at least 7 centimeters of esophageal myotomy is required for a successful POEM procedure. This was by M.I.C.E. 2010. So short and long myotomy have been defined variably and arbitrarily, but not scientifically. During Heller's myotomy, which has been the standard of care, the recommended length of myotomy has varied between 4 to 8 centimeters of the esophagus and 0.5 to 2 centimeters on the stomach. Symptomatic improvement and LES pressures have been found to be similar when the myotomy is within this range. In eclasia type 1 and type 2, the non-relaxing LES represents the main hurdle to the food progression. So the problem is primarily at the LES. And if you see the LES, it is just 4 to 5 centimeters across the OG junction. This was a landmark study by Mittal et al. 1997. And if you see this, the anatomy of the esophageal sphincter, primarily the lower esophageal sphincter is constituted by the circular muscles here, the crura part of the diaphragm, the phrenicoesophageal ligament, and this whole complex is around 4 to 5 centimeter, which is the primary focus of cutting while you're performing the POEM procedure. So what's the rationale for this short myotomy? So although the length of gastric myotomy has been shown to impact clinical success after surgical myotomy, the same is not true for esophageal myotomy. And recent studies have challenged this dogma of long esophageal myotomies. Eclasia, as you know, is primarily, the problem is at the LES, and the results, even with pneumatic dilatation, which is targeting primarily the sphincter, were decent enough. So it is believed that eclasia may have a satisfactory outcome with shorter myotomy, which only focused on the forced LES relaxation of the LES. So standard POEM, you do a length of around 7 to 8 centimeters, while a short POEM, which again, as I mentioned, is variable in different studies, is around 3 to 4 centimeters. So length of myotomy, again, how to measure. So one needs to understand that when we are doing POEM, it's very difficult to say whether you have done a 4 centimeter or 3 centimeter myotomy, or for that matter, 7 centimeters or 9 centimeters. So it's very important to identify the G junction, which has been, there are standard criteria, the presence of the palisade vessels, the presence of spindle vessels, and the trans-illumination technique, that is the two-scope technique, which is considered to be the best to identify the G junction, which is very, very important. And then you use the marks on the scopes to measure the distance, primarily from the incisors. So let's see what the studies are. So this is, till date, we have 3 randomized controlled trial. This is till 2022. 3 randomized controlled trial and 2 retrospective studies. If you see this, the length of myotomy in the short group was less than or equal to 3, while in the longer, it was 7 or more. So in this systematic review and meta-analysis, 5 studies, 520 patients, no difference between short and long myotomy as far as clinical success, hospital stay, or the reflux. However, the abnormal esophageal acid exposure was less frequent in short myotomy, and the procedure duration obviously was less in patients who underwent short myotomy, which is logical. So the conclusion of the systematic review and meta-analysis was the short myotomy and long myotomy are comparable in terms of clinical success and adverse events. Short myotomy has significantly shorter procedure duration and possibly reduced esophageal acid exposure. Then came this large randomized controlled trial, GUT 2023. If you see, the ICARD score was comparable between the short and long at a period of 6 months, as well as at a period of 2 years. And other parameters, the LES pressure, the diameter of the barium esophagogram was similar at 6 months and 24 months between the short and the long myotomy. So if you see this study, the procedure time was 10 minutes less in patients who underwent short myotomy. However, the length of myotomy that they did in patients with long myotomy was up to 12 centimeters. And the short myotomy was also up to 7 centimeters. So a wide range, 3 to 7 centimeters. And the length of gastric myotomy again varied between 1 to 5 centimeters and 1 to 4 centimeters. So there was no difference observed in post-operative GRD here. There was difference in endoscopic esophagitis at 6 months, but not at 24 months. And the study demonstrated non-inferiority of a shorter cut length of poem as compared with the standard treatment, which saved procedure time. GERD was not reduced according to this particular study in patients with short myectomy. This is a study we recently published. So again, a randomized controlled trial, 27 and 26 in long myectomy group. We again found that there was no difference as in the clinical success as measured by the ICARD score, and no difference in the esophagitis rate among the patients who underwent a short or a long myectomy. The procedure time was significantly less in the group who underwent a short myectomy. So short myectomy is quite consistent with the Surgical Society, who recommend that you should be doing at least 4 centimeters on the distal esophagus and 1 to 2 centimeters below the OG junction. Benefit of shorter myectomy are obvious and clear, the main being the reduction of the operating time. And this reduction in the operating time may help you do other procedures and save upon the cost and the resources. It has been previously demonstrated that the operative time indirectly correlates with the adverse events. You have more or gas-related adverse events if you do a prolonged procedure. These are less. Especially short myectomy may be favored in patients with sigmoid type B esophagus who have undergone prior treatment or the presence of submucosal fibrosis. So to summarize, short myectomy is as effective as long myectomy in type 1 and type 2 eclasia. Short myectomy leads to a lesser procedure time than longer myectomy. Short myectomy may lead to less gastroesophageal reflux than long myectomy, needs further studies. As of now, the debates is settled for this subgroup of patients with type 1 and type 2 eclasia. Thank you.
Thank you, Dr. Prabir, for his wonderful talk. Now I would like to invite next speaker, Dr. Randir Sood, Chairman, Institute of Digestive and Hepato-Biliary Sciences, Medanta University, Gurugram. He will be talking on endoscopic management of GI corporations.
Thank you. First of all, I would like to thank Anil and his team for inviting me here. I have about 10 minutes to finish this talk, so I thought that I will only touch upon the important aspects and not show you too many videos. So GI perforations are full thickness mural defects in the GI wall, which may happen spontaneously because of the inherent disease, or most likely today because of the iatrogenic interventions. And spontaneous are because of inflammation, infections, connective tissue disorders. Many times people who are on steroids and certain medicines which can cause weakening of the connective tissue. One very common is the Boherev syndrome because of severe straining on vomiting and presents a real challenge in management. And iatrogenic, whenever we have air or luminal contents outside the GI tract, while doing a procedure, we know that there's a perforation in the gut wall. And instrumentation during endoscopic and interventional procedure, not only endoscopic, even other interventional procedures can lead to it. The incidence with diagnostic GI endoscopy is to the tune of 0.01 to 0.6%, and EMR, ESD have higher incidence, while ERCP has 0.3 to 0.5%. What is most important is the early diagnosis and multidisciplinary approach in tackling these patients, because that is the key to successful endoscopic management in these patients. So let's talk about the principles. Diagnose them early, preferably on the table or at least less than 24 hours, so that there's least contamination of the extra luminal area with the luminal contents. Always use carbon dioxide insufflation during endoscopy. Today, I don't think people who are doing therapeutic endoscopy have any excuse for not using carbon dioxide insufflation, and not because carbon dioxide is much readily absorbed, almost 160 times faster than the nitrogen, which is the main component of the room air. Third is that divert luminal contents away from the perforation site so that the chance of contamination is minimized. Start antibiotics to prevent sepsis, and antibiotic choice of antibiotics will be according to your guidelines of the institution. Early perforations without contamination are very well treated with primary closure. But if there's a perforation with a leak where the luminal contents have gone out, you not only close it, but you also drain the extraluminal area, be it mediastinum, be it peritoneum, be it extraperitoneal area. Gross contamination sepsis, if it happens, which will often happen if you are the bowel lumen is not very well prepared and the perforation happened, or if you detected the perforation late, then of course you should go for surgery, surgical drainage sooner than later. This is the algorithm for the approach, that if your perforation happens and in all locations of the GI tract, immediately recognition of simple perforation without leak or contamination. These are the best cases for endoscopic closure with either through the scope clips or with the over the scope clips. If there's immediate recognition of a simple perforation with a leak and contamination, you endoscopically close that or over the either through the scope or OTSE and do the external drainage. But if perforation with leak and contamination with features of severe sepsis, then surgical closure with washout and external drainage is must. Esophagogastric locations are a little different because you can approach these areas more effectively. Immediate recognition, large complex perforations without leak and contamination, endoscopic placement of fully covered self-expanding stents are very effective for, and you can also use clips or sutures in this situation because endoscopic suturing device can access esophagus and the stomach. Perforation with leak and contamination without features of severe sepsis, again endoscopic placement of fully covered SEMs held with clips and sutures with external drainage is the ideal method of management. Now, which are the techniques we can use to achieve this primary closure of a perforation? The endoscopic closure aims at to prevent passage of luminal contents into extraluminal space and avoid life-threatening sepsis. That's the basic principle for doing it. And we have got either through the scope, clips, that is TTSE, over the scope clips, endoscopic suturing devices, or fully covered self-expanding metal stents. And the management, which one of these to be used, will depend upon the site of perforation and the presence or absence of contamination of extraluminal spaces. Now, through the scope clips are very popular. We have been using them for decades, and now they have various sizes, various shapes. Various companies are making them. Up to 17 millimeter of the flange size is available, so we can cover large defects very comfortably. And I think most of the gastroenterologists, endoscopists who are dealing with interventions are quite familiar with it. And this is the principle that you have a defect, you try to make a round defect into an elliptical defect. How do you do it? One, you decompress the bowel lumen. Second, you start with the at the apex of the distal part of the perforation. In fact, you start with a normal area just below the perforation and let the perforation become tented, and that makes your job much easier. You have approximated two sides, and the through the scope clips become very effective in in sealing this perforation. There's a very new type of clip which is available today, which is the dual action tissue clip, which has got, but this has a outer catheter has a diameter of 2.8 millimeters, so you will need a therapeutic upper GI endoscope. It has a central post, a blue arm and the gold arm. So what you do is, it's like the twin grasper of the OTSE. You catch one side of the perforation, which is even large, and then bring it after catching and applying the clip, approximate to the other side and apply the clip on the other side. So this is a very effective method of this, treating larger perforation effectively. Another innovative ways that you have where you can easily use one of the EVL bands and take it in with your clip, or you can drop it in the lumen and pick it up with the clip, apply this band at the distal apex, then tent the perforation by fixing this band to the opposite wall, and this will convert a round perforation into an elliptical perforation into a simple, clinch, and you can, cinch, and you can easily close this perforation. A very low cost, very effective method. Through the scope clips are very effective. These are some studies which I've shown you, that 98.3% successful closure in gastric perforations, and this is technical and clinical success rate of 96% and 92% for colonic perforation. And this is a meta-analysis published in 2015 of 17 studies, 350 patients of GI perforations, and 90.2 successful closures. ESG position statement and AGA guidelines recommend TTSC perforation for less than 10 millimeter anywhere in the GI tract and right colon. Availability of larger TTSC and that enable us to treat bigger perforations. Over the scope clips, there are two types available. One is the Ovesco. This has got three types of clip. One is the blunt tip, which is for bleeders, and the short spike and a long spike. Short spike is for the GI lumen elsewhere other than the stomach. Long spike is for the thicker muscle in the stomach. So we choose the clip accordingly, according to the site of perforation. The other is a padlock over the scope clip. Both are very effective and can close perforation up to 3 centimeters. Perforation closed in one step, that's the advantage. You grab deeper tissues and oppose the serosa, reducing the chance of a leak subsequent to the clip application. A systematic review of 468 patients with perforation, clinical success was 85.3%, and failure mostly in more than 2 centimeter defects, and a perforation more than 3 days old. So these are the situations where you may fail, and AGA and ESG both recommend OTSA closure for 10 to 20 millimeter clip. I'll omit the video because of the shortage of time. Fully covered SEMS placement is done whenever in esophagus you find a defect which is more than 2 centimeters or 3 centimeters, or you have failed in opposing both the sides of perforation, attempted a TTSE and you have failed, then you go for fully covered self-expanding metal stents. This diverts the luminal contents, allow healing by secondary intention. Systematic review of 25 studies, 265 patients, 99% technical and 85% clinical success with SEMS. And there's another study, 27 studies, 340 patients, technical and clinical success of 91 and 81%. Stent migration is the major issue which happens in almost 1/3 of the patients, and it can be prevented by fixing devices either through the scope clips or the Ovesco stent fix. And there is one randomized trial where it has shown that migration is 7.7% if you use the Ovesco stent fix versus not using any device to fix the self-expanding stents. This is another device. The problem is approaching all areas of the GI lumen with the endoscopic suturing device. This was the legacy device which required a 2-lumen scope, but now this is the SX endoscopic suturing device which can be used with single lumen scope and is slimmer, and you can actually go up to transverse colon easily with this if you have expertise, and esophagus and stomach and the proximal duodenum can obviously be covered, and 1 to 3 running sutures are needed to cover a defect of 3 to 4 centimeter size, and you can do the suturing in 15 minutes. A meta-analysis shows 98.6% clinical success, and as I told you, accessing these areas are the major disadvantage of this technique because you cannot reach everywhere. Another very useful method is the endovac, that is the endoscopic vacuum-assisted closure. And here there is a very simple thing that you use an open pore polyurethane sponge and attach it to a 14 French Riles tube and apply a high suction of 125 millimeters mercury. In fact, I remember that first time I used it long time back in Gangana was we used the sponge in the packing in the case of Olympus endoscope and attached it to sterilize it and attach to the Riles tube, and that was very effective. And over about there are studies which show that that in 210 patients 90% successful closure can happen but this takes time, about more than 2 to 3 weeks. In esophageal perforation is the most effective. Rectal perforation and sigmoid perforation is also, it has been used. ERCP perforation, I'll just finish in one slide that, as I told you, it's 0.3 to 5.5% incidence. But the biggest problem is that it has a very high mortality. 12% and 26%, if detected late. And Stepford classification is what we use for deciding how we treat it. Stepford 1 is when you have a duodenal perforation, then you use surgery preferably, but now with our people, endoscopists becoming more and more courageous and expert in handling this, we use TTS or OTSE. Stepford 2 to 4 is treated with fully covered SEMS. And in fact, in this study of more than 7,000 ERCPs with 25 type 2 perforations, where it was an NBD drainage of the type 2 to 4, type 2 perforation was compared with fully covered SEMS. Fully covered SEMS was far superior in preventing infection, hospital stay, and need for surgery, and had zero death. So just to, this is my summary slide. If you have a esophageal perforation, less than 10 millimeter, use a through the scope clip. If you have a perforation which is 10 to 30, then use OTSE or endoscopic suturing. More than 3 centimeters, use a fully covered self-expanding stent. Gastric, again, through the scope clips or OTSE or suturing. And of course, some people who are good at it can use loop and clip device using a purse string suture to close large defects in the gastric wall. Duodenal and jejunal, you have, in proximal duodenum, you can use OTSE, but otherwise it is through the scope clips which come in handy. For colon, again, for the rectum and sigmoid, you can use OTSE and suturing, but for the rest of the colon, you have to use through the scope clips. And for ERCP sphincterotomy, beyond step for type 1, you use fully covered SEMS. Thank you very much.
Thank you, Dr. Sood. So this brings us to last session of session 29. The talk will be delivered by Dr. Gaurav Chawla. I invite him. He is a senior consultant gastroenterologist from Kanpur Medical Center, Kanpur. And his talk will be on advances in endoscopic management of GI fistula, EVT, suturing, or glue obliteration. Over to Dr.
So at the outset, I would like to thank Dr. Anil Arora, Dr. Praveen, and Dr. Ashish for this opportunity. So I'll straight away go to the etiologies of GI fistula. Most commonly, surgeries are the most common cause, and then we have Crohn's diseases, various malignancies, radiation, foreign body, sometimes chronic tuberculosis, actinochomyosis, corrosives can cause, or diverticulosis can cause fistulas. And what are the endoscopic options available? We have stent placements, we have clips available, we have cardiac septal occluders. But today we'll be discussing about EVT, if this was held, then endoscopic suturing and tissue sealants. What are their roles in fistula closure? So EVT, also known as EndoVac or EVAC or endoscopic negative pressure therapy. So first was described in 2003 in sepsis control during an anastomotic leach in rectal surgery. Major indications are defects in esophagus, either perforation, leaks, and fistula after anastomosis, mainly bariatric surgery, leaks and fistulas, colorectal anastomotic leaks and fistula, and now anastomotic ischemias also it has been used. So basically there are two types of, if defects is small, if fistula sag is small, less than 10 mm, then intraluminal only you can just put a sponge and then connect it to a pressure of 125, as sir has all told, then it will help. Otherwise, intra-cavity, we have to go explore the cavity, put the sponge inside the cavity, and then do that is all intra-cavity. So various mechanisms are there. It decreases the size of the defect, causes 80% shrinkage in the size of the sponge. It causes micro deformations, release of growth factors. It increases the microvascular density. It decreases, totally dries up the cavity. There will be exudate control will be there. Bacterial infection will be controlled. So all these will lead to the healing, which this came from actually skin plastic surgeons, and wound healing concept is very well, they often use pressure dressing. in which situations we should not be doing that. It is not found to be useful in tracheoesophageal fistulas. Whenever there is a multi-locket fluid collection, we should not use. If there is a complete dehiscence of a surgical anastomosis, then it can be used as a bridging procedure to decrease the infection, and then revision surgery can be done. In GI cutaneous fistula, it will not work because the pressure cannot be maintained adequately. Only important limitation of this procedure, it should not be in close vicinity to a major vessel. Or patient should not be on therapeutic anticoagulants because reports of massive hemorrhage has been happened. That too very less, but that. So procedure basically can be done. Patient should be under GA, ET tube should be placed, and usually a silicone 16 or 18 French NG tube is placed, and then it is through the nose, and then it is brought out through the mouth, and then a sponge is placed. Standard sponge size is 3 to 7 centimeter in length, but we have to assess the cavity, assess the fistulous tract, and then place the sponge according to the customized size, and diameter is 2 to 3 centimeter, and then it is connected to a vacuum therapy unit and a canister. So proper evaluation of the defect, characterization of the fistulous tract, and evaluation of the cavity is very important. Then these sponges are changed every 3 days to 5 days. An assessment of cavity happens, and it should not be kept for more than 7 days because it will be difficult to remove. And if you are finding it difficult, you can instill gentle water and saline installation that will help in the sponge exchange. So it's a slow process. It takes multiple sessions, usually 10 to 20, 30 days it may take for complete healing to happen. So this is the type of, which is commonly used, is open pore polyurethane sponge drain, which is commonly used. So with sutures, they are fixed it like this, and then with rat tooth forceps, they are taken to the, so it might be difficult to cross the pharynx also at times. So new type of OPFD, open pore film drains are there, which may be easy to pass through the tract. So what are the data in acute? All the data are very skimpy. Actually, only case reports are there or small cohort studies are there. So in esophageal perforation, 10 cases the German researchers have done, and they found it did well, but it required hospital stay was prolonged in patients. Patients also required IC, but patient recovered well. So this is a mid-esophageal thoracic defect happened. And then EVAC was used. You can see the black arrow showing the cavity, the EVAC at the white arrow, and that is a drain there. And with subsequent sessions, the cavity has completely healed and patient did well. So they did a comparative retrospective analysis between the EVAC and the stent and surgery. They found the patient on EVT has the minimal hospital mortality compared to surgery or stent. So survival was also maximum compared to surgery or stent in these patients. Then there was a systematic review and meta-analysis comparing EVAC versus endoscopic stenting for esophageal leaks. And they found that successful closure was higher, odds ratio of 5 to 6 times better, and major complications were not there with EVAC therapy compared to stent. So now for bariatric surgery, leaks are happening after them. There are also such small case series of 6 patients, around 90% of them recovered. And in here they use similar therapy, but they may use covered stent also over the sponge, SOS strategy they call it, that helps in the healing of the fistulous tract and cavity. So, but duration of therapy is long, we should remember, and number of endoscopic interventions are high. At each assessment, we have to space the sponge according to the size of the cavity. In colorectal surgeries also, after that, leaks have happened, and they have done a RCT, Dutch multi-center, 8 patients, where they found that if EVAC was started in less than 6 weeks after the event, then 75% chance patient will heal with EVAC therapy, compared to 38% if it is started later. Now coming to endosuturing principles, I think was told. So I will not go into the principles of EVAC therapy. This is a trial of 122 patients where endosuturing was used. Basically, it was used for stent anchorage, fistulas, leaks, and perforations. So these categories, they were, and total of 44% underwent prior therapy, and 97 point was a technical success, and immediate success, clinical success was seen in 80% of the patients. So they found that long-term clinical success was around 78.8%, but follow-up period was 68%. And clinical success was seen in 91.4% for stent anchorages, 93% for perforations, 80% for fistulas, but only 27% in anastomotic leak closure. Now, this was a study, multi-center, 56 patients, where they assessed the safety and efficacy of 50 closure by endoscopic suturing by Mayo Clinic. They found that immediate success was there in 100% of their cases, but problem is that sustained closure was there only in 40% of their patients. So this is how the fistula looks after we do endosuturing. And gastric fistulas have a lower failure-free survival compared to others. Then this was another multi-central trial where they assessed the efficacy and long-term outcomes of full-thickness suturing in chronic fistulas. 23 chronic gastric fistulas were there, and they found that, and predominantly it was tracheoesophageal fistulas, and prior cancer surgery was the most common etiology of fistulas. And 60% had undergone failed endoscopic at fistula prior to endosuturing. And 100% patients were given, our APC was done at the edges. 50% they have to use cliff fixation, and 10% stent placements were the additional endoscopic therapies. So all patients underwent immediate technical success of fistula, but only 5 patients, 25% only were able to maintain that at 3 months. So median follow-up was 19.5%. So they found out that esophageal tracheal fistula they were predisposed to shorter dehiscence-free survival than other fistulas. Now coming to the last part, glue obliteration. So it can be used for all type of refractory GI fistula. It is a feasible and harmless technique. It has a minimal morbidity. So cyanoclate glue, we all know it's a monomer and it polymerizes with the exothermic reaction in contact with weak blood, such as blood. We have N-butyl 2-cyanoclate and 2-octyl cyanoclate. So usually it causes an inflammatory response which causes a granuloma formation and ultimate epithelialization. So it has also been used in foregut fistulas. Very short case reports are there, numbers are really less. So they have used either percutaneous or endoscopic, and mostly they have used cyanoclate, N-butyl 2-cyanoclate. The success was there up to 12 to 18 months success was there, and number of sessions also required is just median number of sessions was 1.2 sessions. They have also used in Hepato-Biliary fistulas. Numbers are really small again because literature is gastrocutaneous fistulas, gastroperitoneal fistulas, gastroduodenal fistulas. And again, they have injected it via ERCP, via endoscopic or percutaneous. So NB2 or lipid oil was used in rectal fistulas also. They have used and they found to be useful. Only important thing is in complex fistulas, it may have higher failure rate. N-butyl did better than octyl cyanoclate. Crohn's fistula and sometimes led to malignancy, which were not responding, may have responded. It should be used in small fistula and used as early as possible. And median disease-free survival was when compared to surgery. So to summarize, I think EVT to be used in sick patient with anastomotic leaks and acute perforations, but we have to, it's a good, effective, novel strategy. 80 to 90% will respond, but it requires multiple sessions, long hospital stay. Endoscoring usually for fistulous tracts, any fistula it can be used, but again recurrence is a problem with endosuturing to tune of 50%. Glue obliteration can be used for any defect which is small, and usually again recurrence rate, and because problem is such like that. Thank you.
Thank you, Dr. Gaurav. I think it was a very interesting session. I have only one question, that if the patient comes, a tube fistula comes late and he has an empyema, would you do the fully covered stent and put the thoracic catheter, or would you do the sponge therapy and treat the infection first and then closure?
Sir, for tracheoesophageal fistula, we will never do evac therapy if it has come late. So in esophagus, only for acute perforations, evac will work. For tracheoesophageal fistula, it has not found, it's actually relative contraindication. And
covered stents has found to be very useful for tracheoesophageal fistula. That will work the best.
I mean, if you have an empyema secondary to...
then we will drain it
maybe,
also. We will drain it also, sir.
I think the principle should be treat the sepsis
Yes,
first
yes, sir.
and then
we will
close
drain,
the
we will
fistula.
drain it and then covered stent. But
Yeah.
EVAC we will not use in this scenario.
Any questions from the chairpersons or the audience? I was told that only couple of questions are allowed for the want of time, you know. Then I think we close this session. Thanks organizers once again for giving us this opportunity.
Thank you all the speakers, chairpersons and moderators for the session. Moving on, the next session is Navigating ERCP Challenges, Hilar Blocks and Pancreatic Cannulation. For this session, I would like to invite on the stage the moderators of the session, Dr. Shiva Prasad, Institute of Gastroenterology, Visakhapatnam, Andhra Pradesh, Dr. Pavan Rawal, Artemis Hospital, Gurugram, Dr. Anil Kumar, near Eves Crossing, Meerut, and Dr. Ghanshyam Thapa, Bir Hospital, Kathmandu. And to chair the session, I would like to invite on the stage Dr. Kamal Lamichhane, Bir Hospital, Kathmandu, Dr. Sanjay Sharma, Synergy Plus Hospital, Agra, Dr. Vivek Bhatia, Indo-Excel Liver Gastro Clinic, New Delhi, and Dr. Atul Jha, Kaman Hospital, Lucknow.
So welcome to the last session before lunch, and we have two talks. One has already been completed by Dr. Manu, and the first talk is by Dr. Nilay Mehta, one of the stalwarts of therapeutic endoscopy in the country. I don't think he needs an introduction. And he will be discussing surgical obstructive jaundice with Hilar blocks, the judicious use of endoscopic interventions. We had an excellent session conducted by Patrick yesterday on management of cholangiocarcinoma, and now we'll have a discussion on the role of endoscopy in this situation.
Thank you, Shiva. Thank you, Dr. Arora, Praveen, and Ashish. Hilar block can be benign, malignant, or sometimes indeterminate when you don't know actually whether it's benign or malignant. We need to have a judicious use of endoscope in this setting because many times it's difficult to differentiate between benign versus malignant. It's a difficult drainage procedure. It's not just some other ERCP procedure. And then there are higher chances of undrained biliary system and cholangitis. So you have to be extremely cautious providing therapy in this setting. Benign biliary strictures could be because of surgical injury, post-liver transplant, or primary sclerosing cholangitis. Before you venture into giving therapy, one has to do MRCP and one has to have a location, length, margin, so as to have roadmap to the stricture management. Without that, we cannot give therapy. And stenting is the therapy for biliary stenting, for benign biliary stricture, except for primary sclerosing cholangitis, where dominant strictures are mainly dilated. If stents are put, they are to be removed early as 3 to 7 days. What about malignant hilar blocks? They can be because of hilar cholangiocarcinoma, gallbladder cancer, hepatocellular carcinoma, or malignant lymph node obstruction. We know it can be hilar 2, 3, 4, and I'm not going to dwell into the details over here. Whenever we have these hilar blocks, the first question is whether it's malignant. Does it need endoscopy or endoscopic drainage? How to ensure adequate drainage? How much liver to be drained? Whether it should be done endoscopically or some other method like percutaneous? Whether we should be putting plastic or metal stent? How many stents? Where to place stents? And what is the role of endoscopy in preoperative setting? Endoscopy diagnosis is done now either by breast cytology, forceps biopsy. Both can be feasible. Combining will increase the yield, and if there is any doubt, you can do a cholangioscopy with or without biopsy. If you are doing cholangioscopy and if there is a hilar block, you may have to do PTBD. You have to be aware because of the high chances of cholangitis. Only 15% of the cases of hilar malignancy are in fact operable by the time they reach to us. And there is no role of surgical palliation in this setting. The first question is how much liver to drain. variety of studies comparing 30 to 50% or more than 50. What is consensus? More than 50% of the liver volume has to be drained so as to achieve good drainage, to have the survival benefit. How to achieve right anterior, right anterior drainage is 35%, right posterior is 30%, left is 35%. But this changes when you have malignancy because some would be hypertrophy, some would be atrophy. If you have bismuth type 2, where confluence is not involved, you can put either in right or left, but right is preferable because there you can achieve more than 50% of the liver volume. Bismuth type 3 with left lobe atrophy, it is better to put right. Avoid left if it is significantly atrophy and put 2 stents into the right. If it is right lobe atrophy, just mere draining left here is okay because most of the times you have left lobe hypertrophy. So right anterior posterior gone, you can put 1 stent, but left gone, we usually put 2 stents, right anterior and right posterior. Plastic or metal? Metals are better than plastic, high rate of successful drainage, high long-term patency, and there are more adverse events with plastic stents. To put 1, 2, put 2 the bilateral stents. This study has shown putting metal stent is beneficial, but putting 2 metal stents is more beneficial as far as clinical success and to reduce the chances of cholangitis. So many studies, at least 7 studies, tells us the same story. A bilateral is better for high functional response, longer recurrence of biliary obstruction, and longer survival. So bilateral is better, especially for 3 and if you are doing it for 4. How do you put 2 stents? Either by stent in stent method, where there is 1 stent and the other stent goes from the previously placed stent, or side by side where there are 2 stents simultaneously or sequentially put. Both have good technical and clinical success, but if you have blockage of the stent revision is better for side by side. Technical tips: if you are putting stent in stent, always put the more difficult, which most of the times is left, and then put the easier side. How do you do stent in stent? So there are special stents available, either large cell where the mesh diameter is higher, or there is nitty Y stent where there is a Y in the middle. So after placing wire, dilating both the ducts, this is a large D cell type which has a large mesh opening which is put in the left duct, and through it another wire is placed taking guide of the previously placed wire, and another stent which goes through the first stent is placed. This is stent in stent technique, as you can see over here. And we try to always keep the longer stent outside the ampulla so as to have good revision if required. What is side by side? As the name suggests, they are put side by side. Nowadays we have 6-friend delivery system which is very effective. Previously we used to put sequential, but nowadays we put simultaneous because the success rate of simultaneous 100% compared to 70%, procedure time is less. Same thing, cannulate. Put 2 wires both in the right and left. We put contrast. We don't put air when we are planning 2 stents. Once it is done, we put simultaneous stents using 6 or less than 6-friend delivery system stents. So both the stents are put right and left, and they are opened up simultaneously. You have to coordinate between the 2 technicians, and as you can see, we always try to keep the stents outside ampulla so that it gets blocked, then revision is better. What does the literature says? There is no difference for technical success or functional success. Numerically, adverse events are more for side by side, but there you have a longer duration to block, that is recurrence biliary obstruction in side by side. So that way side by side is better. If the bile duct diameter is smaller, less than 7, then stent in stent, obviously stent in stent is preferred. This is very important if the angle between the right and left or right anterior and right posterior is more than 104 degree, then side by side is preferred over stents in stent, because the reintervention becomes very difficult in stent in this situation. And sometimes we placed one large cell in left duct and we could not place duct in the stent in the right duct. So that is very important. What about percutaneous versus endoscopic? Percutaneous is better if you have type 4. Definitely, we most of the times don't do ERCP nowadays if type 4, and also in subset of type 3. Sometimes you have to combine EUS and ERCP, or ERCP and PTBD, when you can place only one stent in the right duct, and then you have to place stent in the left duct using EUS. So right duct stent is placed, and we could not place left duct stent. So what we do is, over here is doing an EUS HGS, simple procedure. Puncture the segment 3 duct, as segment 3 duct is going from left to right bottom, and then opacify, and then place, as you can see, the right duct stent over here, and left duct stent is placed by hepatogastrostomy. As you can see here, in the spatial stent is placed 70-30, 70% is covered, 30% is uncovered. Endoscopy role is there for preoperative biliary drainage because it reverses adverse events, given time for comorbidity, and if there is infection, we can correct. Neoadjuvant status, it is must. Preoperative biliary drainage is indicated when there is high bilirubin, longer duration sepsis, or the functional liver remnant is less than 30%. Or if you are planning portovenous embolization for left lobe or whatever lobe hypertrophy, or in the setting of neoadjuvants. It is important to clear the infection, to clarify the anatomy, extent of the tumor, and subsequently reducing the morbidity and mortality. How you do it? By endoscopic biliary stent placement, PTBD or NBD. NBD and PTBD are the preferred modalities over here. Usually biliary stenting has more cholangitis chances. That is what the study says. And we usually do PTBD in this setting because even though it is described to put 2 nasobiliary drainage stent tubes, it's not easy to put 2 NBDs. To summarize, endoscopic therapy is indicated for diagnosis, to confirm malignancy, to treat benign strictures, and to palliate the malignant strictures. Roadmap by CT volumetry and MRCP is mandatory before doing any endoscopic procedure in hilar block. More than 50% of the drainage of the liver has to be done. Avoid draining atrophic segment. You have more chances of cholangitis in this segment. SEMS are preferred. We don't do plastic stent in malignant hilar blocks. Bilateral multiple SEMS are preferred. Sometimes you have to combine US ERCP. PDBD may be a better choice for preoperative biliary drainage and for type 4. Thank you very much.
Thank you, Dr. Nilay, for the insightful talk. Now I invite Dr. Manoj Kumar Sahu. He is the Director and Chief of Gastroenterology, Vedanta Institute of Medical Sciences. He will be delivering a talk on inadvertent repeated pancreatic cannulations. What next? Dr. Manoj.
Respected chairpersons, moderators, seniors, and friends, I'm extremely grateful for this opportunity. We'll be speaking very briefly on inadvertent repeated pancreatic cannulation. What next? A broad body of evidence suggests wire-guided technique is the preferred approach, which was discussed before also. If you see the Cochrane Systemic Review and Meta-Analysis, What they found, greater cannulation success, significantly reduced post-ERCP pancreatitis, less need for precut sphincterotomy, and no increase in other ERCP-related complications in the wire-guided modality. Based on literature, 10 minutes, 5 attempts, and 4 PD cannulations are reasonable parameters. We do have many definitions. Once one of the parameters is exceeded, unlikely that a given technique will succeed. We might move towards a failure. Repeated attempts increases the risk of post-ERCP pancreatitis. All endoscopies must recognize and deal with this difficult situation. These are the various RCTs for defining difficult cannulation. Repeated cannulation of the pancreatic duct without biliary access might lead to increased risk of PEP. Need to consider alternative cannulation strategy. The decision to change the strategy should be made very early, should be made immediately. 2 strategies are preferred, and these may occur in sequence. Both require the eventual placement of the PD stent. Dual wear, as we know, pancreatic wear technique. The second is pancreatic stent placement with cannulation of the bile duct above the stent. If it is not successful, immediately we need to move to needle knife sphincterotomy over the stent and cannulating the bile duct. In some scenarios, some situation, we do transpancreatic sphincterotomy, which I will be discussing subsequently. If the PD is cannulated, we are not able to have biliary access. The dual technique, as the image is there, the one guide wire inside the pancreatic duct, need to put another guide wire and have biliary access just above the guide wire. If this is not working, 2-3 times we tried, then we need to move immediately. We need to put a pancreatic stent and subsequently cannulate the biliary system just above the stent. If this is not successful, immediately we need to move for needle knife sphincterotomy and subsequent cannulation of the bile duct. Dual wear technique. The pancreatic guide wire straighten the distal common bile duct, the S-shaped becomes straight. It stabilizes the papilla, it brings the ampulla close to you, it helps cannulation. So it helps cannulating or accessing the bile duct. A hydrophilic wear is placed into the pancreatic duct up to the distal body. Avoid side branch impaction, the cannulation, the manipulation should be very gentle. After cannulation, deploy pancreatic stent after achieving success, because this is the study, 70% what they found after double guide wire technique. If you are putting a pancreatic stent, that significantly decreases the risk of pancreatitis. So you might think that I have done the cannulation, biliary with therapy is done, why to put a pancreatic stent? We need to put pancreatic stent. If the double guide wire technique does not work after 2 or 3 attempts, need to put a pancreatic stent immediately. Proximal tip of the stent should not go beyond the genu. If you are not able to pass across the guide wire, across the ear, beyond the head also, we need to put a small stent at the head area. If this is not working, need to move to needle knife sphincterotomy and subsequently biliary access. If all fail, we have various options, need to terminate the procedure and repeat the procedure after 48 hours. Or if it's indicated, need to do a biliary intervention immediately on the same day, expertise is there, US intervention, or we need to refer the patient to a high volume tertiary center. Transpancreatic sphincterotomy is also an option if your guide wire is going repeatedly into the pancreatic duct, because this does not require the use of a needle knife. It may be preferred in selected patients. Intradiverticular ampulla, small papilla, narrow orifice, papilla distorted because of various reasons. If you see a cohort study, 369 patients, cannulation was successful with this modality, 87%, and the adverse events are not significantly different compared to other modalities. The same thing, the guide wire in the pancreatic duct, your tip of the sphincter inside the PD, you need to cut the septum towards the biliary opening and need to cannulate. So whatever modality we are doing, whatever modality for biliary access after putting a guide wire multiple times in the PD, we need to put a pancreatic stent. So some questions might come if the PD is completely obstructed. We may not able to put a guide wire there. Stent, no need to put a stent. If there is very low risk for post-ERCP pancreatitis, these are some scenarios the stent need to be divided, not deployed. But whatever may be the procedure, we need to consider putting a pancreatic stent because these are the study which suggests a similar outcome. This is a comparison between two modalities, double guide wire technique and wire guided cannulation after putting a pancreatic stent. This study, similar outcome, similar result as regards to cannulation. So place a short 5 French pancreatic stent, proceed quickly to needle knife sphincterotomy if wide wire guided cannulation above pancreatic stent does not succeed with 1 or 2 attempts. We should not delay for long time. Immediately need to consider NKS. This is a study that wire guided cannulation above the pancreatic stent increases the need for needle knife intervention in difficult biliary cannulation. This is the comparison between double guide wire technique and wire guided cannulation above the pancreatic stent. If you see the result, the good success cannulation is good in the double guide wire technique, but the second modality, they are requiring the needle knife sphincterotomy for biliary access. So the suggestion is first consider a double guide wire technique which is not successful. You try 1 or twice to cannulate above the pancreatic stent. If not successful, immediately need to consider the needle knife sphincterotomy and subsequent biliary access. Comparative efficacy of different methods. This is a very recent systemic review and network meta-analysis, but if you see the quality of evidence is not great. What they suggest, the transpancreatic sphincterotomy scores over other modality. Based on the network model, transpancreatic sphincterotomy and followed by early needle knife technique, we are ranked highest in terms of increasing the success rate of biliary cannulation, but we need to have more data. So these are also various studies comparing various modalities. If you see the biliary success, most of the studies, they didn't find any difference, no significant difference as regards to biliary cannulation success. Peri-procedural rectal NSAID, as we all know, a systemic review meta-analysis, significant reduction of PEP in high-risk patient. No significant difference in renal failure and post-sphincterotomy bleeding should be considered in this group of patients. And these are the various studies which suggest that prophylactic NSAIDs helps prevents PEP. Aggressive hydration, as you also know, significantly reduce the overall risk of PEP. Ringal lactate is better than normal saline. Peri-procedural bolus, subsequently IV infusion. So it's little bit difficult if you are doing procedure in an outpatient. We need further studies, more abbreviated protocols to define the safety and efficacy in this group of patients. Role of combination therapy to prevent PEP. Combination means stent and rectal NSAIDs and hydration. There are 2 small trials comparing NSAIDs alone, NSAID plus stent, but not adequately powered to draw conclusion. Another trial did not show reduced PEP for aggressive hydration combined with NSAID versus NSAID plus hydration. Endoscopies should not use the same approach in all patients. The technique should be tailored to the individual risk profile, also the anatomy, papillary ductal anatomy should be an individualized approach. A broad body suggests wire-guided technique is preferred approach, repeated cannulation to PD. 2 strategies are preferred. First, we need to consider double guide wire technique, twice or thrice Not successful, immediately put a stent and subsequently try to cannulate once or twice. Not successful, immediately we should consider doing a sphincterotomy and trying to cannulate. Transpancreatic sphincterotomy may be considered in selected patients. No good data to dose the comparative efficacy of different methods. Peri-procedure rectal NSAID might benefit this group of patients, should be considered. Combination agent, we need to have good data and study to demonstrate incremental benefits. Thank you.
Thank you, Dr. Manoj. I open the session for questions. I think we just have a couple of minutes before lunch. Yes, Anil.
Excellent talk. You said for pre-op biliary drainage, you always prefer PT-PD.
Yeah, not
Why not plastic stent?
We know that it's a high. So I'm not talking about type 2. I'm talking about type 3 or 4.
Yeah, I'm talking type 2.
Type 2 is fine.
Plastic. Yeah. And secondly, you said you always put in multiple stents. When the aim is to...
type 3.
Right. When the aim is to bring down the jaundice. So even if one is sufficient...
So there was one study which showed that one is sufficient, but subsequently all studies have shown that bilateral or multiple, right and right posterior, are better. You have to drain somehow more than 50%. And most of the times so type 2 is fine, you put one in the right, you are done. Type 2 is not different than the lower block. It's mainly type 3 and type 4. I personally believe that we should not be touching type 4. And many a times our gastroenterology colleague, they just place one plastic stent somewhere, put air and then put one plastic stent and they say they've done the job. And I think it should not be done. So our role, special role comes into type 3. Type 2 is okay. You put one right, it's fine.
And Dr. Manoj, suppose inadvertently, it is not infrequent, to inadvertently enter pancreatic duct, goes in smoothly, there is an upward slope and then it turns like, we hardly ever put in a dye. But once it turns horizontal, we are sure that twice we have entered the pancreatic duct. Then rather than placing stent, you said transpancreatic sphincterotomy is not unsafe. So that means it is safe. Then why not routinely do a transpancreatic sphincterotomy rather than placing in a stent?
Sir, transpancreatic sphincterotomy is to access biliary cannulation. So when you are planning a transpancreatic sphincterotomy, we do not have great evidence that in this scenario we need to do in every patient. If you see European guideline, American guideline, and some suggestion from AIG also, they are not suggesting favoring transpapillary sphincterotomy in every patient when there is difficult cannulation because guide you are inside the PD. If you are doing a transpapillary sphincterotomy in every patient, you do not know how much inside you are cutting. Are you cutting too much of the pancreatic duct? What is the risk of development of post-procedure pancreatitis? So what they are suggesting in few study, if the ampulla is difficult, very small ampulla inside the diverticulum of the orifice is very narrowed, where other modality will be difficult, then you can consider doing a transpapillary sphincterotomy. But one study suggests a better benefit.
Yeah, the premise is that you are going to decrease the pressure at the ampulla, either by putting it in stent, which serves the same purpose, or why not do a sphincterotomy, which will be 100% decreasing the pressure.
We do not have a comparative study as of now. So,
Dr. Manoj, just one question from my side. If the patient has already received pre-procedural indomethacin and adequate hydration, would it change any of your decisions about the decision to do an intervention after difficult cannulation? Because frankly, the indomethacin and hydration is for the general patients with pancreatitis or who are undergoing ERCP to prevent PEP. But in your case, the cases that you have described, I think it would not matter if you have done this kind of difficult repeated cannulations, you would still require some kind of therapeutic intervention.
If you see good study about indomethacin, now you are considering rectal diclofenac. So indomethacin, what are the evidence we have? So up to 50% it prevent the development of moderate severe post-ERCP
I'm
pancreatitis,
talking of
not
specifically
100%.
in the situations you described, multiple repeated failed cannulations, not long duration of procedures, the initial criteria you gave. Even in those patients, you feel rectal endomethacin and hydration will prevent pancreatitis?
Yes, rectal endomethacin, now the recent American recommendation is coming in any patient. Even though they are low risk patient, you need to consider rectal endomethacin or rectal diclofenac. So, but in our country, we consider rectal diclofenac for high risk patient. So even though you are giving rectal NSAID, giving adequate hydration, but if you see adequate hydration, the studies, recent studies, there are no great data as regards to severe development of severe post-ERCP pancreatitis. So we may decide that suppose I am giving indomethacin, giving adequate hydration, I am having a difficult procedure. So we do not know that with these two modality, the chances of getting post-ERCP pancreatitis is nil. So that is why they are telling you need to consider putting a pancreatic stent. We do not have great data combining everything. What is the benefit?
Last question, please.
To Dr. Nitin. Sir, which you traditionally put any uncovered stents, or sir, sometimes laser cut stents are there? Any time you will prefer that?
So for bilateral
Bilateral
stenting,
hilers.
it's always laser cut most of the times, right? And so stent in stent, not many companies, only Korean companies make it. Like, you know, either Y stent where you have larger mesh in between, or large cell D type, which is means from top to bottom large cells. But side by side, you have to have less than 6 millimeter, which most of the times is laser cut. So you see any company, Korean, American, they all are laser cut. Only disadvantage is you cannot, you know, release and do things afterwards. Like there is no point of no return kind of thing over here.
And left is always first and right.
Most of the times. But whichever is more difficult, sometimes right posterior is more difficult. So you go into right posterior. Left is even straighter than right posterior. So, and then you put one stent in the right posterior and left. So you have to decide what your CT and your MR is showing. You have to know beforehand in which duct you are going to place stents.
Thank you. I think now we'll break for lunch. I'll thank both the speakers for this session and the audience.
Thank you all the speakers, chairpersons and moderators for the session. So now we are taking a break for lunch. And as we are a bit behind schedule, I request you to join us back at 2:40 p.m. The lunch break will be of 30 minutes only. Thank you.
Good afternoon, everyone. We welcome you back from the lunch, starting with the next session, Expanding Endoscopic Ultrasound Horizons, Biliary and Vascular Interventions. May I have the moderators on the stage, please? Dr. Arvind Khurana, sir, Fortis Hospital, Gurgaon. Dr. Rahul Rai, sir, Super Specialty Liver Clinic, Jaipur. Dr. Neeraj G. Joshi, Nepal Medicity Hospital, Kathmandu. Dr. Ajay Khandpal, Ankita Gastrocare, Haldwani. Dr. Mandhir, sir, Gangaram Hospital, New Delhi. Chairpersons for the session, Dr. Neeraj Jain from CARE CHL Hospitals, Indore. Dr. Charu Gupta from Genesis Hospital, Rohtak. Dr. Pukar Thapa, Norvik International Hospital, Kathmandu. And Dr. Rajeshwar Yadav, Koshi Hospital, Biratnagar, Kathmandu. And Dr. Prakash Raj Neupen from National Cancer Hospital, Kathmandu.
Good afternoon, everyone. Now we are going to start the post-lunch sessions, and it is going to be on endoscopic ultrasound. And for the first session, I'm going to invite Dr. Vipul Rathore, who is the director of Department of Gastroenterology at Fortis Hospital, Mulan. And I must tell you, he is one of the persons from whom I learned US in the beginning, and he is the master in US and other therapeutic procedure, not only in Maharashtra, but I will say in Asia. Dr. Vipul, please. And he will be speaking on US guided biliary drainage, when and for whom.
Yeah. Thank you, Dr. Khurana, and respected chairpersons. Thank you, Anil, for having me this afternoon. US guided biliary drainage, I think, I'm sure all of you, it's a very attractive, modality, glamour in endoscopy. So I still remember the ball set rolling in 1996 by Moritz Wiersma. They demonstrated in porcine model in 96. It took almost 5 years to translate to human in 21. Then I discussed with Mark Giovannini, and when we were together in 2000 in France, and I think both of us did almost at the same time the first procedure of EUS guided biliary drainage, and then the rest is history, as we all know. So when do you do an endoscopic ultrasound guided biliary drainage? I think fail ERCP, not because of a bad endoscopist, but because of a bad pathology or a bad anatomy. Altered anatomy, of course, now we see more and more bariatric patients and patients with liver transplants and so many other surgical interventions where you have to probably circumvent, the biliary access, and that's when you can use it. Contraindication for PTC. In fact, I would say PTC is hardly used except for, as Dr. Nile mentioned, in type 3 and type 4 or type 4 bismuth strictures. By and large, we don't use it, but I still use it in a long rendezvous procedure with a post-liver transplant, and it is still useful in some subset of patients. Duodenal obstruction, when you can't be in front of the ampulla. Proliferative tumors, I feel inoperable, and for pure malignant biliary obstruction, palliation. De novo EUS guided biliary drainage. Now, this is a controversial area which I'm going to talk a little bit about. And of course, gallbladder drainage, which is for very, very small subset because of improved anesthesia and ICU settings. We cannot move ahead without mentioning a man who first drained the bile duct endoscopically through a plastic stent, my mentor, Professor Nip Sohendra. And I've been so lucky in the frame of time in my life that Sohendra trained me in ERCP, and Binmoller, who pioneered the hot axios, at that time he was a deputy to Sohendra, and he trained me in EUS. Now, how lucky that would be to be trained by the pioneers of EUS and ERCP in one go. So this is something I would be very grateful to my mentors. And move ahead, what are the things which you'll need for a EUS guided biliary drainage? And these are the list of things. You must have a checklist before you touch a patient like this, because the margin of error in EUS BD is very small. What changed? If you ask me one accessory which changed EUS guided biliary drainage before hot axios came, it was this device, the cystotome. It completely changed our approach, our ease, our success, technical as well as clinical success rates. I would say this is a very important tool you should have, and we should have 6 French, 8.5 French and 10 French, all 3 size if you want to do regularly this work. This is the first case where I still remember in 2001, there was a complete mass, we punctured, and those were the days there was a diagnostic linear scope of Olympus. 7 French stent could be placed, no cystotome. Try and dilate a duodenal wall and a bile duct wall without a cystotome. You'll understand how difficult it is. So that's how we started the journey, and then rest is the history, as we all know, that so many such procedures developed, EUS guided choledochoduodenostomy, a rendezvous procedure, then hepaticogastrostomy, EUS guided choledochogastrostomy, and of course gallbladder drainage. So as I said, the technical steps are like this. You puncture with a 19 gauge, aspirate the bile under fluoroscopy or contrast injection, put a guide wire, and depending on the type of pathology you are looking at, then you decide the procedure. So just to give you a little idea, these are the kind of anatomy which would definitely preclude an approach transpapillary. And what is important, you should have a very good dilated bile duct about this obstruction. So these are proliferative ampullary tumor metastatic are the ideal cases for this kind of an intervention. So what we did was, you will see here, I'll just quickly go through. So it's a dilated bile duct. You should have a huge dilated CBD. Then you can use this technique very, very effectively under color Doppler control. And you can see here that we will puncture with a needle, get a cholangiogram, put a guide wire, and a straightforward. Now the advantage is that we are going away from the primary tumor, and this allows us a longer stent patency. And I think so. I'm very confident about one indication today is proliferative duodenal periampullary tumor, which purely requires palliation. So there are some studies which have shown a very, very good clinical success and technical success in excess of the 85 to 95% range. And I think this is a technique which I personally prefer if I have an option to drain EUS guided, and if there is biliary dilatation, the bile duct dilatation. Of course, now we have even a baby hot axios, which is 1 centimeter with 8 millimeter diameter. Now, if there is a complete obstruction of the duodenal area because of surgical intervention, as Dr. Nila had already mentioned, we would go with a special stents like this with a hepaticogastrostomy. I feel that there are some interesting studies which have come out recently, which has shown that if there is enough dilatation of the IHBR, it is safer to do an antegrade stenting through hepatic route rather than doing a hepaticogastrostomy. So I think we are all evolving in this space, and we still don't have the final answer, and I'm going to talk about it. So you've already seen this procedure. So these are some of the data of clinical success rate is very high of hepaticogastrostomy. But I want to share with you something very important, that if there is a complication in the duodenal, paraduodenal region, they are very difficult to manage, and therefore some experts believe that at least the liver seals the bile leak, and even if something happens, it's easy to manage a peritoneal space rather than retroperitoneal space of duodenum. So there are views about it. Now what has changed? That's what I showed you earlier, a picture of Dr. Binmoller. What I'm going to share with you, not just the technique of EUS guided biliary drainage, but a concept of EUS to be done in every patient who is deemed operable, especially for resection. And here I can show you that this patient had a small lymph node. We took a biopsy in the mediastinum. It turned out to be metastatic adenocarcinoma. And now you need dilatation like this to get a hot axios in space. You know, one-step procedure. And this will allow us immediate deployment. So I personally feel that this kind of procedure, I think, will have a center stage in coming years where its primary tumor is far away. Or gallbladder drainage like this. Just to give you a little idea about the comparative trial. I just came across this trial, and look at the adverse events. 23 trial, ERCP adverse events are 17.1%, 16.5%. I want all of you to pay attention here. Adverse events are high. I don't know why. Who will accept 17% complication rate in ERCP and 16% complication rate in EUS-BD? And therefore, ladies and gentlemen, the learning curve for EUS guided biliary drainage is steep. We say you need 200 gastroscopy, 200 colonoscopy to master these techniques. Tell me, these guys have come out with some study, and they say you need 33 procedure, and to master it you need 100 procedure. How many centers will do 100 EUS guided biliary drainage? So these are some of the questions which we need to answer, and I personally reckon that you need to spend a lot of time before you take up this technique. Now, there are dedicated platforms, only a couple of them as of now. We are still using ERCP accessories. So to conclude, EUS guided biliary drainage has an acceptable alternative when conventional ERCP is unsuccessful because of the anatomy or pathology. Improved PTC, compared to PTC, it is definitely safer, the studies have shown. And I think in malignant biliary obstruction, those two studies have shown that EUS-BD is proven non-inferior and perhaps superior to ERCP. I have my doubts. I want more data on that. I personally would go ahead with a de novo EUS-BD for a proliferative tumor where we know that the stent may get occluded very easily, it's very difficult to go in, I would go straight with EUSBD. I think long-term preceptorship is important, like any advanced procedure. I think what is happening for those EUS guys here, they are de-skilling their ERCP levels. So improve your ERCP skills. Please improve your ERCP. Your cannulation rate should be at least 98 to 99%. What are we talking? So improve your ERCP skills. This is my appeal to all of you. Adverse events should be either comparable to ERCP or should be lower than ERCP for it to stand the test of time. We all need more level 1A evidence in this space. Thank you very much.
Thank you, Dr. Vipul.
Yes.
I do agree with Dr. Vipul regarding the safety. I think success is very important. You should have a 99% success rate. But whenever we do any procedure, we know when we are going to end up with a complication. So when you are not sure, stop it rather than causing a complication. No one knows that this is the area. If I cross, there is going to be complication. So one should know where to stop. Thank you for that nice lecture. We are not taking any questions for a shortage of time.
Thank you.
Thank you, sir. For the next talk, it's by Dr. Malay Sharma. He's Director, Department of Gastroenterology, Ayurveda Hospital, Meerut, and is going to deliver talk on US-guided vascular intervention in GI tract. Thank you, sir.
I'm thankful to Dr. Anil for calling me to this lecture. Vascular intervention is an uncharted territory. And the principles are block the unblocked vessels which are bleeding and unblock. So how to unblock it? This is less common. This is unblocked vessel bleeding. Don't know what is this. Don't know what is this in duodenum. Don't know what is this in stomach fundus. And again, these are the stomach fundus, and the last picture is of the rectum. So once we don't know, we have to know the charted territories, how we are going to assess these vessels. And these are the vessels which can be assessed. Everything, every vessel can be assessed as shown in the picture. But you have to know thy vessels, and you have to see, you have to be able to do the US-guided intervention. And this is one such intervention where we are going transaortic puncture of the needle and get assessed into the node. So the coil and glue injection, yes, again, looks quite simple, but you must know where is the inflow, where is the outflow, what are the pathways of bilateral hypertension, portal hypertension before you decide to do which pathway you are going to inject in, where is the inflow. You must attack the inflow and not the outflow, but to be able to identify where. One broad trick I will tell you, whenever you are doing EUS, the farthest, the lowest, and the vessel closest to spleen is the place where you should inject. Forget what is the inflow, outflow if you cannot identify. So what are the territories uncharted? Here you can do diagnostic intervention. These are the type of intervention. This is a case. We presented with bleed, GI bleed, recurrent pancreatitis. We did EUS, found blood in pancreatic duct, came out as Haemosuccus pancreaticus. And then this is a case, bleed, duodenal ulcer, can't figure out what it is. We did EUS endoscopic ultrasound and then identified it as a dewlaphy ulcer. Then this is a clip. Again, we did an OTSC clip on the dewlaphy ulcer, massive bleed. Don't underestimate dewlaphies, they can bleed massively. So then diagnostic issues, sometimes you need to puncture the vein. And you need to go through the aorta, as you said, these are the untouchable, beyond the territory. But you can go, as I said, you can go through the aorta and you can go into the portal vein. Why puncture portal vein? Because there is a thrombus. And this thrombus is malignant or benign, or you have to sometimes do an FNAC. So then puncture to intervention. We are puncturing the vessels, but we have to now intervene. What do we intervene? What are the agents? Coil, glue, thrombin, gel foam, and all these agents are there. Coils are microcoils, large coils, smaller coils, and these are the coils. What is the difference between large coils and small coils? Large coils, you need the stiffer part. Smaller coils, they are deployed by 22 gauge needle, 21. Okay. So, gastric bleed. Now, just don't think of a gastric bleed. 3 days back, life and death, patient bleeding. We put in a glue, routinely, standard, endoscopic glue, patient started bleeding, everything lost. Fortunately, I was there, put in a US scope, blind, all blind, but I could see the vessel. And into the vessel, we injected glue. It was a matter of 2 minutes. It was no intervention would have been possible. So, I have a firm belief that when there is massive bleed, don't rely on endoscopy, rely more on EUS, and especially if the patient is becoming hemodynamically unstable. But not only the EUS will identify whether the source is gastric or paragastric, because sometimes the bleed can be from the paragastric location. We will show you, and this is the pathways of varices that I have shown, and these are the pathways of varices into this. This is the stent procedure to place a coil and then prolate. But these are the pathways of paragastric varices, because the patient had an ulcer, as is shown in the picture on the top left side, and this ulcer was created after glue injection. Patient was bleeding massively, and in this case, we were forced to inject glue into the paragastric varices. So don't underestimate the paragastric varices. They can bleed into the stomach, cause bifundal varices. Coming to duodenal varices, this is what I did. Keep on doing bending of the duodenal varices, and these duodenal varices can be bended. And how do you bend them? The principle is duodenal flow is from below upwards, and when the flow is from below upward, you start bending duodenal varices from below upward. These are duodenal varices. What about rectal varices? The analogy is same. The rectal varices, the flow is from above downwards. That is from superior rectal vein dividing into two. Inferior rectal vein dividing, superior rectal vein dividing into two, entering the lateral part of rectum. And once they enter the lateral part of rectum, analogous to esophagus, there is a downflow zone and there is an outflow zone in rectum and lower rectum. And then you have to. Now this is the second picture I have shown earlier. Bleeds in rectum. What do you think? Looks like dulophy ulcer, but you do EUS. It is rectal varices. Masquerading as a dulophy ulcer, you band it and it rebleeds. And why it rebleeds from higher up? Because the flow is from above downward, and you reband it again, the patient is okay. Bend always from above downward. Not. You have to bend blindly sometimes, because when you inflate, the varices become obliterated, and these are the zone of rectal varices, zone of downflow, where to inflate. The area is 7 to 10 centimeter. Rectum is large. Keep on bending, no problem. Don't worry about it. So non-variceal brother. So this is, we had talked variceal, non-variceal, and this is a case where a gastroduodenal artery was bleeding, and we are using microcoils which were retrieved later on once the patient was operated. Then aneurysm, important, common. Sometimes India doesn't have many centers who can offer intervention radiology, and I didn't have one at that time. Today I have, but at that time I kept on injecting aneurysm, and though this is angiographic, but I kept on injecting coil, aneurysm, thrombin, and everything. Whatever I got my hands on, later on devised what is the way to inject this aneurysm and this. Then they injected, when I injected thrombin became smaller, and this is, then it became, because thrombin shrunk, and then there was flow again into the aneurysm, then re-injected, and these are the aneurysms which I different type injected, treated with thrombin, and I thought the job is done. Thrombin makes a nice thrombus, obliterated, but there is recurrence not of bleeding, but recurrence of the aneurysm, persistence of the aneurysm. So though there have been some aneurysms which have spontaneously obliterated over a period of time during my observation by EUS, but when it is an aneurysm, it is aneurysm largely requires work immaterial of the size, and aneurysm can rupture into lumen, pancreatic duct, bile duct, and into the peritoneum, and that is why we have been able to do this aneurysm coil, all the things. The question is, what do you use? What are the principles? Though no logic principle have been made so far as obliteration of aneurysm is concerned, but I can point out that you can place several aneurysms, several microcoils, but there may be a principle, one to inject coils, how many coils, and because these coils create a problem in CT scan and all that. So the principle is small aneurysm, large aneurysm, giant aneurysm, which are more than 4 centimeter, and you can individualize what is to be done. Unblocking the blocked vessels. This is thrombolysis of portal venous system. What do you do when the portal vein is thrombosed? This can be thrombosed at these 3 places, and we have been able to offer thrombolysis by US guided at these 3 places, but the question is where to inject. Inject it at a splenic vein or supramesenteric vein, preferably supramesenteric vein, because you have to know which part of the vein, and this is a case where portal vein thrombolysis was done by injecting selectively needle into the part of the portal vein by EUS guided injection, keeping the catheter there and then offering continuous catheter thrombolysis of the portal venous system through this. And then the same was maintained for over a period of 2 hours, and streptokinase infusion was done. Though currently I am no longer very fond of this technique because I have to keep a cannula maintained, puncturing through the pancreas, through the portal vein, keep it there, and to me I feel unhappy. But I still say that I keep on injecting streptokinase into the portal venous system and also into the pulmonary artery thrombus, which occasionally I get these thrombuses, and into these thrombuses we give systemic anticoagulation. Is contraindicated sometimes in pulmonary thrombolysis in TRO. So I have explained thrombosis, thrombolysis, how to cause thrombolysis of this, and the last part of the last 30 seconds left is for the EUS guided double one arrow, two birds, and then this arrow, two birds is you trying to puncture. This is not practically I have not done. I wish I will be able to do it soon, and that is creating an anastomosis by puncturing from EUS guided through the IVC, then into the portal vein, and then I'm maintaining that portal vein access. So then passing the guide wire, and then opening up the stent through the IVC and portal vein into the access, and then keeping this stent within the creating dips. Should be easy, should not be. Thank you very much. And
Thank you, sir, for a very excellent talk. Unfortunately, for the lack of time, we can't take questions, but you have shown us what we were never heard of. Those things can be tried with you, especially in various life-threatening situations. Thank you so much, sir. So we can end this session. Thank you all the moderators and chairpersons.
Thank you all the chairpersons, moderators, and respective speakers for the interesting session. So we have approached now towards the end of our session. So the last session of the day in our conference, it is New Frontiers in Hepatology. For this, as moderators, I would like to invite on the stage Dr. Niranjan Subedi, Beer Hospital, Kathmandu, Dr. Ravi Prakash Sharma, Kathmandu, Dr. Yuvraj Sharma, Patan Hospital, Kathmandu, Dr. Anira Vaidya, Beer Hospital, Kathmandu, and Dr. Raj Kotwal, Shunyata, Gangtok. And to chair the session, I would like to invite on the stage Dr. Jagdeep Singh, Dr. Jagdeep's Gastroenterology and Liver Disease Clinic, Amritsar, Dr. Shubhashish Majumdar, Max Healthcare, New Delhi, and Dr. Saurabh Argal, Kokilaben Dhirubhai Ambani Hospital, Indore.
Hello. Good afternoon, everyone. Welcome to the last session of the conference. I hope we are having good time. So for the this session, Evolving Drug for a Team Hepatitis, I would like to call on Professor Dr. Sunil Taneja, sir. He is from my alma mater, PGI Chandigarh, an excellent speaker and academician. Thank you.
Thank you very much, and my sincere thanks to Professor Arora for giving me this opportunity. So over the next 10 minutes, I'll quickly take you through the advances in the management of autoimmune hepatitis. And in IBD, a lot of biologics have been used now, and I feel that over a period of time in AIH also, we'll have some biologics coming up. So quickly, just an overview in the next 10 minutes. And we know autoimmune disease is a T-cell mediated disease, and it's a heterogeneous disease, can present at any age group as early as first, second decade, and then as late as 7th to 8th decade. And this disease is characterized by hypergammaglobulinemia, autoantibodies, certain HLA antigens, typical histology on biopsy, and one of the criteria is also appropriate response to immunosuppression. Now, this is the first-line treatment of autoimmune hepatitis, and this treatment has been endorsed by most of the guidelines, including the EASL, APASL, and the ASLD, and I'm showing you the ASLD guidelines. Now, if you have chronic hepatitis, the treatment of choice is steroids with azathioprine. This is the first-line drugs. In patients with cirrhosis, you tend to use steroids, and in compensated cirrhosis, you can still use azathioprine, but you have to be cautious. But azathioprine should not be used in patients with decomp cirrhosis. And in acute severe AIH, you tend to give high-dose steroids or IV steroids. And once they are in remission, then you can add the other immunosuppressive drugs. So frontline, you don't give them budesonide or azathioprine in acute severe AIH also. Now, moving on, what are the endpoints of treatment in autoimmune hepatitis? So once you've made the diagnosis, you tend to assess them at 4 weeks. If there is less than 50% reduction in the AST, ALT, you call that as non-response. Complete biological response is defined as improvement in transaminases as well as IgG levels at 6 months. It should come down to normal. And if it is not up to that mark, then you call them as incomplete response. And histological response is usually seen at 2 to 3 years. You need to do a biopsy again and show remission. Now, with the first-line drugs and the available treatment, the remission is seen in around 65%. Incomplete response in around 15%, treatment failure around 10%, and again, drug toxicity in around 15% of patients. And so there is a big chunk of patients will not respond to this first-line drugs. Now, this has been divided into 2 groups now. One is the treatment intolerant, where you have side effects to the first-line drugs, and the second is insufficient response or non-response, as I defined earlier. Now, what are the second and the third-line drugs which can be tried? You have calcineurin inhibitors, in which tacrolimus and cyclosporin has been used. You have mycophenolate mofetil, you have mTOR inhibitors, 6-mercaptopurine, and some little data on methotrexate and thiaguanine. Of these 2 most impressive drugs which have been used are tacrolimus and mycophenolate mofetil, and I will show you the data on this. Now, this is a big study by Kumali et al., and they included 2,200 AIH patients, out of which second-line drugs were given in 302 patients, MMF in 121, and tacrolimus in 80 patients. And what was the reason for switching therapy? ASA intolerance in 38%, and steroid side effects in 14.9%, and non-response again seen in around 45% of patients. Now let's look at the response to treatment. So complete response was achieved in around 70% in both the groups, MMF and tacrolimus. The response was obviously better in patients who were intolerant to the first-line drugs as compared to patients who were having inadequate response or no response. So if you have no response, inadequate response, the response to second-line and third-line drugs is poor. So 30 to 40% will respond. So 60% is another chunk where you need other drugs because they're not responding to the second and third-line drugs also. Now, this is again shown in this pictures, the same results. So a recent paper by the Swiss group, again, similar results, 144 patients, 50 patients received MMF, and remission was achieved in around 80% who were intolerant versus 30% in patients who had inadequate on response. So 70% did not respond to the second and the third line drugs here also. Now, a very important study recently published in JH, they've used mycophenolate mofetil as the first line drug. Some encouraging data, but there are a lot of caveats to the study. I'll just quickly go through this paper. 70 patients from Belgium and Netherlands, age group 57 years, predominant female population, and they were randomized to receive prednisolone plus AZA versus prednisolone plus MMF. And primary outcome was percentage of patients with normalization of ALT and IgG after 24 weeks of treatment. Now let's look at the primary outcome, 56 versus 29%. So MMF was much better as compared to the azathioprine group, and the secondary outcomes, side effect profile, much higher with azathioprine, and treatment discontinuation was also higher in patients who were given AZA as compared to the MMF. So let's look at the caveats in this study. Good points, a randomized control trial, and MMF showed better results as compared to AZA plus prednisolone, and they also showed some better side effect profile. But then obviously there are issues, high cost of MMF as compared to azathioprine. You can't use it in the reproductive age group where most of the patients would be. And we know that from the transplant setting that MMF also causes GI intolerance. They've not mentioned about GI intolerance in this study at all. It's a twice daily drug, and whereas azathioprine is used only daily. And if you look at the response to azathioprine as a first-line drugs, in all the other studies, it is up the tune of 80%. And here they have shown it as very low. There's no data on TPMT levels in this study. So they've not monitored the patients according to the TNT levels also. So obviously there are caveats in this study, but then impressive results, MMF might become this first-line drug in the future. So let me just try and summarize. CNIs in the treatment of autoimmune hepatitis, second line and third line drugs. Response varying from 50 to 70%. I'll just quickly skip these slides. What are the other drugs which have been used? Everolimus and not really impressive, very small data, around 40% response rate. Same is for sirolimus, small data is available, response rate around 30 to 40%. So not much data, not really impressive drugs. So let's look at what is evolving now. So we are looking at biologics now. Rituximab, monoclonal antibody against CD20, and this has been used in few studies. I'll show the data on this. You have B-cell activating factor inhibitors, belimumab and inalumab. A lot of clinical trials are going on. Some data, clinical case reports, and shown good results. A little bit data on interleukin-2, proteasome inhibitors, and TLR4 antagonists. All experimental drugs. We need more data on this. So let's look at rituximab. Very impressive data, and could be the first-line drug in the future. This is from the autoimmune hepatitis group. 22 patients, all type 1 AIH, age 40 years, and 100% patients received prednisolone, 82% received AZA, and around 68% received MMF. And these patients were given rituximab. Look at the results. 2 doses of rituximab given. AST-ALT came down drastically, and this was sustained at 2 years. Immunoglobulins also came down significantly. And look at this response here. Flare-free response was 91% at 1 year, 71% at 2 years. So very impressive data just with 2 doses of rituximab. Now, recent data, Liver International just published, multicentric study, 35 patients, 83% females, 30% had cirrhosis, and 12% had variant forms of AIH. Indication for rituximab was refractory AIH in 40%, concomitant autoimmune diseases in 54%, and intolerant to prior treatment in 6%. Look at the results, very impressive. Overall, 89% complete biochemical response, and reduction or discontinuation of immunosuppressant in 97%. And in refractory AIH also, response rate is 86% and 100% reduction in the dose. And they brought down the dose of steroids from 20 to 5 milligram in more than 50% of the patients. And in patients who have concomitant other disorders, rheumatological or hematological, again, impressive results, 90% and 94%. And flare-free rate at first, second, and third year is really impressive, 86%, 73%, and 62%. So looks very impressive, and maybe in the future we might start using this drug more often. The other drugs, a little bit data on belimumab. This is a BAFF inhibitor. 6 patients, they had concomitant PBC also. Pretty good response rate, and appears to be a promising treatment option for patients with AIH in the future also. So let me conclude here. Autoimmune hepatitis is a complex and heterogeneous disease. Our knowledge on the mechanisms of autoimmunity has increased exponentially in recent years. The ultimate goal of developing new treatment for autoimmune liver disease are to minimize tissue injury, improve the quality of life, and increase life expectancy. The response to first and second line drugs is reasonable. Biologics may satisfy the unmet clinical need for treatment of difficult to treat cases. And monoclonal antibodies against CD20, that is rituximab, and monoclonal antibodies against BAFF or BAFF receptors, which inhibit B cell differentiation, appears promising drugs for the future. Thank you very much. I will stop here. Thank you.
Thank you, Dr. Sunil. We'll have questions if time allows at the last of the session. So now I will call upon Dr. Sunil Dadi. You'll be talking, there is debate, very interesting topic, management of large gastric varices, endoscopic management versus IR intervention. So after Sunil, I'll be calling for Dr. Amar Mukunda to get ready for the counter session. Thank you.
Thank you. Thank you, Mr. Chairman. At the outset, I would like to thank Dr. Arora and his team for the kind invitation. And my job is to debate the management of large gastric varices and endoscopic versus IR management. Since it's a debate, I won't be discussing about the classifications and the procedure details. I'll just be talking about literature evidence of endoscopic management. We all know gastric varices are less common compared to the esophageal varices. They are seen only in 20% of patients with portal hypertension. But when they bleed massively. It's a severe bleeding, and they have a very high mortality. And another important thing is they can bleed at a lower portal pressure. Among all varieties of gastric varices, it is the cardiofundal varices, IgV1 and GOV2 are the most common who bleed in the highest level. So the management consists of a primary prophylaxis or the secondary prophylaxis or management of acute bleed. Acute bleed management is standard, ABC, antibiotic, restrictive transfusion, vasoactive drugs, and the hemodynamic stabilization. We can use balloon tamponade sometime. In a old study, compared Lincoln balloon with the Sangstaken tube, although balloon achieved hemostasis in 80%, but a very high risk of rebleed. So it is just a temporary bridge till the person is stable or till the anti-endoscopic option is available. And among all tubes, the Lincoln tube is much better because it has got a very large size of gastric balloon. So the first line treatment is endoscopic therapy. Should be performed within 12 to 24 hours. The options we have is band ligation, glue injection, thrombin, and the EOS guided interventions. Band ligation has been there in the good old time, where people used AVL for GOV1 type of varices and the smaller forms of GOV2 varices. And a study compared the band ligation with glue injection, and there very high rebleeding rate with the band compared to the glue. And this is the free of gastric variceal bleed, much better with the cyanoacrylate compared with the glue. Although the survival, there was no difference. So glue is better than banding, and nobody uses EVL for this indication nowadays. Endoscopic glue injection, since its introduction in 1986 by Nip Sohendra, in 3 cases, successful stopping of bleeding in actively bleeding gastric varices, it has become a standard of care. Since then, there are a lot of studies on this. And all these studies, it shows very high rate of control of bleeding with few side effects of rebleeding and the embolism of the glue. In a very recent systematic review and meta-analysis, 2024 June, the hemostatic rate ranged from 65 to 100%, recurrence is 34%. So you need to do repeated glue injection to prevent the late rebleeding as well as the recurrence of varices. The adverse events, moderate, are very less, only 3%. These are the independent factors responsible for gastric variceal bleeding in glue injection. Thrombin injection, there is a systematic review and meta-analysis, safety and efficacy, 11 studies, 222 patients, rebleeding rate early as well as late, and the rescue therapy rate are reasonably okay. It could be a better alternative of glue. In a study, randomized trial comparing glue versus thrombin, initial hemostasis, treatment failure, 6-week mortality, more or less same in both the groups, but the only difference was in glue group, there was a lot of ulcerations over the gastric variceal. So, and the complication related to those ulcers, and with thrombin, there were no ulcer-related complications. Among the EOS guided techniques, we have the glue injection or coil injection, or a combination of glue plus coil, and an experimental modality, which is EOS guided intrahepatic portosystemic shunts. I'll skip these therapeutic. It was first described by Romero Castro in 2010, 2010, placement of coils for the management of gastric varices. These coils has got synthetic strands which make them stay within the vessel. So initial study, 4 patients, and the eradication was achieved in 3 of them. Later on, similar group compared their vast experience of placement of coil and compared with the endoscopic glue injection, and they have found to be better than glue. A 97% obliteration rate with, the GV obliteration rate was more or less same in both the groups. The hospital stay was less in coil compared to the glue, and the adverse events were much higher, 40% with glue compared to only 9% with coil injection. This is the largest series published by Binmoller group. You combine glue as well as the coil, and it shows a very good efficacy. And both combination of these two is very highly effective, less embolization and the less rebleeding rates. So, what about when you compare the endoscopic glue versus the endoscopic EOS guided therapy compared to the endoscopic glue injection? There are various groups. This is a systematic review and meta-analysis. And for hemostasis, endoscopic glue, EOS guided therapy, hemostasis is comparable. Obliteration is somewhat better with EUS. And among the EUS options, coil plus glue is better. This is again a meta-analysis comparing the monotherapy versus combination therapy EOS guided. Again, it shows the EUS plus glue plus coil is much better than the either therapy alone. So EUS guided coil and glue is the preferred. Can you use other option other than glue? You can use gelatin in place of glue, and it is found to be equally effective when it is compared with the endoscopic glue injection. What is the safety and efficacy? The efficacy is around 100% coil plus glue, and after one session, the efficacy is around 80%, and very little pulmonary embolism reports. Again, this is a propensity-based international multicenter trial. Again, so similar EUS guided coil and glue is safe and better efficacy. Another important advantage with EUS guided procedures is you can target the perforating vessels as is done by the IR people. So, and this has also been found to be effective in primary prophylaxis of the gastric varices. So what is I'll skip this because this is only a experimental modality till now. Limitations of EUS, it is not effective in Arakawa type 2 gastric varices. That means when there are a diffuse form of gastric varices, there are multiple draining vessels, multiple large veins in the gastric wall, then you can't inject all of them. And then with EUS, you have a limited knowledge of vascular anatomy. You need to have a cross-sectional imaging to do that, or a angiographic method to do that. And the tools and techniques available for EUS are not specifically designed for vascular intervention. We just extrapolate those things from the IR people. So what is the flip side of the coin? What does IR people do? They decompress by placing a shunt. Utility of shunt in gastric varices is limited because we all know gastric varices can bleed at a lower pressure. Tips will only reduce the portal pressure, and that too on the right side of the portal system. So it may not stop the bleeding. There is a study comparing tips versus endoscopic glue injection, and varicose obliteration was better with endoscopic glue. The rebleeding was more with the glue injection. The other option they do is embolize by either doing a Bato, Parto, or Kato. And they need to have a shunt to perform all these procedures. When they perform balloon-directed Bato therapy, the balloon remains distended for hours together after the procedure to prevent the slippage of the sclerosant into the systemic circulation. And again, when you block these portocable shunt, there is increased portal pressure toward the liver, and it can lead to the portal hypertension-related complications. There are process-related complications, including the embolism. And with Parto, if you block the shunt with a plug, then you can't re-intervene if it is needed. There is a study comparing the glue versus BRTO. And again, the free of gastric varices, BRTO is relatively better, but the survival, there was no difference. When you compare a study, BRTO versus TIPS, so BRTO is much better compared to the TIPS as far as the control of gastric varices are concerned. This is the network meta-analysis. Since there are no head-to-head comparative trial between EUS-guided therapies as well as the IR-guided therapies, so this is the network meta-analysis where they used the various techniques, various literature available on these. And this is the Sukra plot, shows the right uppermost corner is BRTO and immediately followed by the EUS glue plus coil. So BRTO and EUS glue plus coil are almost comparable in this network meta-analysis. So highest varicose obliteration with EUS glue plus coil and lowest rebleeding risk and less side effects. This is again a recommendation by the Indian College of Radiology, evidence-based guidelines. Author is sitting here. And the first statement they say is the pharmacotherapy and endoscopic therapy should be the first line therapy. So ladies and gentlemen, in the management of large gastric varices, endoscopic therapy is preferred in a person who has got actively bleeding gastric varices. In a person, when you do EUS guided, you are obliterating these varices in real time. When there is a thrombosis of portal vein and splenic vein, you can't perform the IR-related interventions. If there are no shunting, then you can't do IR interventions. But IR interventions can be preferred in the presence of shunt, recurrent bleeding, real-time local flow, because they do angiography and they have all the knowledge of the efferents and afferent vessels. If the person has associated shunt-related encephalopathy, again, this is preferred over the endoscopic therapy. And again, the type 2 Arakawa, this is better. So at the end, I think we are good old friends. We are complementary to each other rather than competitive. Thank you very much.
Yeah. Now call upon Dr. Amar. Is here.
Good afternoon, all. At the outset, I would like to thank Arora sir and Gangaram team for having me here. So I think Dr. Sunil has made the job easier for me, and so I'll quickly come to my particular expertise, so role of TIPS. So as he already said, that gastric varices bleed at a lower portal pressure. So yes, we all know it bleeds at a lower portal pressure, but TIPS should be done along with embolization of varices for long-term and better control of bleed. So this is what is coming up. You go inside, you create a shunt, so you reduce pressure. So it may be less, but definitely it is higher. There would be a gradient. So there is no second thought. You make a shunt, you reduce the pressure, simultaneously go into the varices, which is being fed by the portal system. You obliterate them. Yes, the job is done. And there are RCTs, and one RCT was shown by Dr. Sunil, another is here. So TIPS versus glue for gastric varices. So TIPS was more effective. So if we talk head to head, as per the RCT, as per the data, yes, TIPS scores better. Without embolization of varices, this was the era when embolization of varices was not there. Today we are doing embolization of varices. Like we heard, US is advancing, similarly is IR, and we have our own tools like for helping the patients as well as gastroenterologists and hepatologists sitting here. So I'll just quickly show you an overview. So how gastric varices are on CT scan. So if you see, there are multiple pockets, one here, second here, third here, so multiple. And this is one of the section. If you see in the coronal reformatted view, there are many more. So if you go by endoscopy or by EUS, you puncture one by one, or sometimes maybe you can go into the perforator. But in such a jumbled scenario, getting into perforator is not easy. And see how easy it is. So yes, BR2 used to take a lot of time, and we have gone to PARTO. If you see here, this is a disc which is a plug. So we place a plug, and just on top of it, there is a catheter through which we inject the sclerosing agent, which completely obliterates the shunt in a single go. So it's totally obliterated. And this is how it looks. You remove the catheter, in 15 minutes you are done. And this is how it looks after a year. See, after a year, here is the plug. Apart from plug, you don't see anything which we saw. So one intervention, everything clear. Absolutely clean stomach. So this is what can be achieved. And this is one of our study where we did a salvage BRTU. So it was not a primary BRTU, not a secondary BRTU, no prevention, nothing. It was a salvage BRTU where the patient kept on bleeding despite endoscopy therapy, and we treated 52 such patients, and there were no rebleed from gastric varices after BRTU, and overall survival rate was 92% at 1 year. And apart from it, there are other advantages. We are not only talking about rebleed. What we saw, the CTP score improved. This is 1 year follow-up. MELD score, again, improvement in the MELD score. Albumin went up. And if you see serum bilirubin, it dipped, and there was some elevation, but still better than when we started treating. So yes, it has definite advantages. So as already said, BRTU is preferred over TIPS. Will be not talking about it. And this was the study. Again, it has been shown in hepatology, not in my journal. Done by whom? All hepatologists. BRTU 27% versus 3.7% of rebleed at 1 year, and 7.4% rebleed at 2 years versus 34%. So again, coming from hepatology perspective, one of the most reputed journals. Now, this is the most latest from India. So we cannot actually, undermine from study from AIMS, July 2024, a hot cake. So this is what it happened, RCT, GV rebleed rate, if we see 24% versus 2%. And it is IR therapy, which included both BRTU and TIPS. And if you talk about mortality, so here we can see 17.8% versus 1%. So again, there is a definite advantage even in rebleed. And this is a, RCT setting, that is what we are talking. Now coming to EUS guided therapies, again coming to systematic review and meta-analysis, endoscopic ultrasound. consisting of 604 patients, and obliteration rate was 83% and rebleeding rate was 18%. So if you go by, we just compare like what is the rebleed rate. So yes, rebleed rate is 18 to 20% by EUS coiling as well, which is again BRTO and TIPS may be a better alternative. Now, this is again guideline from our Indian perspective, where we have shown, and these are the statements, that BRTO and TIPS are safe and effective in management of GV bleeding. So yes, we all agree. As concluded in the last slide by Dr. Sunil, yes, we act as a friend and we are there. But there are certain other advantages of obliterating. Just show you a very interesting picture. If you see here, these are the large gastric varices, which has been shown. In fact, Dr. Malay Sharma also showed some big varices and certain pictures. But along with it, what we see, these varices are at the cost of the portal vein. This portal vein is not getting blood. It is getting atrophied, and all the blood is going into the varices, and this is how it is. So mesenteric blood as well as the splenic blood getting into these varices, coming out like this. So liver is getting devoid. Liver is not getting all the nutrients what it should get from the mesenteric circulation, or the growth media not getting. So what we do, we obliterate, and this is how. So first thing we achieve is obliteration. Second thing what you see is, sorry. If you see the portal vein before, this was the portal vein before, this is the portal vein after. So you obliterated the varices and you led the hepatopetal flow to restore itself. So liver getting a better perfusion. You see the perfusion over here, you see the perfusion over here. And with this idea, we also did a RCT at our place. So what is the influence of shunt occlusion in patient who had shunt and hyperammonemia? So we randomized these patients and we compared. So there were two things what we saw. So there was a standard medical therapy who were only on different kind of medical management, and one was shunt occlusion group. So we saw that the volume in standard medical therapy reduced. So this was the interesting thing. So what happens if there is a shunt? Definitely the liver is going to shrink. It will get small. Whereas here the volume increased. So BRTO is leading to increase in volume. Whereas if you continue with the shunt, it will lead to decrease. And what are the other advantages? So liver volume increases, albumin increases, ammonia decreases, and MELD sodium improves. So this is what we got from our RCT. And again, this has already been shown. This paper has been quoted before. And definitely BRTO had the highest rate of variceal obliteration, followed by endoscopic ultrasound, coil, and glue. So yes, this is what we have. Yeah, in coming days, things will change, but it will change for the good of the patient. Maybe EUS is evolving, similarly is IR. So we don't know where do we stand after 5 years. We may be debating every day, but probably we work more as a friend, and we continue to work as a team for the betterment of the patient. So with this, I conclude that retrograde variceal obliteration, consisting of various jargons like BRTO, PATO, CATO, tips with antegrade embolization, these are the robust tool in the management of gastric varices. That's pretty clear. And IR therapies have definitely a better obliteration rate and least rebleeding rate. That also is clear. But yes, many times, because endoscopist is the first to intervene, maybe the first therapy would be the endoscopic therapy, but wherever there is any failure, we should not hesitate to send the patients to IR. Thank you so much.
Thank you so much, Dr. Omar. So, Dr. Sunil will have a short comment, if anything, in counter.
I think I appreciate his lecture. The only thing is, my friend proudly presented the study published in hepatology and the study published by the AIMS group. In that study, the BRTO was compared with the endoscopic glue therapy. So you can't compare a Vande Bharat train with a steam engine train. So endoscopic glue therapy was invented in 80s and BRTO much later. So if you have a BRTO compared with EUS guided therapy, then things would have been different.
So even with EUS guided therapy, the rate of rebleed is 20%. And given a choice, suppose you are given a choice to travel on Vande Bharat and simultaneously on a steam engine, which any person would like to travel. So that's my, argument over here. Probably everybody will say ki if jet is available, I'll prefer to go by jet. So similarly, we should go by the time. Whatever is better should be offered to the better as per the evidences. Thank you so much.
Thank you so much. So next speaker.
Next speaker is Dr. Shivam Khare, and he is speaking on EOS guided liver biopsy and portal pressure measurement. Dr. Shivam Khare is assistant professor and associate consultant in Sir Gangaram Hospital, New Delhi.
I think गलत लगा दिया उसने ये नहीं है slides have to be changed. Good afternoon, everyone. First of all, I would like to say thanks, Dr. Anula sir, for giving me this opportunity. So my topic is US guided liver biopsy and portal pressure gradient measurement. So we all know US is becoming one-stop shop in field of endohepatology, and we can do multiple procedure by US in hepatology. I will discuss about US liver biopsy and portal pressure gradient measurement. So we'll discuss one by one. First is US liver biopsy. So we'll discuss this topic in following heading. What are the different routes? Then why we can prefer US biopsy, liver biopsy, various US liver biopsy strategies and technique. So we all know there are 3 routes of liver biopsy. We all know the indication and positive points related to percutaneous and transjugular, but we should know some negative points also, like for percutaneous, patient discomfort is there. First, pain could be there because we have to pierce skin. Then we can access only right lobe, and patient has to remain in right lateral position for 4 hours. Similarly, in transjugular liver biopsy, there is need of radiation. Then patient discomfort again is a problem because we have to give incision in neck, and fragmentation is quite common with transjugular liver biopsy. So why we can prefer US liver biopsy? First is clinical efficacy. Now, availability of various studies, we can say the efficacy is comparable with percutaneous liver biopsy, and we can take bilobar targeted biopsies and also in presence of mild to moderate ascites, and we can also do concurrent upper GI and US evaluation for varices, pancreatobiliary screening, and FNA from the other side. Second is safety. So we can apply the Doppler and choose basal-free approach. So bleeding-related complication could be less with US liver biopsy. And third is better patient experience, because we did all procedure under sedation, so comfort is there, and usually no pain during the liver biopsy. So next is US liver biopsy strategy. We'll discuss one by one. First is aspiration versus biopsy and needle gauge. So according to various studies, biopsy needle is better than aspiration, and we should use 19G needle rather than 22G needle to get adequate sample. Regarding the type of needles, among the all type of needle, francine tip will give better tissue yield in US liver biopsy. Regarding the technique, so these 2 studies published in GI endoscopy, and they compared various technique of US liver biopsy, and they showed the weight heparin suction technique is optimum technique to get adequate tissue. Then next is pass and actuation. So one pass 3 actuation will give better tissue compared to one pass 1 actuation. Then regarding the one lobe or both lobe biopsy, so this paper showed unilobar liver biopsy may underestimate the fibrosis in 21% patient in NAS. So if you are suspecting NAS, then we can perform a bilobar liver biopsy. And the tissue yield is equal for both lobe, right and left. But performing liver biopsy, left lobe is always easier. So next is how to do liver biopsy. So in this video, you can see. First, we have to remove the stylate, then we flush the needle with heparin mixed saline until the few droplet came out from the other end of the needle. After that, suction syringe is prepared by 2 ml of the saline with 20 ml of the vacuum. And this suction syringe is attached to the FNA needle. And procedure is done in left lateral position. Then After applying the Doppler, we can choose vessel-free approach, and we can also measure the trajectory path. And after that, puncture the capsule and take 3 actuation by only doing 1 pass. And we should not in hurry to remove the needle. And we should wait if any flow in track. In almost all cases, this flow will disappear in few seconds. And after that, we can remove the needle from the liver capsule safely. And after that, sample is pushed over the cell block cassette, and this sample is flushed with heparin mixed saline to remove the clot, and this core sample shifted to formalin container and sent for the histopathological examination. So recently we published a paper, our experience on US liver biopsy, and the yield was around 90% with good number of complete portal tract and total specimen length. If we compare US liver biopsy versus percutaneous, so first study showed the percutaneous is better, but in this group, they did not use optimal suction technique. And second study, US is better, then third, US and percutaneous both are equal. So we can say US is comparable with percutaneous liver biopsy. Then regarding the complication, pain is more common in US liver biopsy group, and the bleeding is more common in almost equal in both groups, but cost is higher in USLB group. So who is the better candidate for US liver biopsy? If anybody need concurrent upper GI and US examination, if anyone need sedation and comfort, need of bilobar biopsies in case of mild to moderate ascites, and portal pressure measurement simultaneously. So next is US guided portal pressure gradient measurement. So first question comes in my mind, do we really need US guided PPG measurement? Because we have HBPG, and HBPG is a very good marker for the portal hypertension, but HBPG has few limitations. Like pre and post sinusoidal portal hypertension may give false normal pressure, and radiation exposure is required during the HBPG measurement. One more thing, according to these two studies, HBPG may underestimate the portal pressure in NAS patient. And another thing is, if you are doing US for other purpose, at the same time you can do portal pressure gradient measurement. Next question is USLV is safe? So answer is US portal pressure gradient is safe technique with good technical success without any adverse event according these multiple studies. Then technique of US portal pressure gradient measurement. First is using the digital computed manometer, in which the 25 gauge needle is attached with this computed manometer, and we can measure the portal pressure gradient. And now there is sufficient data available to see the efficacy of this computed manometer, but very limited availability in India. And this study presented in DDW 2022, they showed, this is the multi-center study, and they showed the good correlation between the US PPG and clinical and non-invasive marker of portal hypertension along with liver biopsy. Second technique is by using the conventional multi-parametric manometer, which is available in all hospitals, and the portal pressure gradient measurement is just like similar to HBPG. Easy availability of this conventional multi-parametric manometer, and we can use 22G and 25 gauge needle both, but very limited data available. This is a single center study which showed the good correlation between the portal pressure gradient measurement along with non-invasive and clinical marker of the portal hypertension. So in this video, sorry, this is, yeah. So in this video, we can see how to measure the portal pressure. First, we have to puncture the hepatic vein and with 25G needle and maintain the saline column without any air bubble. Then needle is flushed with heparin saline and set 0 and take 3 reading. And all these steps also follow in after puncturing the portal vein, and the portal pressure gradient is a difference between the portal vein pressure and the hepatic vein pressure. So finally, conclusion, US liver biopsy is non-inferior or equivalent to percutaneous liver biopsy. Optimal technique is weight heparin with 19G FNB Francine tip needle with 1 pass 3 actuation. US LB to be considered over PCLB. If anybody need concurrent upper GI and US evaluation, bilobar liver biopsy if required, we can do simultaneous portal pressure gradient measurement or in NCS patients. In these two groups, This could be cost effective also. Regarding the US guided portal pressure measurement, it might be helpful in NAS and pre-sinusoidal portal hypertension, but we need more data to establish as an alternative technique to SBPG. And this is my last slide. Percutaneous liver biopsy and HBPG are well-established technique, so we cannot replace them by US liver biopsy and US PPG. But we can use these new technique in certain group of the patient and could be useful techniques in the near future. Thank you.
Thanks, Dr. Sivam, for a nice presentation. Next presenter.
I want to call Dr. Madhumita Prem Kumar. She is the Associate Professor of Department of Hepatology, Postgraduate Institute of Medical Education and Research, Chandigarh.
So thank you to Professor Arora and the entire Gangaram team for bringing me. I'll have to bring up the rear. So the topic that's been given to me is non-cirrhotic portal fibrosis. Is it a vanishing entity, or is it losing its sheen under the M.I.C.E jargon? So I had to think about why this topic was given, because this is not intuitive and it is not standard. So the questions that we really need to look at: what is the spectrum of M.I.C.E and this new definition? So does it cover what we would know or call erstwhile NCPH? What is the spectrum of PSVD NCPH? And whether we have individuals which could have both or one. So there's one condition where we all think that there could be an overlap, is the lot which was originally called cryptogenic cirrhosis, but could originally have been M.I.C.E due to a older high BMI. So how do we distinguish between the two? So the M.I.C.E algorithm is changing, and worldwide we're having increasing risk of globesity or obesity. So what we used to be calling steatotic liver disease is now M.I.C.E, and then if there's inflammation, it's MASH, and then of course that would progress to cirrhosis. And what you will note is the steatosis is gradually decreasing, and the amount of inflammation is increasing, and later on the steatosis entirely disappears. So at this point, they could well be cryptogenic if we didn't have any metabolic risk factors. And at this point, we could also confuse them with non-cirrhotic portal fibrosis, where the parenchyma is lost or is extinguished, so parenchymal extinction. So the SLD spectrum has now been redefined based on whether there is associated metabolic risk or alcohol intake. So patients who are consuming very limited amount of alcohol will be M.I.C.E predominant. Those who are taking alcohol with metabolic risk will be MET-ALD, whereas the ones who are having no metabolic risk factors would be taken in the other groups of steatotic liver disease as alcohol pure ALD variety or cryptogenic SLD, which is what we will be discussing. So what are the cardiometabolic criteria for M.I.C.E? I think we need to just have one. So everybody in the audience is likely to have at least one. So any BMI which is more than 23 in Asia, high fasting blood glucose or HbA1c, higher blood pressure, which is just 130/85. So the diabetic cutoffs have been used, not 140/90. Anyone with dyslipidemia or requiring lipid-lowering therapy, and anyone with low HDL. So again, low HDL could also be in patients who are having chronic liver disease. So again, cardiometabolic risk needs to be seen in context. So if our patient has cardiometabolic risk, they would come under the M.I.C.E jargon, I believe. And if there's no other cause of steatosis, they would come under the cryptogenic SLD jargon, as we will discuss. So M.I.C.E has changed its name. Why should vascular liver diseases be left behind? So the NCPH or non-cirrhotic portal hypertension, the idiopathic subgroup or INCPH, and non-cirrhotic portal fibrosis. So all the synonyms that we use for NCPH will now come under a much broader umbrella term called portosinusoidal vascular disease. And with its subcategories with portal hypertension and without portal hypertension. And here is where the waters are muddied. We can have patients without portal hypertension who have some amount of steatosis and they are non-cirrhotic. So would they come under the M.I.C.E jargon? Let's see. Let's see if they do come. So if we look at the causes of NCPH, if it is a sinusoidal type, then we can also have alcohol-related hepatosclerosis. We can have microvesicular steatosis, which could be due to alcohol or any other cause like AFLP. And there's a post-sinusoidal cause also where alcohol can cause phlebosclerosis of hepatic veins, so small vessel outflow tract. So all of them would come under what we used to call NCPH earlier. And we also have the pre-sinusoidal diseases, but they are not going to be coming under the MASLD jargon. So the name change has told us that we require a biopsy, we require some sign of portal hypertension, a histological. So PSVD is now going to be a histological diagnosis. It is mandatory to have a good sized liver biopsy and have either imaging or clinical evidence of collaterals or portal hypertension or specific histological lesions, which are obliterative portal venopathy, incomplete septal fibrosis, and nodular regenerative hyperplasia. These are the three which would make up the triad. There are also minor histological lesions that would qualify as PSVD. So the name change has occurred and we need to get comfortable with it. So coming to the central point. So what we have understood the two bits of jargon. Is NCPF actually vanishing? Well, yes and no. We still see these three histological features when we are looking at biopsies, but it is underreported. Explant livers in patients who are undergoing liver transplantation even today, they still have evidence of non-cirrhotic portal hypertension. A good number are actually NRH. We have had patients who have been transplanted for NRH because they appear to have dysplastic nodules. And now with the increase in use of multiple drugs, especially ART, we are having more of vascular disorder related or patients who are on drugs like azathioprine, didanosine, all of these drugs which result in non-cirrhotic portal hypertension. So the disease remains the same, the histology remains the same, but maybe the causes are changing. So we have more of drug-related or thrombophilia-related portosinusoidal vascular disease. So what we had originally as a young adult presenting with a massively enlarged spleen, a very dilated hepatoportal sclerosis, a very dilated portal vein, maybe that is now changing into a PSVD varieties, but the disease still exists, albeit under a different name. So let's look at this biopsy. There's some amount of steatosis in the biopsy. You'll see that the sinusoids are really dilated and congested. So this is also non-cirrhotic portal hypertension, but this is HVOTO. Does this qualify as PSVD just because there's steatosis in the side? Let's look at the fine print. So PSVD is going to exclude all HVOTO or SOS or VOD, which earlier we would be happy to include in the NCPH umbrella. So this is one category of portal hypertension that is excluded from the PSVD jargon. So then let's look at this biopsy. There's an enormous amount of steatosis, as you can see. There's not enough fibrosis. There's Mallory hyaline. But oh, what's this? This is an obliterated small portal vein. So this is phlebosclerosis in a patient with MASLD. So both are coexisting. So we can have patients who can fit the metabolic criteria for MASLD and come under this very broad umbrella term of PSVD. Maybe it is too broad, but the debate is going on. So coming to the approach to, our current approach to portosinusoidal vascular disease, if we have a patient who's having any of the three features of obliterated portal venopathy, regenerative hyperplasia, or early fibrosis, if there are no signs of portal hypertension, then we have these criteria, then it would be PSVD without portal hypertension. If there are signs of portal hypertension, and we do elastography and we find a high splenic stiffness, with a low liver stiffness, then this is likely to be PSVD with PH. And of course, if we have any amount of fibrosis or LSM is high, then these patients would meet the criteria for cirrhosis and not NCPH. So can they coexist? Very much so. But we don't have too many of the idiopathic groups. So what was idiopathic PSVD is now pretty much disappearing. And INCPH or NCPH is probably now a subset in a very broad category of diseases, which was known as PSVD. So a lot of debate. So the second scenario when we can have an overlap or some confusion or where these patients with NCPH are disappearing would be this category of patients, cryptogenic cirrhosis, where we are having end-stage cirrhosis. So if we consider two patients, a pregnant lady who's having PCOS and incidental splenomegaly, she's lean, and you actually find varices with low liver stiffness, this would meet the criteria for NCPH PSVD. We can have an executive who's obese and has cardiometabolic risk criteria, again has steatosis. So this would meet the criteria for MET ALD. On the other hand, we have a lean patient who, if you take a history, was overweight 20 or 30 years ago, and now has come for evaluation, pre-surgical evaluation, and we are finding that there's a very large liver, very large spleen, there is high fibrosis, comes under cryptogenic cirrhosis. So this patient should not be confused with the other two, but could well have had MASLD cirrhosis. So cryptogenic cirrhosis is one where we need to look at cardiometabolic risk. And again, this is another patient where we are having an NCPH kind of appearance, classically dilated portal vein, a lot of collaterals, a massive spleen, but you're having some amount of steatosis on the liver biopsy, but if you look, the LSM is pretty low. So this is a case where MASLD and PSVD are probably coexisting. Confused enough that there is an overlap. So let's look at data from India. So explanted livers, this is data which has come from a Turkish group. So they found that about MASLD, which was for cryptogenic cirrhosis, patients who were transplanted. So about 12% met criteria for NAFLD. Autoimmune was there in just 2 patients, and it was idiopathic in about 60% of the cases. I'll just take a minute more. And then in the group, a large series from India and 30 cryptogenic cirrhosis, more than 70%, more than 65% were actually found to be MASLD. So maybe the pre-test probability and the high prevalence of MASLD in our geographic region would suggest that these patients would more likely have MASLD than PSVD as an etiological factor for cryptogenic cirrhosis. So NCPF is still prevalent in patients in our explanted livers. This is data from Medanta. And lastly, we need to conclude that although NCPH per se is not disappearing, with the change in nomenclature will not change the disease. We are going to meet the same patients, but maybe the causes have changed. Maybe we'll be able to identify more vascular causes or drug-related causes which are predisposing and would now meet criteria for PSVD or HVO2. So INCPH may be disappearing because not much is idiopathic in 2024. Thank you very much for your time.
Thank you, Dr. Madhumita.
Thank you, Dr. Madhumita, and thank you, chairperson and moderators. I think now this is the last session, and we wish to conclude this our academic feast. Just at the end, on the behalf of the organizing committee, I would like to extend my thanks to all the speakers for their valuable time, therefore crisp and very informative talks. All the moderators and chairperson for their interaction during the session. I would also like to thank all the pharma people because we need their support for organizing such a conference. Thank you to the organizing committee, my other members, the organizing event manager, Pranav, Shipra, Shilpa, and our few more members, which I would like to say because they help us a lot. We need your feedback. We need your feedback in terms of the academic program. We need your feedback how we can improve ourselves more in the next time. Maybe the time, situation, some other positive feedback as well as the negative feedbacks. So by saying so, I think we conclude this academic feast, and we will wish to meet you again next year the same month. Thank you.